All right, good morning, everyone. Thank you all for coming here on a Monday morning, and official welcome to the 2024 CAPT-ACTP Annual Conference. My name is Julia Shen, and I'll be the MC for today and tomorrow. And I also have the pleasure of being the CAP president until the end of the conference day tomorrow, where I'll hand it off to our new president. This year, our focus is patient-centered care in evolving healthcare systems, and over the next 2 days, we'll have a lot of discussions, conversations, as well as brainstorming regarding how we can bridge the gap to access and, eventually get medication, treatment, healthcare to the patient. Okay. Can I get the next? Okay, so I'm going to start off with a land acknowledgement. CAPT would like to take this time to acknowledge that the land on which we gather during our annual conference is located on the traditional territories of the Mississauga, Haudenosaunee, and Anishinaabe nations. We give honor and thanks to the traditional inhabitants of this land in Toronto. To say this is to acknowledge a debt to those who are here before us and to recognize our responsibilities as guests to respect and honor the intimate relationship Indigenous peoples have to Turtle Island. Extending harmony and sharing resources is at the pillar of how our First Peoples interact amongst one another. They sought to walk gently on this land, carrying the value system of living harmoniously with both nature and man, utilizing the land for what was needed without overconsumption of resources, honoring our differences by offering their assistance to European settlers and extending their knowledge to survival in times of harsh climate and difficulty our newcomers had with navigating food and healthcare remedies along the journey. Thus, we seek a new relationship with the original peoples of this land by committing to building decolonial research and connecting health professionals that can positively contribute to the evolution of equitable healthcare in Canada. Our values are based in having honor and a deep respect for what was done before us. At CAPT, we're compelled to engage in initiatives that move towards harmony, reconciliation, self-determination, and decolonization in our existing structures. So may we continue to lead with love and be guided by togetherness as we transform our personal and institutional relationships with our Indigenous friends and neighbors. All right, so on the screen, we have the agenda for today. So we will be starting off with a keynote from Dr. Reshma Amin, and she'll be talking about, the burden of rare disease and bridging the gap. So we're lucky to have her join us today. The rest of the day is going to be filled with 5 different panels. We're going to be exploring a lot of conversations when it comes to institutional readiness, when it comes to Canadian healthcare readiness, system readiness. We'll also be having a lot of conversations regarding policy, especially pertinent policy conversations that are happening now. And we'll also be seeing some case studies regarding very innovative approaches to eventually getting access when there's some challenges with data. I'll also note for the panels, we will have a question and answer period at the very end for the audience. So for anyone who has a question, you'll see there's some mics around the room. We're not going to be singing karaoke, but if you have any questions, feel free to line up when the Q&A is open. We will also have a student oral presentation session at the very end today, so we really want to celebrate all of the great research and initiatives that students and academia have done. And at the end of the day, we will have a reception concurrent with a poster exhibition. So please stay with us until the end of the day, and we welcome you to that piece. Okay, so throughout both today and tomorrow, we will also be having a career fair. So there will be booths at the front or where you registered. So for anyone who's interested in having conversations with those individuals at the booths, we welcome you to. And related to the poster exhibition, when it happens, you just have to go right up the escalator and just keep going forward. You'll see all of the poster boards there. You won't miss it. I will say new for this year, we are going to have an audience vote for best poster. So, please do visit if you're going to be around. And if there's any interesting posters, you have any engaging, meaningful conversations, please do vote for that poster and give them the recognition that they deserve. And if you missed anything I said, that's totally fine. All you have to do is really connect to our QR code. You'll be connected to a link tree. That's where all the important information is. You'll have our agenda, our abstract booklet, as well as that poster voting form. All right, and so without further ado, I will be introducing our keynote for the day. Dr. Reshma Amin is the Director of Long-Term Ventilation and Sleep Medicine at the Hospital for Sick Children. She's a Senior Associate Scientist in Child Health Evaluative Scientist at the Sick Kids Research Institute. She's a Professor of Pediatrics at the University of Toronto, is also cross-appointed to the Department of Health Policy, Management, and Evaluation at the University of Toronto. She's also an adjunct scientist at ICES. Dr. Amin's research focuses on improving outcomes for children using long-term ventilation at home and their families. Her team is developing and evaluating interventions aimed at supporting patients and families transitioning home with new medical technologies to decrease caregiver burden, reduce preventable healthcare utilization and associated costs, and promote patient safety. An emerging research aim is the development of real-world evidence to characterize the holistic disease burden of individuals living with neuromuscular disease in Canada and the impact of disease-modifying therapies. Dr. Reshma, I'll invite you. There you
go. Hi, good morning, everybody. It's a great pleasure to be here. And I'd like to thank CAPT for the opportunity to present this morning. So our learning objectives for the next 30 minutes or so are that we're going to talk about the challenges in conducting rare disease research in Canada. We'll discuss what real-world data is and how to generate real-world evidence and sort of the unique opportunities to evaluate the impact of rare diseases using these on the healthcare system. And I'll close by sharing a research program example and some lessons that have been learned along the way. And so on the slide here, you can see this is a photo of a patient I look after with spinal muscular atrophy type 1. The patient on the left is ventilated invasively using a tracheostomy 24 hours a day. The video that you're seeing right now on the right is the patient with the exact same disease who was diagnosed by newborn screening, received gene replacement therapy, and now that child is able to walk and talk. And the reason we're all in this room today is really because we want to ensure that all individuals with rare diseases have access in a data-driven way to ensure timely and equitable access to disease-modifying therapies. So rare disease in Canada. There's 7,000 rare genetic diseases in Canada that impact more than 1 million Canadians and their families. 2/3 of these diseases cause significant disability, 3/4 affect children, more than 1/2 lead to early death, and more than 1/3 of these diseases remain unsolved. We have a lot more work to do. So drugs for rare diseases in Canada. At present, only a small number of rare diseases have treatments. Expensive drugs for rare diseases are defined as those that cost more than $100,000 per year per patient for therapy. And really, sales for these drugs in Canada have increased significantly over the past decade, which of course, unfortunately, there's existing information gaps related to these drugs and their high treatment costs. And this is really a big challenge for decision makers across the country. And as a result of this, there's really been significant government investment in a national drug strategy for rare disease. So there's a promise here of $1.5 billion over 3 years, and there's 4 main pillars of the national rare disease strategy. So pillar 1 is really to seek national consistency in coverage for drugs for rare disease. So what that means is that regardless of your postal code, you'll be able to access drugs equitably across the nation. Second pillar is really to support patient outcomes and system sustainability, so establishing a national governance structure and also an advisory board to ensure implementation systematically. The third pillar is really to collect and use real-world evidence. This is being driven and led by CDA and also by CIHI. And the fourth is an investment in innovation. And I really want to dive in and hone in on pillar 3, real-world evidence and data. So what do we mean? What is real-world data, and what is real-world evidence? So real-world data is defined as data that's collected in the context of the routine delivery of care, as opposed to data that's collected within a clinical trial, where study design controls the variability in ways not really representative of real-world care and outcomes. So how do we get real-world data? We can get real-world data in a variety of ways. So clinical data, we can get this from either electronic medical records, we can get this from case report forms, or we can get this from patient registries. The information that we get here are the demographics, the history, the comorbidities, the procedures, the treatments these patients are on, and their clinical outcomes. We can also get real-world data from looking at patient-generated data through patient-reported outcome measures. So here, we're getting insight directly from the patient in terms of what it's like living with that disease. So this helps us understand what happens outside of the clinic visit or outside of hospital admissions. The third main type of real-world data comes from cost and utilization data. So this is really from health admin databases, and really it's the health system look at how the patient's interacting with the healthcare system. And fourthly, government data sources provide information about the needs of the population they service. So census data, tax data. And so now we know what real-world data is. What's real-world evidence? So here it's the clinical evidence regarding the use and potential benefits or risks of a medical product or drug or device derived from the analysis of real-world data. So why do we need it? We need it because it helps us to bridge the gap between research, so what we learn, and everyday practice of what we do in healthcare. And it creates a difference between what's expected to happen versus what really happens. And it also provides regulatory bodies with data outside of clinical trial conditions to expand access to disease-modifying therapies potentially. So how do we go about using it? This is where it gets a bit more complex. And so I found this nice schematic online in terms of how you actually can operationalize real-world data to generate real-world evidence, and I'll take you through this. And also later in the talk, you're going to hear about an example of our research program that's proposed, really geared towards developing real-world evidence. So first, you have to start with a protocol to ask a clinical question. Then you need to define the elements that need to be collected to form your real-world evidence. You need to establish your data capture methods. You're going to have disparate data sources. You have to blend them all together with some kind of probabilistic matching. You'll then need to define and calculate your clinically relevant outcomes that you're interested in. And finally, you're going to need to be assessing and controlling for variability in your data quality and your availability and confounding factors. And so with that in mind, I want to now switch back and just hone in on two particular types of real-world data. So one, clinical data that we derive from patient registries, and two, cost and utilization data that comes from health administrative databases. So patient registries. Patient registries are a rich source of real-world data. And we know from CDA's most recent documentation review that there's 66 rare disease registries in Canada, and there's 82 international registries. And again, from registries, we get information definitively about diagnosis, but also information about demographics and history and comorbidities and procedures and treatments and medications and clinical outcomes. But there are limitations. So unlike a clinical trial where you have completely curated data, with registries, essentially it's data that's extracted from the electronic medical record and then inputted into the registry. So there often can be gaps in completeness of that data. And secondly, when patients give their consent to have data in their registries, traditionally consenting to linkage to health admin databases is not part of that initial consent. So health admin data, what even is that? So healthcare administrative data is data that's generated every encounter a patient has with the healthcare system. So the terms healthcare utilization data, administrative healthcare billing, administrative claims data, or simply claims data, they're all synonymous with the term healthcare administrative data. And basically what it is it's data that's collected for administrative or billing purposes, yet we can leverage it to study healthcare delivery, benefits, harms, and costs. And so because health administrative data reflects every time a patient interacts with the healthcare system, this can be in various permutations and combinations. Let's see if my slide works here. And so we can have acute care utilization. So that's going to refer to emergency room visits, hospital admissions, ICU stay, length of stay, and days in hospital. We can have same-day surgery. We can have diagnostic tests, so for sleep studies or ECGs. We can have their drug claims. Long-term care patients are admitted to long-term care homes. Home care, if your patients are prescribed home care nursing to go into the home and provide care overnight. Or outpatient visits, so all of those patient visits to see general practitioners, but also all of those outpatient visits to see all of the specialists. So in Canada, we have both national and provincial data holdings. From a national perspective, we have the Canadian Institute of Health Information, and then each of the provinces also has a provincial health administrative database. But unfortunately, there's significant variability in data coverage, both nationally, when you go from nationally to provincially, and also even across provinces, which we're going to talk about. So as part of the work that CAPT has been doing as part of the rare disease strategy, they published this very nice report about data learnings for rare disease analysis. And although the font is small on the screen, I just want to highlight a couple of things, just to highlight sort of where the data holdings lie and also where the gaps are. And so from CAPT data, we can get information on acute and emergency room visits. And you can see that from CAPT, this is very nicely represented. However, when we go to get information about outpatient clinics, there's major gaps with going to CAPT alone to access outpatient clinic visits. And therefore, you have to go to provincial health administrative databases to get that information. When we look at home care, long-term care, and primary care, there's also significant gaps potentially when going to CAPT data alone. And just to give you an example of primary care, so sometimes for primary care in some of the provinces, the family doctors are going to be on alternative funding plans, which means that unless they're doing shadow billing, that billing is not going to get captured in these provincial health administrative databases. And we won't then be able to reliably get data on number of GP visits. And then finally, pharmaceutical care. So a hot topic in this room, I know. So nationally at CAPT, you can get data on all of the publicly funded drug plan data across the country. However, as you probably know better than I do, there's also private drug plans that cover many of these costs. And only 3 of those private drug plans are covered within CAPT data provincially. So there's major gaps in relying exclusively on pharmaceutical data at CAPT alone to identify which patients are receiving certain medications. So what about across the provinces? So this slide up here, I'm going to take you through it, but really it's to highlight variability in data holdings across the province and to contrast those with CAPT. So what you can see here is I have the column here for data holdings, and those are the different types of healthcare utilization. If it's a green bar, that means that that data is available for more than 95% of the population. If it's yellow, it means it's available for less than 95% of the population, but we don't know beyond that what percentage. And if it's red, there's no data at all. So what I want you to appreciate from this is if we look down the line of CAPT, there's a lot of yellow there. And so to really get better data at present, we need to go provincially to the health administrative databases. But even when we go across provinces, so I've just highlighted 5 provinces here, you can see there's significant variability across the provinces. Now, Alberta and Ontario probably have the most robust health administrative databases to do research, but as I'm going to show you on the next slide, there are still gaps even amongst those 2 provinces. So this is a table that highlights sort of the 5 most commonly used health admin databases in Ontario. And I just want to hone in on this sort of second one, the Ontario Drug Benefit Claims. So here, this is the publicly funded drug service for prescriptions in Ontario. And in Ontario, patients will get this private, publicly funded program if they're more than 65 years of age, if they're younger but on assisted care, which means there's a huge segment of the demographic population that's not covered by this public program that we're going to be missing if we're relying on this approach only. In addition, some drugs are often prescribed through exceptional access programs or limited use programs. Unless they're meeting certain criteria, they're not going to be appearing in the ODP claims available through health administrative data. So again, gaps in accessing data about pharmaceuticals. Okay, so we've sort of talked through what health administrative data is. We've talked through sort of differences sort of nationally and provincially, but let's talk a little bit about, now that we know that, how do I go about identifying patients with rare diseases in health administrative databases? So there's actually 3 different ways that you can do this. The first is identifying patients with diagnosis information. The second is identifying patients via prescribed drugs. And the third is using a proxy method. So in health administrative data, we identify patients using something called the International Classification of Disease Code. We're using the 10th edition now, and there's Canadian-specific codes that we use in Canada. The challenge is that not every single rare disease has its own unique ICD-10 code. For example, for patients who have Duchenne muscular dystrophy, the ICD-10 code is actually muscular dystrophies. So relying on the ICD-10 code alone will not let you be able to identify those patients. Secondly, identifying patients via prescribed drug. This works well if there is a drug that's prescribed for that rare disease only and it's on formulary. If this drug is prescribed off-label, or if that drug is also prescribed to other diseases, you then cannot reliably identify your patients. And thirdly, sometimes clever health services researchers come up with proxy methods where they say, okay, I'm going to take this index, you have to have visited a neurologist, you have to have had this admission with this billing code, and you have to be within this age. And if we put all of those together, then we're going to be able to identify a cohort. But again, that's not going to be perfect either. It has its own inherent challenges. Okay, so this is just to highlight the example of Duchenne muscular dystrophy. So again, the ICD-10 code is not a specific code. Unfortunately, there's not a specific drug treatment yet that's available only for Duchenne patients. And thirdly, there's no validated algorithm yet in health administrative databases to identify patients with Duchenne muscular dystrophy. So what that means is we can't reliably identify a cohort of patients with Duchenne muscular dystrophy from health administrative databases alone to date. Okay, so sometimes when we think about health administrative data analyses, clinician researchers or investigators are going to ask certain questions about these diseases that are going to be driven by disease characteristics. So first of all, I want to highlight these are rare diseases, so inherent to that is their small patient numbers. This poses a unique issue for health admin database research. So number one, you actually cannot do meaningful analyses with very small numbers of patients. It's just these sophisticated analyses are not feasible because you're not powered to do so. The second thing is when working with health administrative data, to protect the anonymity of patients, you have to have a certain cell size per se to be able to do that work. So small cell numbers are really challenging. So to overcome this, often what you do is aggregate, sort of go back multiple years to then be able to have a large enough cohort. But when we do that, we can run into problems where we're not only using ICD-10 codes, but we can also be using ICD-9 codes. And so this picture, this graphic here, what it shows is really the transition from ICD-9 to ICD-10 codes in Canada. And just to highlight that that transition took over 6 years to make that transition happen. So if you're going back to look at a cohort that's inclusive of before the 2000s, you're going to have a mix of ICD-9 codes and also ICD-10 codes. And that, again, increases complexity for your analyses, but also increases the chance of misdiagnosis or underdiagnosis. Sometimes in different diseases, the clinician investigator is going to be interested in looking at disease onset and progression. And again, if you want, you're going to make some assumptions when looking at health admin database data alone, such that you're going to say, okay, this is going to be the first doctor visit or the first hospitalization with that specific code. So again, not a perfect assumption. There's definitely inherent biases. And the next thing to highlight is we're all interested often looking at mortality. And just to know that we can only rely on health admin database for mortality if the deaths occur in hospital or in long-term care. Otherwise, the deaths are not tracked. Fortunately, that's where most of the deaths do occur. Very few are occurring at home, but just to be aware, that's also a potential limitation. So another case example, just coming back to spinal muscular atrophy. So very fortunate that 3 drugs have been approved that are disease-modifying therapies by Health Canada for this patient population. But again, inherent challenges in doing health administrative data work for this patient population. So small patient numbers, this is concerning for the reasons I've outlined before, the ICD-10 stuff and also the small cell numbers for analyses. And then finally, for these disease-modifying therapies, the additional curveball is that across the country, they're prescribed using different prescribing plans, making it not reliable to use health admin databases to identify the patients who receive those drugs alone. So a lot of gaps and challenges when relying solely on health admin databases to do some of this rare disease analysis. Okay, but all hope is not lost. So CAI has been doing a lot of great work, really as part of this rare disease strategy, and has identified some nice initiatives for improved analyses. And so one, the ICD-11 codes. So with these ICD-11 codes, they're going to identify 5,500 out of the 6,000 rare diseases as compared to the only 8% that we have now. However, as my understanding is we don't yet have a date when health admin databases are going to be rolling over to ICD-11 codes. And secondly, as you saw from the other slide I shared with the ICD-9 to ICD-10 rollover, that took 6 years. And we could anticipate a similar period of time when we switch from ICD-10 to ICD-11. Second initiative at CAI is to really consolidate data into a pan-Canadian prescription drug information system. This is sort of a 5-year plan. I think that is going to be incredible because that would be able to overcome all of those limitations to identifying patients based on their drugs that I've outlined already. Another initiative from CAI is to collaborate with rare disease registries and newborn screening programs. We're going to hear more about that later this morning. And then finally, improving the coverage of data in outpatient healthcare settings, because as you saw from the slide I presented, really one of the dearths of data for CAI is that they really have limited outpatient data in their national data holdings, which means you have to go provincially. Okay, so if we come back to this national drug strategy for rare disease, I want to focus now on pillar 4, which was the investment in innovation. And so through this, CIHR had a rare disease initiative granting competition, and through that, there were 4 main pillars for this grant, these grant funds. So the first was improving diagnosis for rare disease, and so 3 teams nationally were funded to really do genomics work to improve diagnosis. The second was bringing gene therapies to clinical trial readiness, and again, 3 different teams were funded to do this work. The third specific grant call was developing a national pediatric rare disease clinical trial and treatment network, and 1 national team was funded to really be able to improve clinical trial readiness in Canada. And the fourth call was to improve health and administrative data and monitoring for rare diseases. And 2 grants were funded, and really pleased to say that our group was really the second group that was funded for this pillar of CIHR funding. And our work is really geared around developing a program of research that helps to improve and overcome some of the gaps that I've highlighted already when we go to health administrative data alone for rare disease analyses. And the work that I'm going to be talking about is really going to nicely, I think, complement the work that CAI is doing nationally as well. So the title of our research program was Real-World Evidence for Canadian Neuromuscular Disease, establishing a framework for national integration of patient-reported outcomes, clinical registry data, healthcare utilization, and healthcare-associated costs. And so I just want to highlight the co-principal investigators of this team. So Victoria Hodgkinson, who's over there, right there, Hans Lockmuller, Eyal Cohen, Gord Jewett, and Homira Osman. And I also really want to highlight, we have a huge team. So we have the Canadian Neuromuscular Disease Registry co-investigators across the country. We have the Neuromuscular Disease Research Network that's members, all of the health service researchers and economists. We have several patient partners that are involved in this work. And then also we have nonprofit partners with Muscular Dystrophy Canada, Cure SMA Canada, and Defeat Duchenne Canada. And our 3 nonprofit partners have also generously provided funding in support of this work in addition to the CIHR funds. And so the aims of our proposed research program are really twofold. So aim 1 is to understand the burden of neuromuscular disease in the Canadian healthcare system, including the prevalence, healthcare service utilization, direct costs, and health inequities. And aim 2 is really to work to establish a platform for real-world evidence generation for neuromuscular disease that can be used as a model for other rare diseases. And so our project objectives, there are many, is really to determine, disease-specific healthcare utilization nationally and provincially, and it'll become clear why we're doing these at 2 levels. Disease-specific prevalence nationally and provincially, disease-specific costing and variation in costing between Ontario and Alberta, healthcare utilization costs and prevalence of diseases based on health equity stratifiers, disease-specific mortality. We're going to do some work looking at the sensitivity of the ICD-10 codes, ascertaining diagnosis through them versus using registry data, and then finally looking at the impact of disease on the patient and the family. And so we have conceived this research program into really 2 parts. So part 1 is data linkage for a retrospective cohort. And so here, just in terms of a high-level overview of what we're hoping to achieve, so step 1 is really to take patients with spinal muscular atrophy and Duchenne muscular dystrophy who are identified using the Canadian Neuromuscular Disease Registry. We are going to link them to health administrative data, and we're going to do this nationally at Statistics Canada and then also provincially, and through that we're going to get information about mortality, healthcare utilization, and also healthcare utilization associated costs. Okay, so national linkage with Statistics Canada. Why? So the linking nationally enables us to report on unique socioeconomic and financial data holdings that are not available in the provincial databases per se. So we can get CAI data through Statistics Canada. We also can get access to the social data linkage environment in Statistics Canada. We can get vital statistics information, tax information, as well as access to the immigration database. In addition, this work is being conducted in patients with rare diseases, which means the numbers are small. And so patient prevalence in each province may be low and lower in certain provinces compared to others. And really having this national linkage will enable more fulsome reporting of health service utilization across the country. So we're also going to be linking provincially across the country in 5 provinces. So in BC, Alberta, Ontario, Quebec, and New Brunswick. And the next line there, you can see it's in bold, and it's in bold for a reason I want to just highlight. So currently, if you want to do healthcare costing of healthcare utilization from publicly funded utilization, you can't do that nationally at CAI. You actually have to go to the provincial databases to be able to do that. And even when you do go to the provincial databases to do that, you can only do this in 2 provinces. You can only do this right now in Alberta and in Ontario. And as I touched on before, we're going to be doing some of that ICD-10 validation work with known patient diagnoses from the registry compared to how those patients were coded using ICD-10 codes. So why these 5 provinces? We've picked these 5 provinces to ensure adequate representation across the country. And we also picked these 5 because we worked with the Health Data Research Network of Canada and all of the provincial health administrative databases and found that really these 5 were the only 5 that had the existing infrastructure to be able to help us carry out this work. So the Canadian Neuromuscular Disease Registry is how we're going to be identifying our patients definitively. And just to highlight that CNDR and its network of investigators really is a global model for rare disease registries. So Victoria Hodgkinson, who's here today, and also the one of the co-PIs of this work, she's the executive director of CNDR. So since its inception in 2010, CNDR has really led the recruitment of more than 5,000 individuals with various neuromuscular diseases. And to highlight that working with a registry really is a huge opportunity that overcomes many of the barriers that I've highlighted related to going to health admin data alone for rare disease analyses. So the registry overcomes the hurdles of patient identification by diagnosis, symptom onset, disease-modifying therapy, start and end dates. But with this program of work that we've laid out, and especially for this sort of step 1, there are several anticipated challenges that we're going to be needing to work through, and I'll talk about each of these in turn. So patient consent, data completion of the registry. The registry does not include all patients that have those diagnoses. Variability of data holdings across provinces we've touched on already. And then finally, a lack of a harmonized research ethics process across the country. So patient consent. So for many registries, including CNDR, patient consent for data to be held in the registry alone does not include consent to share health administrative data linkages. So therefore, we need to consent all of these patients. And so our research ethics board has allowed us a waiver such that we need to contact all of these patients to consent them, but if we can't get a hold of them or if they've passed away, we are then able to be granted a waiver of consent. Secondly, data completeness of registry data. So unlike a clinical trial, again, which is completely curated, where you know you're in good control of what data is there, one of the challenges of registry work is that it's passively collected. It's extracted from the electronic medical record and that is inputted in. So often there can be gaps in the completion of the data in a registry. So right now we're knee-deep in the trenches. These are all the data elements that we're hoping to connect on, but we're gonna have to see what the data completeness is, and then we'll have to develop an approach for gap filling. So it's a huge amount of work to develop a registry and maintain a registry, and I just wanna put a plug out to this group that really there needs to be ongoing financial investments, probably from government infrastructure, to maintain registries because we're going to be so dependent on them to help overcome so many of these barriers to research to really generate robust real-world evidence. And finally, currently the registry, the CNDR registry, does not contain every single patient that has spinal muscular atrophy or Duchenne muscular dystrophy in the country. So as part of this research program, we're really going to be working on doing a blitz to increase enrollment into the registry to have more complete representation. Okay. And then this is a big one. So a lack of a harmonized research ethics board process across provincial health administrative databases. So we are conducting essentially identical analyses pending data element availability across all 5 provinces. But we need to submit 5 separate research ethics board applications to each of those provincial data holdings. And there's no harmonized synergistic process. It's not like if you get approval at one, you then will have an expedited approval at each of the other ones. No, it's an independent process for all of them. Then in addition to that, we have to complete separate data sharing agreements for each of those. So you can imagine that this is really a barrier to efficiencies in conducting multi-jurisdictional research. So that was part 1 of our program. So part 2 is really developing a data platform for real-world evidence generation. So what do we mean by that? So here we're going to be generating 4 prospective 2-year national cohort studies. And they're going to be in spinal muscular atrophy, Duchenne muscular dystrophy, spinal bulbar muscular atrophy, and oculopharyngeal muscular dystrophy. And we pick these 4 cohorts of patients because these are cohorts that are important for Canadians with neuromuscular disease. So SMA, we chose that one because it already has 3 disease-modifying therapies that are available. Duchenne muscular dystrophy, we chose that one because we can't reliably identify those patients in health admin databases currently, and there's going to be disease-modifying therapies in the very soon near future. SBMA, this neuromuscular disease is more prevalent in the Indigenous population in Canada than really anywhere else in the world. And oculopharyngeal muscular dystrophy, due to founder effects, also has a very, very high prevalence amongst French Canadians. And so this is, again, an overview of what we're hoping to achieve with our part 2 of our research program. So we're going to be administering patient-reported outcome measures prospectively to these cohorts. We're then going to be linking with registry data for these 4 cohorts, and then we're also going to be collecting information on direct out-of-pocket costs. Because again, using health admin databases, we can only get publicly funded healthcare costs. We'll then be able to bring all of that together and then link again provincially and nationally to health admin databases to really get a holistic view of disease burden. So we'll be able to have information from a patient level, so health-related quality of life, out-of-pocket costs. From a family level, so what's the impact of the family from a caregiver burden perspective and a mental health perspective. And then we'll be able to have really robust information about total healthcare utilization, again, nationally, and also more of a deeper dive provincially in certain provinces. And then we'll also be able to have information about healthcare costs. And so we're gonna have data being collected every 2 months. We're establishing 2 new registries as part of this work in SBMA and OPMD at CNDR. We're gonna be having prospective patient-reported outcome measures where we're collecting that data, as well as out-of-pocket costs. In terms of our patient-reported outcome measures, we're really thinking about them quite broadly because we want to be able to look at patients within the neuromuscular disease itself, but also across diseases, so both patient generic and also patient-specific outcomes. And I just want to touch on briefly our plan for Indigenous patient engagement. So our team is really committed to ensuring that our research is conducted in a way that's culturally sensitive and also respects Indigenous data sovereignty. And we're very fortunate that our EDI leads on our team, Alexandra King, Malcolm King, Carrie Schellenberg, and Gerald Pfeiffer, have engaged with Indigenous people with SBMA doing active research since 2020. And so really we're going to be drawing upon their work and their advice to help us sort of move this program forward. So from a patient engagement perspective, through the work that our EDI team has done, there's the establishment of a community guiding circle for this community. So when we reached out to ask for participation in the grant processes to move things forward, we get consent not just from individual patients, but also from the community guiding circle as well. In addition, we have a research coordinator who actually is quite experienced in working with this patient population. We've also budgeted specifically for culturally sensitive supplies to do this work. And then finally, from a data management perspective, we are going to be working with the community guiding circle to make sure that consent and regular updates and ongoing participation are ongoingly reviewed in a way that's accepted and meaningful to the Indigenous community. And so in summary, what are we hoping our impact will be from this program of research? We're hoping that we're going to be able to develop a framework for rare disease linkage studies. We're going to be doing some work validating ICD-10 codes to sort of set the stage for future ICD-11 codes. We're going to be informing health system decision makers on the variability of neuromuscular disease burden across 4 diseases, but also across the country. We're working to build collaborative relationships with health administrative researchers in other provinces. So currently, the only maritime province that has the infrastructure to be able to do this work at the provincial level is New Brunswick. But we've got all of the other health admin provinces on board so that they can learn from this program and build capacity for future work. We're going to be establishing a platform for future cost-effectiveness studies of disease-modifying therapies. And then finally, we really want this program of work to be an exemplar for other rare diseases to build rare disease real-world evidence research generation programs. And so in summary, the future for rare disease in Canada is bright. We have the science, we have the infrastructure, and we have the government investment. Registries and health administrative databases are rich sources of real-world data, but there's challenges, as I've highlighted for you today, I think that, with using them alone, and really to be as effective with using these resources, we really need to have ongoing investment into them to overcome these challenges. Our hope is for our planned program of research in neuromuscular disease to serve as an exemplar for other rare diseases. And we hope that the challenges and the lessons learned along the way that we've shared today, that we'll continue to share with the community, can really help other investigators embarking on this work for other diseases. And with that, I would like to just show this beautiful mind map created by the Care for Rare Canada for rare diseases. And thank you for your attention, and happy to answer any questions.
Hello, hi, my name is Prince. I'm from Dalhousie University. I do health equity research, just focusing on mental health. So my question is, if you want to do a retrospective cohort study where in a certain year there was no ICD-11, so you have to use both 11 and 10. So do you anticipate, while doing that, do you anticipate any measurement bias or any differential misclassification, and how do you, what do you suggest to mitigate those type of issues?
No, that's a great question. Thanks for the question. So I think that for the work that we're doing, we're fortunate to partner with the Canadian Neuromuscular Disease Registry. So with that registry information, we're going to be able to definitively know who has the patient diagnoses. So we're going to be linking in that exact cohort, so we'll already have a case identification. And then what we're going to do is actually validation work for the ICD-10 coding. So we'll basically know that these are the patients that we've identified that definitively have spinal muscular atrophy or Duchenne muscular dystrophy. Then, and so that's how we're going to link and do all of our analyses. As an additional analysis, what we're going to do is look at the sensitivity of those ICD-10 codes, because now we'll know these are the patients from CNDR who have these disease diagnoses. This is how they were coded, and we'll be able to better understand how patients were coded. If they're all coded accurately, then great, that's fantastic. But if there's major misclassifications, then that's work that we're going to do to then basically develop an algorithm that can then be used across different provincial health administrative databases to correctly identify those patients, so that ongoing work can be done, because ideally every single patient with neuromuscular disease would be enrolled in the CNDR registry, but unfortunately that's not the reality. And so until we can get to that point, it would be nice to then be able to do this work directly in those health administrative databases with all of the cohort completely. But we'll have to overcome some of those barriers by doing some of the work that we've planned.
Thank you for the wonderful talk. It was great to see the step-by-step process and the very practical barriers and solutions you guys are working towards to, bring this to fruition. Are there any key learnings maybe that you would like to think about sharing for the medical community or even the industry side on how we can proactively train each other on how to get this stuff up and running faster, or maybe what to include in training programs?
No, it's a great question. I think that, one of the things to make this type of research more efficient, and I think there's already been some investment through CIHR to develop something called the Canadian Health Data Research Network. And they have been helpful, and we've been working with them when we've been sort of conceptualizing this program. But what's still limited, and I sort of alluded to this, is with the lack of sort of a cohesive REB process, it's really quite difficult to be able to do this work in a time-efficient way. And it really is like you're reinventing the wheel with doing it in each of the different provinces. So I think from a systems perspective, to really move the needle forward in an efficient way, it would be to have a national cohesive REB process. And I know the clinical trials group is working on this sort of as a whole to have a standardized already be processed for clinical trials, but I think something similar would need to be in place for health administrative data research, number one. I think number two, in terms of sort of training from like a medical perspective, I think to become a health service researcher, there's sort of two main pathways, right? And so often it's sort of the graduate school PhD statistician to then become a health service researcher. There's also a second way for like, you know, clinicians to become health service researchers. So I think highlighting the need for this type of work, I think is important to kind of go into medical schools and highlight this is a great type of research to really move things forward and really what's needed, because we are very fortunate in Canada to actually have this type of richness of data available to us that they don't have in the US and they don't have in many other countries in the world. And then I think lastly, in terms of industry, I think it's again realizing that this is sort of, that there is this sort of wealth of information, but there's multiple challenges, and then working with your partners to try and overcome them. But I think it's sort of a systemic issue that has sort of multiple barriers along the way that need to get solved, not just for rare disease, but also for any kind of diseases doing this sort of work.
Thank you, Reshma. That was an incredible presentation. Thank you for your insights, and thank you for sharing the work that you and your team is working on. And we wish you all of the best moving forward with that. So next we will have a panel titled "What's Up with TAT? Tackling Cancer Genomic Testing Inequities in Ontario." I will invite the moderator as well as the speakers up to the podium.
Well, good morning. Good morning. So my name is Filomena Servideo Italiano, the very proud president and CEO of the Colorectal Cancer Resource and Action Network, or more affectionately known as CRAN. Aren't you relieved that I at least provided an acronym for the charity's name, unlike my first name? So as the moderator of this morning's session, entitled "What's Up with TAT?" or Testing Turnaround Time, Tackling Cancer Genomic Testing Inequities, I'd like to extend a very, very warm welcome to each and every one of you. This is a deeply personal session to me, seeing that we are doing an enormous amount of work at CRAN, and this is going to be, ladies and gentlemen, what I truly believe to be an informative session to each and every one of you. So I'm privileged to be joined today by four remarkable experts whom I would like to introduce. Gentlemen, as I introduce you, would you kindly just hold up your hand, if that's okay? Mr. Steve Slack, our stage 4 colorectal cancer survivor and patient advocate, offering the patient perspective. Dr. Brian Lowe, molecular pathologist from the Ottawa Hospital. Dr. Ken Craddock, molecular pathologist from Sunnybrook Health Sciences Centre in Toronto. And Dr. Michael Rafel, GI medical oncologist from the Odette Cancer Center at Sunnybrook Health Sciences Center. Whoops. So why are we here today, ladies and gentlemen? we have what we consider to be a really good problem on our hands. Biomarker testing is growing. Over the past 10 years, biomarker testing has expanded and led to improvements in patient outcomes. Wow. But this has most certainly created significant challenges within our healthcare system, because the increased demand for biomarker testing has led to delays in biomarker testing results and treatment, potentially leading to negative patient outcomes. In medical oncology, for example, there's evidence to support the delay of systemic therapy in the non-small cell lung cancer patient population. In this patient population, there's an average of 4% of patients who will die during each week that passes without initiation of systemic therapy. The study found that if systemic therapy were delayed by 1, 2, 3, and 4 weeks, the mortality rates could increase by as much as 4, 7, 10, and 13% respectively. And with respect to the pathology perspective, a study published earlier this year highlighted key practice variations in cancer biomarker delivery time throughout participating centers. 88% of the sites, that's 7 out of 8 centers, exceeded the recommended turnaround time of 14 days. It highlights the urgency of improving the biomarker testing turnaround times. A patient group roundtable hosted at CRAN's 2023 Biomarkers Conference, which included heads of 9 Canadian patient advocacy groups and 6 additional tumor type presentations, identified challenges and barriers to biomarker testing from their respective patient populations. The top 3 reported barriers or challenges by the 9 patient advocacy groups were: number 1, lack of timely access to testing and reporting of the results to help inform those really important clinical decisions. 2, lack of patient education and awareness of biomarker testing. And 3, inter and intra-provincial disparities with respect to biomarker testing access, funding, and the silos that exist within institutions and between provinces. We at CRAN forged ahead in 2024 to capture the patient perspective across, this time, 24 tumor types by disseminating an online patient survey across Canada through 24 patient advocacy groups, gauging that lived experience of the advanced and metastatic cancer patient with respect to biomarker testing and comprehensive genomic profiling. The survey results confirmed the previous year's results and far more, but most importantly, the top challenge identified: there are most certainly delays in obtaining biomarker testing results. So with respect to this critically important session today, by the end of the program, participants will be able to understand the barriers that delay turnaround time, or TAT, and how this can lead to inequities in timely, comprehensive genomic profiling reporting. Learn about the significant negative clinical patient impacts and consequences of delays in reporting. Explore potential solutions in improving TAT and discuss with peers, the panel members, discuss with peers and panel members TAT issues and solutions. So on that note, allow me to proceed to the patient perspective, which we truly believe is grounded in positive change in the healthcare ecosystem. it gives me tremendous pleasure to introduce to you Mr. Stephen Slack, a survivor of stage 4 sigmoid colon cancer. He's probably one of the most inspiring humans I've ever had the privilege of supporting, and after becoming acquainted with him today, my friends, I believe you will feel truly humbled by his story. He's a husband, a father, a son, a brother, friend, and patient advocate. His disease has not defined him. Instead, his disease has encouraged him to serve others and be the best version of himself that he can be, to relentlessly go out into the world, make it a better place with courage, hope, and perseverance, and above all, love in his heart for those going through the same journey. Good morning, Steve.
Good morning.
So I tell you what, why don't you come up here to the podium, and what I will do is I will ask you a series of questions, if that's okay?
Okay.
Okay. Hopefully this will work. Welcome, Steve.
Thank you. I'm glad to be here.
We're so happy you're here today. So happy.
Thrilled to be here.
All right. So what I'm going to do, Steve, is I'm going to provide a brief synopsis of your disease journey, if that's okay with you?
Sure.
Okay, we've got the first 2 points up on the screen. So in June of 2021, you were diagnosed with sigmoid colon cancer and 23 inoperable liver metastases, which then quickly led to the surgical resection of your colon cancer. On August 24th of 2021, about a month after your surgery, you met with your treating oncologist, who ordered biomarker testing as well as Foundation 1, the latter of which required you to pay about, I think it was $3,500 as an
yes.
out-of-pocket expense, right?
Correct.
Okay.
Yeah.
Awesome. 1 week later, on August 31st, you started bi-weekly FOLFIRI chemotherapy without any targeted therapy, no precision medicine. Is that correct?
That is correct.
Okay, here we go. So Steve, can you share with us whether or not you had any knowledge or understanding of biomarker testing when it was ordered by your treating oncologist? And if you had any knowledge of how the results could have helped to guide treatment selection? Go.
The short answer is absolutely not. I had no knowledge. I had never heard of biomarker testing at the time. I had no idea of its significance to me as a metastatic colorectal cancer patient. I'm not even sure I was aware that the testing was ordered, to be honest with you. No idea. So I didn't know what questions to ask or questions I should be asking or what to expect, or certainly had no idea that this testing could be important because it could inform additional targeted therapies that could assist with my treatment of my disease.
Okay. How long did it take for those biomarker testing results to come in? And as well, how long did it take for the Foundation 1 results to come in?
So the biomarker testing results, I specifically remember that. It took a couple of months, about 2 months, for those results to come. And I found out at an appointment with my oncologist before my third or my fourth round of chemo. And I just remember at the meeting, he said to me, listen, I have these results. I want to go over them with you. And that's when I found out that about RAS wild type. I, again, didn't know what that was. But as he explained it to me in fairly layman's terms so that I could understand it, I remember thinking and I'm listening. And when he was done, I looked at him and I said, this sounds like this is good news. Am I right? And he said, yeah, this is really good news. And so he explained that meant that I would be, as of my next round of chemotherapy, he'd be adding in a targeted therapy called panitumumab to my treatments. And I was just really happy that, it sounded like this was a positive thing. It would positively impact my prognosis. As for the Foundation 1, I was wondering about that one too. not just for the result, but also the fact that I did pay for it, because I'd like to kind of know what my $3,500 got me. And a couple more rounds went by, and I didn't hear anything. And I kind of figured, because I think he explained to me that it went to the States or something like that. So I understood that it was going to take a long time. But I don't know. It was weeks later that I said to my oncologist at a appointment, I said, by the way, whatever happened with that Foundation One, that test that I paid $3,500 for? Like, did we get that back yet? And he said, oh, I'm sorry. Yeah, I've had that for a few weeks now. I thought I told you, or I thought I gave the report. But anyways, no, it didn't. There wasn't, we were looking for a needle in a haystack, or hoping for one. We didn't find it, so nothing there. But that's how I found out about Foundation One.
So at what point did you become aware of the importance of biomarker testing results, taking into account that you had a left-sided primary tumor consideration?
Well, I found out at that appointment when he explained to me the results, and that we were going to add it as a therapy, that it meant that I would have a better, hopefully a better outcome by adding this targeted therapy. But again, it wasn't until a few rounds into my treatment that we found that out.
So 2 months later?
2 months later, yeah.
2 months. Okay. All right, so we'll stop there and we'll continue with your journey.
Okay.
All right. So on October 26, 2021, once your biomarker testing results became available, panitumumab, a precision therapy, was added to FOLFIRI chemo. In March of 2022, you started hepatic arterial infusion pump chemotherapy at Sunnybrook, which ended in September of 2022. And ladies and gentlemen, just as a reminder, for those of you who may not necessarily be well acquainted with HAPE, it's essentially a puck-size pump that's implanted just under the skin and directly hooked up to the liver to help reduce not only the size but the number of liver metastases. And this is for patients such as Steve, who have unresectable liver metastases. The goal, obviously, is to help metastatic colorectal cancer patients achieve surgical resection. And in the event that that doesn't happen, it's to reduce the burden of disease in the liver, achieve regression, disease regression, or achieve stability. I'm sure Dr. Rafel would have done a much better job of describing it, but that's essentially the goal of HAPE. It's a wonderful, wonderful program at Sunnybrook. And what HAPE did manage to achieve is to get Steve's disease in the liver from 23 liver metastases to one liver metastasis. No further treatment was then recommended for the next 7 months, and for his family and for Steve, it was a wonderful achievement, wonderful. In April of 2023, a PET-CT picked up that one remaining unchanged liver metastasis, which meant, Steve, you then qualified for the Living Donor Liver Transplant Program. You were restarted on FOLFIRI and panitumumab in May of 2023, right through to October 23, and began the process of seeking out a live donor. And then, on November 27th of 2023, you underwent a highly successful living donor liver transplant, and today you have acquired a no evidence of disease status.
That is correct.
So my last question to you, Stevie, is, do you have any thoughts that you'd like to share with us about your delayed biomarker testing results?
I do. The first thing that jumps off the screen at me, I'm looking at the prompter down there. You said highly successful living donor liver transplant, and it was. But it does not mean it was easy. It was a grueling procedure to undergo. The entire process, from having to put yourself out there to friends, family, and the general public, going, anyone like to give me 2/3 of your liver? That's a hard thing to do. And then to go through this process of screening donors, and it was the first 2 that were screened were not suitable, so it was the 3rd one. It took months. And emotionally on myself and my family is brutal because, you know, you feel like the clock is ticking. You know, before the window of eligibility closes, something progresses in the disease, and all of a sudden this potential solution is off the table. So yeah, it was successful, and I'm super grateful, but it was a really tough, strenuous, emotional, anxiety-ridden process, and then the recovery was brutal. The surgery was a long, tough recovery. I think some doctors would say, my doctors would say I'm still recovering. To an extent, it hasn't quite been a year yet. And so my thought is, you know, as grateful as I am to the incredible doctors in our system that got me to where I am today, I do wonder what would have happened, or could things have been different had that biomarker testing been quicker. And I mean, I did so well on the targeted therapy panitumumab. What if I had been able to start it from day one? Like, what if I had started it with my first treatment, and the first few treatments I hadn't missed that? Maybe I wouldn't have had to take this drastic step. Maybe I would have had a complete response and wouldn't have had to go to the drastic step of having to go to a liver transplant. And I mean, on top of everything else, and again, I'm not complaining, but you know, a liver transplant that's like a lifelong thing now that you know, I'm left to live with, the medications and the side effects of those medications. It's a life-altering thing. And so yeah, I wonder, you know, could things have been different? Maybe that I wouldn't have had to take such a drastic step for my health. And the other thing, of course, that I have to call out is not all patients are as lucky as I am. You know, that delay could mean their life. And so I'm very aware of that.
You're awesome. Thank you, Steve. Thank you so much.
Thanks.
It was good, huh? Okay. All right. Let's proceed to the pathology perspective. Our next presenters, Drs. Lowe and Craddock, will provide a lay review of comprehensive genomic profiling and solid tumor cancers and the benefits of accessing timely CGP results through a 2-part talk. Dr. Craddock will speak to the journey a test undergoes from post-surgery to the time a report is generated. He will explore ideas on where we can improve on CAPT. Dr. Lowe will then speak to the informal assessments of TAT patterns from a center that services a rather large community region in Ontario. From a personal point of view, ladies and gentlemen, I've learned this throughout the years. While pathologists may not necessarily deal directly with patients, they are quite mindful of the fact that each slide with which they work, each report generated, actually has a living patient associated with it, and strive to do their very best to get those reports out as quickly as possible to help reduce the anxiety, the stress, despite enormous challenges. It gives me great pleasure to introduce firstly Dr. Kenneth Craddock, who will then be followed by Dr. Brian Lowe. And we have a time crunch here, gentlemen, 15 minutes, 7.5 minutes per. Thank you.
Thank you, Philomena. All right, let's go right ahead. Okay. So here's a few of my friends. It's almost Halloween. These are some of the things I see under the microscope when I'm tired. Okay, and a few faces to the lab. So there's a number of hands that these biopsies go through in the lab. And I think, you know, people generally see the lab sort of as a black box and you get the result at the end, but there's a lot of stuff that happens. So we have pre-laboratory steps, i.e. like before, so the sample gets to the testing laboratory. So the molecular testing laboratory may be a different lab than the original lab that receives the specimen. And then we have post-laboratory, so getting that report to the oncologist that needs it. And so here are some 2020 consensus Canadian recommendations as to how long this process should take. And sort of going into more details as to some of these steps, what's going on. Okay, so pre-laboratory, what's going on here? So we have a biopsy, we have diagnosis, so that's a big step right there. And then we may or may not have a reflex order of a biomarker testing at the time of diagnosis, and Brian's going to talk a little bit about pathologist reflex testing, which is a big part of reducing these turnaround times. And then there's the transportation to the testing center. So if your lab does not have the testing available in-house, then we've got transportation to deal with. And that may be, a lot slower than you might think. Then we've got, some accessioning at the testing lab. You've got the pathologist has to review and make the order in the LIS. You've got the histology lab has to be involved and cutting slides for us. We've got DNA and RNA extraction. And we've got the actual molecular testing on fancy instruments. The tissue actually has to be macrodissected, so the pathologist is circling the tumor so that we can make sure that the DNA, RNA that we extract is going to be representative. Otherwise, we're going to get a negative result, but we're not representing the tumor. And then we have a number of steps going on in the lab. And so the sample is passing from multiple hands. And when those people are busy doing something, then it has to wait until they're, ready to get to that next job that they have to do. Each hands that it changes to is introducing potentially additional delays. So, and then you have the final report, and then the total turnaround time being ideally 13 to 30 business days, or ideally less than that. And then we've got the report. And then, so here's some Sunnybrook turnaround times. So for lung cancers, colorectal cancers, acute leukemias, and myelodysplastic syndrome. And so with the acute leukemias, we do have them quite a bit faster, partly because of a new instrument that we're using that combines multiple steps. Instruments are a big part of this. But we have ups and downs. So what's causing these ups and downs? So, lab staffing is a big thing, and instruments, reagents, sometimes these tests need to be repeated because of the instrument failure. Reagents not properly QC'd by the company. We've got, rapid increases in volumes and multiple additional testing indications. So here's maybe some opportunities. So for the pre-testing lab, expedite diagnosis. Now, and all of these things are, things that, require time to implement. So you need to have, the people need to be, not only have enough time to do their job, but also, can we improve our process and meet about that and try different things. So this is all, a lot of this comes down to staffing. So increasing the tissue available, so make sure you've got enough tissue when you take the biopsies. Putting the tissue in a specific way in the block so that you have as much as possible. So optimizing workflows, again, people need time to be able to do this. So we need to advocate for more adequate staffing levels in the labs is a big one, on all levels. And we need to staff according to the peaks in the workload, not the average workload. Otherwise, when the peaks come, then you're going to fall behind, and that's where we have big problems with turnaround time. And so we need those labs who are sending to the molecular testing labs to send them fast. So, and they need money to do that. As opposed to a free service that's not going directly to that lab, we need same-day courier. And then, labs need to work to get their reports into Connecting Ontario, where a lot of oncologists can access these results, very quickly, as opposed to contacting someone to try to get a result faxed. And there's big IT challenges in getting labs to get these reports into the Connecting Ontario electronic system. Again, people need time to undertake these projects. So I think I need to pass it on to Brian.
Okay. So great to be here. I'm going to just say that wonderful to share the stage with my colleague Ken Craddock. Known him for about 10 years now. And my portion here is to provide an Ottawa perspective to TAT, especially around colorectal cancer next generation sequencing. So our molecular testing in Ottawa is performed within a laboratory association, the Eastern Ontario Regional Laboratory Association. It serves as a nonprofit this region called the Champlain region of Eastern Ontario. 1.4 million residents, 18 hospitals, and in a given year, 14 million lab tests. The Lab Association is comprised of 750 medical laboratory professionals, about 75 medical scientific staff, and 50 admins. About 10 years ago, the Lab Association, together with the Ottawa Hospital Cancer Centre, decided that it was timely to begin investing in local molecular oncology testing. And at that time, and even currently, there are clear benefits to local testing. Among them, greater autonomy on turnaround time. With local testing, one can now optimize and perform better stewardship of the specimens that are being used for molecular testing. And with a local laboratory, we can actively collaborate with clinical stakeholders. And this is very important both for the optimization of utilization of sometimes expensive molecular tests and the interpretation of results that sometimes requires complex considerations of the clinical and pathologic context. So for 10 years in Ottawa, we've had the Molecular Oncology Diagnostics Laboratory. And I want to say that currently, with these increasing volumes that Ken was talking about, that we're all facing in Ontario, we are running 2,500 next-generation sequencing assays each year. The majority are Ottawa hospital specimens, but I want to point out that the minority, a very significant minority, are specimens from other hospitals in our Champlain region. So I'm going to just briefly go over this because Ken already covered it. I think the essential point to reiterate is that molecular oncology diagnostics is complex and it's a multi-step process. As Ken alluded to, sometimes technology, new instrumentation really can improve the processes in our lab, make things simpler, eliminate steps, and that can improve turnaround time. It improves also lab workflow, relieves our sort of requirements of tech time. But that's really only a part of the picture. And so what I want to present is a case study around TAT for Ottawa around colorectal cancer. I can do this because about 2 years ago we implemented a new information system, Epic Beaker. That system tells me that over the last 2 years we've processed about 805 colorectal NGS cases. Want to just point out that Cancer Care Ontario defines turnaround time as from the time the sample is received in the lab to when the lab signs out the report. And our Epic Beaker tells me that over these 805 cases, our average turnaround time is 12 calendar days. So this is the key question. Is 12 calendar days of turnaround time acceptable? And again, our new LIS system is plotting this histogram of turnaround times for these 805 cases. And you can clearly see that 12 days really is an average, which means that if you look at the histogram, there are 13% of cases with turnaround times, lab turnaround times, between 15 and 19 days, and importantly, 5% of cases with lab turnaround times greater than 20 days. Now, we've begun looking at these long turnaround time cases. Approximately 50% are due to technical repeats or repeats on a second block because the first one was insufficient. There's also another 50% that's requiring more effort to look into, and that's what we're doing now. Now, besides internal lab processes, our Epic Beaker also can look at the steps that take place preceding the lab. And so I want to point out another turnaround time, namely the turnaround time from test order to lab receiving the block. This histogram shows that the bar on the left, the vast majority, 72%, are actually less than 2 days, so that's great. These are, as it turns out, orders from pathologists, and these are happening under the so-called concept of reflex testing, so ordered by pathologists. But there are a lot of cases in that tail of the histogram, and unfortunately, these are the cases ordered by our medical oncologists. And as Ken pointed out, no surprise, when a medical oncologist orders one of these NGS cases, there are many other steps that need to take place, pulling from archives, slides, blocks, asking for the path review. That really is fundamental to these longer turnaround times. We've dived more deeply into the distribution of data between specimens that are Ottawa hospital specimens and those that are from other hospitals. I can say that there's actually, depending on site, a different proportion of long turnaround time cases, and the average turnaround times range from 6 to 11 days. So just some final words. I want to say that this turnaround time analysis clearly points that we need process improvements. We need to do much more work streamlining the process for requesting slides, blocks, and path review. On the upside, we think in our region we have seen clear benefits of our integrated information system, and that helps us locate diagnostic reports and confirm specimen IDs. And last, 4% of our cases are actually from Dynacare Life Labs, so from outside of our IRLA integrated network of hospitals. And these take 3 to 4 days longer. You may think 3 or 4 days longer isn't that much, but you add that to all the other turnaround times, and this really can make a big difference to treatment planning and patient outcomes. So with that, I'm going to pass the torch to Michael, my colleague, or to Philomena. Yep. Okay.
We're going to proceed to the medical oncology perspective, ladies and gentlemen. I am very honored to introduce to you Dr. Michael Rafel, who will be speaking to the medical impact of delayed TAT, clinical benefits of timely somatic testing in cancer and the importance of equal and timely access to CGP. As a side note, Dr. Rafel is the co-chair of CRAN's Medical and Scientific Advisory Board and a compassionate supporter of CGP timely access. I know for a fact that his talks are absolutely riveted, so you're in for quite a treat today. Please join me in welcoming Dr. Michael Rafel.
Hello, everybody. Monday morning. I see some smiles. Everyone's really well dressed. I feel like I overdressed today with my scrubs. Okay, but I need to get to know everybody because, you know, we've got to get excited on a Monday morning. We're talking about some topics that we can lose ourselves on our Twitter, Instagram, who's going to become the next president. All sorts of things are going on in life. Who here thinks they are close to the age of 40? Close to or above? Hands up. Close to or above? All right, who here is close to or above the age of 40 who has had a colonoscopy? Oh. All right, you all fail. Everyone in this room, when you leave today, is going to go see your doctor. Everyone's going to get a screening colonoscopy. I add this to all of my talks now. I've had one, my wife's had one, everyone in this room, colonoscopy time, all right? We're getting to really know each other. All right, so let's move on to the talk. So I'm going to talk about the medical oncology or the clinical impact of delayed turnaround times for molecular testing. As you heard, I'm a GI medical oncologist from the Odette Cancer Center. I'm a bit queasy because we're a little bit too close to the second best medical oncology center at Princess Margaret, but I will suck it up. All right, so disclosures, I have none. Are there any people from pharma in the room? Yes. All right, no one will identify themselves, okay? I don't take money from pharma. I sleep easy at night. Just joking, I love pharma. All right, takeaway point number one, delays can be deadly. This is common sense, but it's important to illustrate. So for about 15 years now, I've been very interested in the impacts of delays to initiation of chemotherapy. And so this was the very first research study I ever worked on, and I peaked at the beginning. We published it in JAMA. It's been all downhill from there. But for those of you who don't know much about colorectal cancer, the majority of patients with early stage disease, stage 1 to 3, will go on and have surgery as the main step in their treatment, and then we will give them preventative or adjuvant chemotherapy. And we now have decades of research that tells us that adjuvant chemotherapy can reduce the chance of the cancer coming back quite significantly by about 20%. But there are delays in our medical system, not just in terms of turnaround time, but involved in getting access to a surgeon, a medical oncologist, getting a port, getting a PICC, getting chemotherapy. And so what we found when we did a large systematic review and meta-analysis of over 15,000 patients is that every 4 weeks you wait until you start adjuvant chemotherapy, your risk of dying increases by 14%. And so let's apply this to a theoretical patient. So if you have a 65-year-old gentleman diagnosed with a stage 3 colon cancer, we can use readily available online calculators to help us predict that with the timely initiation of adjuvant chemotherapy, their 5-year overall survival will be about 60%. If you delay that by 4 weeks, we drop that down by 6%. If you delay that by another 4 weeks, you drop that down by 12%. And these emphasize that the timely initiation of chemotherapy saves lives. I challenge you to show me a drug that improves overall survival by 12%. So simple steps that are really, really important to patient care involve getting patients the right care that they need very, very quickly. Takeaway point, if you remember nothing else besides getting a colonoscopy, delays in oncology can be deadly. Takeaway point number 2. Our treatments are slowly but surely getting better, like a fine wine. Unlike me, you saw that picture up there. That was the day I actually proposed to my wife. It's been downhill from there too. Well, for me, not for her. She's getting better with age. All right, takeaway point number 2. Our treatments are slowly but surely getting better. So this figure illustrates the steady march towards improvement in overall survival for patients with metastatic colorectal cancer. So if you look back to the year 2000, we were all worried about Y2K. I remember that. Is the laptop going to turn on? We only had one drug to treat advanced colorectal cancer, and that was 5-fluorouracil. And what we used to do is you give it by a bolus. And if it stopped working, you say, why don't we just give it a little bit longer over an infusion? We didn't have any other drugs to offer patients. But through steady work by our pharma colleagues, our academia colleagues, by our patients and our patient advocates, we have fought and fought and fought, and we have inched our way towards better survival. So right now, a patient diagnosed with metastatic left-sided colon cancer has an average survival of about 35 to 40 months, and patients with right-sided colorectal cancer have about half, 15 to 20 months. So while we all could agree that we have way more work to do, these numbers could be way better, over these past 25 years, we've made slow but sure improvements. And what's really exciting is that we have seen some truly breakthrough, remarkable therapies. So 20 years ago, the idea that we could cure someone with metastatic cancer was unheard of. But this is a figure of a Kaplan-Meier curve from a clinical trial called Keynote 177, which looked at the use of a medication called pembrolizumab, an immunotherapy molecule for patients with MSI-high colorectal cancer. And what you can see is that tail of the curve. That is what we want in oncology. This is what gives us a smile and gives us joy, because that means that the curve is flat, and that means that no patients are dying. And so these are patients who are cured of their cancer. These are mothers, fathers, sisters, brothers who are given back to their family, given back to the community. We are really changing lives. But again, in order to make sure that we get these breakthrough therapies to our patients, we need genomic profiling to know who would benefit from this. And these are just not theoretical examples. These are patients that I treat on a daily basis. So this is a patient of mine I saw just a few weeks back. I met him when he was 33 years old and was diagnosed with metastatic MSI-high colorectal cancer back in June of 2020. This was a young man in the prime of his life, a young, beautiful family. 10 years ago, I would have had nothing to offer him but chemotherapy, which, as we saw, can help, but it comes with an accumulating burden of side effects, and it's not a cure. I was able to treat this patient with an immunotherapy over 2 years, and then most recently, you can see he's been off all treatment now since June of 2022, and he has been hopefully cured of his disease. This is his clean CT scan with a normal-sized lymph node in July of 2024. So we are giving patients back their lives. So our treatments are slowly, surely getting better, but we need to make sure that we have the genomic profiling to match the right treatment to the right patient. Takeaway point number 3. To select the right treatment, we need biomarkers, and we need them quickly. So as I mentioned, back in 2000, we only had one drug, so nobody cared about biomarkers because it didn't matter what they showed because you had no other drugs to be able to offer patients. But as we've had that steady march towards improvement, we have many drugs, we have many different types of drugs, and we select these drugs based off of the individual patient's tumor biomarker status. And so we need that information in order to properly treat them. And so now, in routine clinical practice, this is an example for colorectal cancer, we check many biomarkers, and these biomarkers have real implications because we use these to determine what is the best treatment for the patient sitting in front of us. And again, this is not theoretical. These biomarkers are incorporated into all international clinical practice guidelines, so we need to step our game up. We need to do better at getting these results back to clinicians so that we can start patients on the most appropriate therapy. Here's another example from a patient I saw just last 2 weeks ago. This is a 25-year-old person with metastatic colorectal cancer. I'm very fortunate that I have in-house NGS testing from colleagues like Dr. Craddock, was able to find out during the initial hospital stay that this was an extended RAS wild-type patient. As you heard from Steve, these are the patients who can benefit from the use of EGFR inhibitors like panitumab. We started this patient on FOLFOX and panitumab, and here's what you can see. This is a plot of their tumor markers. The CEA, something we follow in the blood for patients with colorectal cancer. The normal marker is less than 4. You can see that this patient started off with 25,000. We started them on chemotherapy and this targeted therapy, and within just a few months of therapy, their tumor biomarker was down to 27. That is a 99% reduction, and we were able to start this treatment right away because we had these in-house testing available to us. Takeaway point number 3, to select the right treatment, we need biomarkers. And my last takeaway point, we need our biomarker data as soon as possible so that we can start caring for our patients as soon as possible. And so I have clinic this afternoon, that's why I'm so well dressed, and that is why I need this information, because when I see patients in the clinic, I need to be able to start a treatment plan right away. So imagine a loved one being diagnosed with a cancer. They're meeting with their oncologist for the first time, as I'm going to meet several new patients this afternoon. They are told devastating news. They have a metastatic cancer. They are told even more devastating news. They are treatments that we have that can help. We can control the cancer, we can try to improve symptoms, but there is no cure. At some point, your loved one is going to die from this cancer. They have important questions that start racing through their minds. What are my treatment options? What is my prognosis? And imagine having to tell the patient's family that I cannot answer those life-altering questions because I don't yet have all the data. We need 2 weeks for that result to come back. You can imagine how you would feel, how inappropriate that is. So every single patient who comes into my clinic should already have all the answers there so that I can start right away with outlining a treatment plan for them. So takeaway point number 4, we need our biomarker data ASAP so we can start caring for our patients as soon as possible. And with that, I will say thank you.
Ladies and gentlemen, our experts are prepared to take questions or comments from you, so please step up to the mics.
I scared everyone with the colonoscopy remark. But seriously, everyone get a colonoscopy.
Colonoscopies are important.
Perfect.
Okay, one of the questions I had is about, I see a lot of data post-pandemic, but one thing that we see, I guess in most clinical settings, is just that increased burden of many complex diseases, including cancers, just with lower screening. Are you seeing more of these patients, and is that affecting the ability to actually obtain biomarker testing in a timely manner? Or had you have data pre-pandemic as well that can match? Thank you.
Yeah, so I think that we all recognize that during the pandemic, there was a lot of slowdowns in screening. There was also a lot of fear about presenting to hospital. The majority of patients I see as a medical oncologist are presenting with advanced disease, and so throughout the whole entire pandemic, there was no slowdown in my practice, and so I saw just about the same amount of patients. I think we have not yet seen the overwhelming burden of patients who are going to come because they've started now their screening again, who are going to start coming through our surgeons and then make their way to us. I don't have the specific numbers, although I know a number of my colleagues from ICS have looked at the impacts of delayed screening and the potential burdens we're going to have to face. I think that speaks to what Dr. Craddock had mentioned before about planning for the surges, because what is our average volume is likely to increase in the future. And if we want to be able to handle that, we need to plan for the future.
I just want to add to that. I'm not that familiar with the paper that a colleague or a bunch of colleagues in Ottawa published, but I think we did see an upstaging of colorectal cancer in Ottawa, because of delay of surgery, right, during the pandemic.
Judy Glennie, 2 colonoscopies. Propofol is fabulous.
I like it, yes.
The prep is not so much fun, but the propofol makes it all worthwhile. And I'm sorry, I had to step out to take a call, but I guess one of the things that, and this is very Ontario specific, one of the things that is a bit confusing to me is we've got all these committees that are looking at, into planning for various molecular tests and all the rest of this stuff, and it's not like next-gen sequencing, et cetera, is a new topic. I mean, we've known it's been coming forever. So where is the holdup in terms of coming up with a comprehensive plan that is accessible for people and that we can advocate for? Would love your comments on that.
I can start with that. I think like most things, it comes down to we need the appropriate allocation of funding. We're learning about new biomarkers each and every day, and so I'm constantly emailing our colleagues saying, hey, can we add this to our panel? Can we add this to our panel? And so there's only certain things that CCO funds for specific types of cancer, and if it's not funded, we have to find a way to get that into the budget, and usually that means taking the resource from something else. One of the things I learned as a clinician that I didn't know as someone who's not in the pathology lab several years ago is that when our pathology colleagues and our molecular oncology colleagues are doing these tests, they're running these humongous panels, and there is a whole wealth of data that is being taken down, and not all of that data actually makes it into the clinical reports. And so it was a few years back when I learned I could just email them and say, hey, when you ran the NGS, was this there? And I think that there's a lot of learning that needs to happen, and I think that sessions like this are important because when we bring these specialties together, like medical oncology, surgical oncology, patients, and pathologists, we can learn from each other. I do think we need to advocate for more funding, and I think that the simplest way to do that is across tumor types, we should be giving comprehensive genomic profiling. It shouldn't matter whether you have a colon or a lung or breast cancer. If we have this information, it can be helpful for immediate actionable change for patients to get on the right treatment, but it can also open up potentials for future treatments like clinical trials, because a lot of the trials that are being brought out now are biomarker driven, and if you don't know about the biomarker, you're not even eligible to consider the trial. So I think it should be offered to every single patient regardless of their cancer type.
Another point I could add is sort of the pathologist reflex testing concept where, so right now for lung cancer, when a pathologist diagnoses a lung cancer, we can then order that genomic testing at that time. Whereas for colorectal cancer, we're only funded to order that testing if we know that it's metastatic. And so, you know, we are slowly, and that's part of the reason, you know, the CCO funding is, you know, there's specific indications to try to reduce those costs and stuff like that. So, you know, but we need to work towards, you know, and I'm sure it will happen, you know, reflex testing on every cancer that's diagnosed, you know.
You know what, I'd like to jump in there on that as a patient and go, when I learned about reflex testing and that it's not an across-the-board thing, I thought that was absolutely bananas. Like, why isn't that? And you know, I think the answer comes down to money, and so I think Dr. Rayfeld is right that, you know, we really do need to advocate for proper funding because, you know, reflex testing across the board is really where we should be.
And I'm going to follow that up with, you know, advocacy for funding is very important, but how we use the money, especially in 2024, 2025, is going to be equally important. So our capacity to do, you know, higher volumes, you know, which is going to be obviously the case if we do reflex testing on every case of cancer, we have to be better at how we process the data, how we distribute, you know, our molecular reports, and all of that probably takes lots of changes at a provincial level. And so in medical school, you never really talk about, you know, process improvement, not once, right, in my medical school training. So hopefully, you know, we have some young, you know, doctors that may, you know, drive some of this, and maybe the people in this room. But process improvement is going to be equally as important as allocation of more funding.
Dang Chuan, Pfizer. So I understand that the panel is focusing on Ontario, but I wonder if you can comment if the same challenge are facing other jurisdiction, if any one of the provinces best in class and what they are doing different. Can you learn from them?
So I recognize, ladies and gentlemen, that I'm supposed to be wearing my moderator hat here today and not speaking from a content perspective. But if it's okay, I'd like to chime in here a little bit. We have significant advocacy efforts dedicated to this very topic. And we are leading the charge not only in the colorectal cancer space, but across 24 tumor types when it comes to CGP, biomarker testing, because we have identified a number of challenges and barriers when it comes to not only accessing biomarker testing, but biomarker testing results across 24 tumor types. And what we have noticed, what we have managed to identify, is there are funds being allocated across the various provincial jurisdictions. So I hope this answers your question. There are funds being allocated in silos, and they are not being appropriately allocated, and they are not comprehensively being utilized, which is in and of itself a challenge that needs to be thoughtfully addressed. That's first and foremost. Secondly, there are human resources that need to be looked at in a very thoughtful manner, which is why we have scheduled meetings with the various ministries of health to bring these barriers and challenges to their attention so that they can represent the best interests of their constituents. Having said that, we are moving forward with this charge in scheduling our 3rd annual Biomarkers Conference so that we can continue to address these barriers and challenges in the hopes of bringing about thoughtful, meaningful, and additional change that represents the best interests of our metastatic cancer patient populations, with the help of our experts, not the least of whom are seated here today, across the pathology spectrum, medical oncology, all stakeholders. But to date, we have yet to identify one province that truthfully represents that champion. Significant change is required, because when your loved one is diagnosed with metastatic cancer, this horrible disease, every day that they are waiting for biomarker testing results to come in feels like an eternity. I hope that answers your question.
I'd actually like to jump in on that question as well. So as a patient, and I also volunteer with CRAN as a volunteer cancer coach, support cancer patients across Canada virtually. And by the way, I just want to add that CRAN is just an incredible organization. And when I go back to, we were talking about, how I learned about biomarkers, how I really learned about biomarkers and the importance of biomarkers, and so many other things around cancer is really from getting connected with CRAN. Has educated me so much, and that's why I made the decision to be a cancer coach and help support other patients. But to directly answer the question, just again from patient perspective, anecdotally, I support patients across this country in just about every province. And I can tell you my story is one that I hear over and over and over again. It's not, so the end sort of impact of all of what Philomena's been talking about there really is patients across the country all sort of experiencing this same kind of delay in testing and the impacts from that.
I'm sorry, ladies and gentlemen, I recognize that we have gone over time, and we're done. Yeah. We're done. We're good. Thank you. Thank you for coming today. And thank you to our experts, wonderful experts.
All right, so we're moving into our morning break now. Refreshments are just right outside the conference room, and I think washrooms are right behind the conference room. Feel free to mingle with all the colleagues as well as any of the speakers throughout the day, and we ask that you return at 11 a.m. All right, so hope everyone had a nice break. We will have another networking session later in the afternoon. Our next panel for the day is titled "A Wave of Innovative Rare Disease Drugs is Coming. Is Canada's Healthcare System Ready?" And I'll pass it on to Brad.
Perfect. Thank you so much, and thanks for having us here today. I apologize. One of our panelists He's an in-demand character, and he had to present earlier today at across town. So he's on his way here. He's going to crash the party a bit late, but he will. Dr. Mandani will be joining us. Thank you so much. I think we've had a really interesting morning so far, and I hope that actually our session today will nicely complement it, because we heard a few themes earlier today around early testing and genomic testing, as well as we heard at the beginning of the morning around rare diseases, how many are currently kind of in Canada today in terms of therapies and the challenges in collecting evidence. And in this session, I think it's going to kind of play a very interesting support to those themes around the area of drugs for rare diseases, how, what's in development, what's coming in the next 10 years, and what do we need to do as a healthcare system to prepare for those new drugs, those new wave of innovative therapies. And we'll have a lot of very different perspectives on that, so I'm really excited. My name is Brad. I lead our real-world solutions team at IQVIA in Canada, where we deal day in, day out around collecting real-world evidence and insights around patients. Today with me, I'm very honored to have an excellent set of unique perspectives that cover across the spectrum on this topic, starting with Whitney Ayub-Goldstone. She's the Executive Director of Immunity Canada and will bring, among other things, a patient perspective around rare disease patients in Canada. Christina Elliott, counsel at Fasken Health Law and the former Ontario Minister of Health and Deputy Premier, will hopefully bring a perspective around the Ministry of Health and how the Health Ministry can better support patients with rare diseases and the future of that organization. Dr. Mamdani, who's not yet here, will bring the perspective of healthcare analytics, real-world evidence, and AI around better supporting patients with rare diseases. And Dr. Jim Dowling, who's staff clinician, senior scientist at the Hospital for Sick Children, and he's also a professor of pediatrics and molecular genetics at the University of Toronto. So again, bringing a healthcare provider expertise to the subject around the challenges and barriers with how we currently identify and treat patients with rare disease and what we can do. So before we begin our subject, part of this topic was kind of conceived around a recent paper that we did in collaboration with Takeda. And Takeda, thank you very much for your support on this report around what's going on in the development of drugs for rare diseases and what does that mean for healthcare system readiness in Canada. And that report is available through Takeda's website, where you can learn more. But essentially, in terms of what we tried to do with this report is we tried to look at what's coming, what's in the pipeline, in terms of volume, in terms of mechanisms of action, different therapeutic areas, to really get an understanding of the drug development pipeline and what promise we can expect to see over the next 10 years. And then look at, okay, well, what does our healthcare system look like today, and what might need to be changed? What are the barriers in terms of healthcare system readiness, and how, by linking those two things together, what insights can we generate? Just to highlight, why this is important, one of the details of the report shows that rare diseases impact 1 in 12 Canadians and are often life-threatening. So while each individual disease can be quite rare, when you sum them all up, it impacts a great number of lives and patients across Canada. So in terms of how we went about the report, we looked at the pipeline today and extracted all of the drugs that have some sort of indication for rare disease, or what we call orphan drugs. for patients with rare disease. Looking at our IQVIA Pipeline Intelligence, which is a database of all clinical trials active across the globe. From that, we filter down for active trials, excluded rare or included rare non-oncology indications, and essentially whittled down from a total of 6,259 drugs that we could see had some sort of development for rare disease to 1,147 active drugs for rare disease in development today. Some of the interesting components of those drugs when you look at them, we looked at them from phase of development, the therapeutic area, routes of administration, mechanism of action, trying to learn as much as we possibly could around what are these drugs and how could they impact, how could they impact patients today. So some of the key findings from that study, as I mentioned, there are over 1,100 DRDs, or drugs for rare disease, currently in the pipeline. Roughly 39%, or almost 40%, are first-in-class medications. So these are unique molecules, unique compounds, really typically highly innovative drugs distributed across diverse set of therapeutic areas, with quite a few targeted towards the nervous system, the immune system, the gastrointestinal system, and the metabolic system. 25% of them have indications with genetic conditions. So a quarter of these are coming with molecular genetic biomarkers. We heard a lot about biomarkers earlier today. Half of them can be used in pediatric indications. Quite a few rare diseases do manifest early on in a patient's life. Around a third are administered through some sort of complex mechanism, whether that's infusion or specialized injection. Why this matters is around the impact it has on healthcare delivery. Infusions tend to be highly resource intensive, similar with even more complex mechanisms of delivery. Cell and gene therapy is a very good example of highly complex drug delivery that has a real implication on the healthcare system. Within those, half are either biologics, blood products, or next generation therapeutics. So this includes gene therapy, cell therapy, RNA-based therapies. So the net of what we found is there's a lot of promise. 1,100 candidates in the pipeline today. They come with very complex or very innovative designs. They hold a lot of promise, but with that complexity comes challenges in terms of getting the right therapy to the right patient. Overall, when you look at failure rates within clinical trials, we expect around 200 drugs for rare diseases to reach the Canadian marketplace within the next 10 years. I keep pressing the wrong button. There we go. So what does that mean? So we kind of looked at that list and then compared against what it would take to deliver that medication to the right patient at the right time, to look at, from a healthcare system perspective, where are the barriers, potential barriers, and what can be done about them, and which is really the subject of today's conversation. A few key themes came out of the report. First is the need for education. Rare diseases are rare. Most physicians have not seen them. Most patients are not aware of them. So education plays a major role in identifying the right patient. The role of genetic testing, which we heard a lot earlier today, a lot of these conditions are genetically linked, and the earlier we can get testing and the more expansive the testing, the easier it will be to identify these patients earlier in their disease state, which is kind of paired with the next one, delayed diagnosis and access challenges. It's not uncommon in a rare disease patient's story to hear about years, if not decades, of going from one specialist to another with seemingly disparate or very unlinked symptomology, only to much later come to the right conclusion around diagnosis and prognosis. So diagnosis and that access to the right specialist is critical, as well as the infrastructure challenges we mentioned around these delivering these complex medications. These complex medications are coming with limited clinical evidence by nature of the fact that these are rare patients, as well as potentially higher costs. A lot of them are curative in nature. So it comes with access challenges and funding challenges to ensure that the right patient gets the right medication. And then finally, but certainly not least, patient engagement and partnership. Patients play a critical role as they are often the holders of important pieces of information around these conditions that we can only learn by engagement with patients. So with that, kind of hopefully what we've set up here is that there's a lot of promise in the next 10 years in terms of therapies coming to market, treating patients that have previously had no therapeutic options. It comes with a lot of challenges in terms of getting the right therapy to the right patient at the right time. And we have several stakeholders that have a different view or lens to how we improve our health system readiness for patients for rare disease. So with that, maybe I'll start the questions to Whitney. You've been working in patient advocacy for, I have here, over 15 years, from across multiple rare disease patient topics. Maybe the question for you is, how do we better support patients with rare disease? Maybe open it up with maybe a
really specific question.
Just to get your initial thoughts.
Okay. Well, first of all, thanks, Brad, and thanks to Takeda for this session. It's really nice to be back here at CAPT. So I'm Whitney. I'm not as a patient myself here. I'm here representing Immunity Canada as well as the Network for Rare Blood Disorder Organizations. We are representing a group of thousands of patients over 22 disease states that use plasma and blood-based blood-derived medicines and plasma-derived medicines in Canada. These are typically medications and treatments that are not on provincial and territorial formularies and are on the Canadian Blood Services formulary. And we are now seeing through the Drugs for Rare Diseases and through the rare disease pipeline that these patient demographics are now seeing drugs come in through the provinces and territories, which is not having done in the past. And we've also noted that this patient population has been left out currently of the consultations for the Drugs for Rare Disease strategy. In July, we released a joint report, Immunity Canada and the NRBDO released a joint report about reframing the DRD strategy to include these patient demographics. With that, I'll go into, I think what we'll hear over and over, and we've been hearing over and over, and we'll hear in this room too, that we hear about the need for data. We know what our weakness is. Yes, there's a lack of funding. There's a lack of structuralization and a lack of collaboration, a lack of consistency across the provinces. How do we make this all work together? From a patient perspective, what we see, and we will hear obviously too in the DRD strategy, we know we want data, we want earlier diagnosis, and we know that there are these things coming. So how do we use what we have to make it work better for the patient? So I think what we want and what we can, the patient organizations and the patients can help with is humanization. That's what we're here for really, and democratization. How can we work together and collaboratively? And we hear constantly from a patient perspective, patient engagement, stakeholder engagement, without actually having genuine patient engagement. And I think that is something that we're not being used to the best of our ability. For example, there are good things being done here. Inform Rare Kids Can, the CBA strategic initiatives for the DRD, there are good things happening in the DRD space where we are collecting that data, where we are working collaboratively, where we are creating genuine patient engagement and research. And I think these need to be used and also structuralized in a way to create equity across Canada if we can collaborate more. But that engagement with the patient organizations needs to be genuine, and they want it to be genuine. They don't want to just come in at the end for you to sign a form saying that they were there, or to hear them speak and you hear their story and go, wow, that's really sad, that's a really hard journey you've had. Oh, that's what that disease state is like? Oh, okay. And then you walk away and develop a drug with the physician or with the researcher. They actually need to be there from the beginning to make this an actual successful process for patient care. So the democratization and the humanization of this whole process is what's needed to make this a successful drugs for rare disease strategy in Canada. As well as, you mentioned education in the report. I think that's so important, medical education of healthcare, but we also need education from the top down, education from policy, from government, all the way down to the patient level. So it needs to be, that education needs to continue. Because we have, we have physicians who don't know anything, but we also have government who doesn't know anything, and we have patients who don't know anything about their own diseases. So that education needs to be throughout. I was just in Europe at a conference, and I was talking to a physician who was from Madrid about a clinical trial, and he said, oh, I don't know about that clinical trial. And then he came back to me the next day going, oh my goodness, I have patients who should be on this clinical trial. Why didn't I know about it? And then you meet patients who say, I didn't know that was my disease. I didn't know anything about it. My physician didn't give me any information about it or talk to me about it in a way that I could understand. I didn't know that drug was available. I didn't know that drug was coming down the pipeline. I didn't know that newborn screening was available. So I think good things are being done, but the patient organizations need to be used appropriately and genuinely. So I know it's a really long-winded, but you asked me to be here, so it's your fault.
Well, thank you. No, that was, that was it. I don't think it was long, and I think those were all key points that we certainly need to hear and be aware of. Maybe, Dr. Dowling, Whitney mentioned physician education, but maybe I'll toss it over to you next, which is from a clinician perspective. What do you see as the greatest challenge, given the number of drugs for rare diseases that are on their way, in terms of how physicians care for patients?
Yeah, thanks. I don't know if I could point to one specific greatest challenge, because I think we have challenges across multiple areas. It's interesting to see the number that was quoted in the report of 200 plus drugs, because I would say one of the big barriers we face is even getting the drugs to Canada in the first place. Right now there are multiple drugs approved in other jurisdictions that are really not even in the pipeline in terms of approaching Health Canada or looking for a funding envelope. So I think I see that number, but then I worry about the other part, which is even just getting any of these drugs, and figuring out, nationally how it is that we can be more attractive of companies to come, but then also sort of conversely figuring out models to work with both the industry, but also for more of our own developed products. The diagnostics piece that you brought up, I think, is an interesting challenge, and I guess as an anecdote from the education perspective, and not to be maybe glass half empty about thinking about medical education. So probably many of you are familiar with Duchenne muscular dystrophy, which is one of the more common rare diseases, and probably of those 200 drugs that you pointed out, many of them are actually for DMD, because it's a very active clinical space. About 20 years ago, there was a big educational effort across the world to try to improve the diagnostic delay. Because at the time, patients presented about age 2 years and are diagnosed at about age 4.5. And 20 years later, we're basically at the same two numbers, which I think speaks to the challenge of education in that regard. And maybe one of the things we need to be thinking about is how we change the paradigm of that. I'm an ultra specialist, and I can appreciate the small rare diseases I deal with. I have great empathy for my family practitioners and general pediatricians, because they have to think about everything. And then also be able to somehow identify a needle within the full haystack. And I think the most effective diagnostic strategies have really related to when the commitment for screening efforts have occurred. So I think, another disease I take care of is SMA, and that's been, I think, one of our big national successes in terms of both treatment, but then also diagnostics and the rapid rollout of newborn screening. But even within that, I think highlights some of the interesting challenges because Ontario, for example, approved newborn screening for SMA, I think about 2 years ago, and we just now had the last province come on board for that, even though the clinical benefit of it is so dramatic in terms of early diagnosis and treatment. And so how is it that something so obvious to have on the newborn screen took so long to roll out? So I think that speaks to an additional challenge. And then I think SMA highlights another one as well, is that even just for this one rare disease, which has now 3 therapies, the amount of mobilizations taken to actually administer these therapies at the hospital level has been quite big, and that's just one drug. So if we have 200 more drugs coming, how are the hospital systems going to handle that? Particularly if the idea is that most of these drugs might be administered at ultra-specialized hospitals like Sick Kids. And so how do we make sure that patients can access that, but that also the hospital itself can handle that increasing burden? So I think those are some of the few things I would highlight. I guess the fourth thing would be we have so much opportunity to be creative and paradigm shifting in Canada. And at the same time, I think it's been a traditionally conservative place for approaching drug development. From the industry point of view for developing ultra rare therapies, either the drugs that come out are so incredibly expensive, it's hard to figure out how to access them. And then number 2 is, well, many of the diseases, really there isn't an industry push to develop drugs. So how do we think about this from a national level? Could we do more creative planning of how to make and implement drugs?
Thanks, Dr. Dowling, and welcome. As Dr. Mandavani already let everybody know, you'd be crashing our party. So, ladies and gentlemen, welcome Dr. Mandavani as well to the panel. I know you probably are just running, so I'll let you settle down for a few minutes before I throw a tough question your way. I'll switch next to Christine. You have a very unique perspective. You've seen the inner workings within our Ministry of Health. From your experience, what have you seen has been the biggest challenge? Maybe something that folks outside of the system aren't particularly aware of, but I won't limit your answer to that. From your health ministry perspective, what do you see as the biggest challenges?
Well, thank you for the question. It's again a big question, but good morning, everyone. I'm really happy to join you today for this session. But before I get into that, I'd really just like to comment on what Whitney was saying about the need for the patient voice in a humanization and democratization of the patient voice, because during my time as patient ombudsman, before I got back into politics again, that was something that we were really trying to raise in a real way and not just a tick off the box, yes, the patient was there and they had something to say, because the patient voice is so important. Nothing about you without you is part of it, but it also means that you're going to have a better design, you're going to have a better outcome, because you're going to be building something for people that know what they need. And you really need to have that patient voice in all of the decisions that you make in every respect. So thank you for bringing that up. It is really, really important. But just wearing my government lens, I would say, I think what you really need for rare diseases is somebody to take up the cause, because it's seen as something that, well, it's a scattering of so many rare diseases, and how can we possibly deal with that? But you need to, because it's a lot of people taken together. And you know that you've got another 200 plus rare disease drugs coming on the market in the next 10 years. So it comes down to, first of all, I think leadership, both internally within the Ontario government, speaking to other cabinet ministers as the health minister to talk about the need to develop a strategy here, and then working with the other provinces and territories in the federal government to come to some common conclusions on what's important for health technology assessments, what do you need to be collecting in the registries that you're not collecting right now, to really be able to form a system that's going to be relevant to the people that need that help. And then, of course, when you start talking about those issues, and you'll hear this a lot from me, is money. because right now health is the biggest ministry in government, and you can't keep growing it and throwing more money at it, because then you start taking away from other things, education, roads and bridges and infrastructure and justice and everything else. So you need to start thinking about it in a better way, in a different way. And what is going to make a difference to be able to carve out that niche, to be able to have the money to pay for those drugs for rare diseases, many of which cost more than $100,000 per patient per year. And in addition, we're moving more towards personalized medicine generally. And so you have to look at how can you continue to deliver good medical care for the people of Ontario in this case, and not break the government bank. So you need to look at being more innovative. How do you do that? How do you look at ways, not to save money on drugs, but how do you look at delivering medical services, looking at building hospitals, for example? Do we still need to keep building them same way, or should we be delivering some of them in clinics? I mean, there's lots of different discussions that are going on out there, but there has to be a way found through discussion to make sure that we can find the money to pay for drugs for rare diseases and other personalized medications that are coming our way. So I think there is a big challenge there, but I think that with the announcement by the federal government on developing the strategy overall for rare diseases, maybe that can be a topic for discussion about how do you educate medical professionals, not just in medical school, but on an ongoing basis. Do you have regular updates for people so that people don't have to go through years of testing and going from doctor to doctor to doctor to find out what's wrong with them, which takes its toll both mentally and physically on them. So I think we need to be innovative, we need to be collaborative, both internally and externally.
Thank you for that. Before I then ask Dr. Mamdani a similar question around the challenges from a research perspective, I'm just going to prompt the audience for a second. Get ready. Following this, I'd love to have questions as we go. Keep this fluid and dynamic. So if you start thinking about questions, feel free at any point. The microphones are in the room to ask from a variety of perspectives. We've got some great experts here today. With that, though, Dr. Mamdani, you've done a lot of things in rare disease from a real-world evidence and research perspective, from an AI perspective. Maybe to start, kind of, what are some of the challenges that rare disease presents from a research perspective, from a data perspective?
Everyone can hear me? Fantastic. I'm so sorry I was late this morning. I kind of view things from the kind of research math nerd lens, I guess you could say. And I view it from a clinical perspective as well. I think it's relevant for all of healthcare, but particularly for rare diseases, and I do not claim to be a rare disease expert at all, but I have seen patients with rare diseases and such. I don't practice clinically anymore, but oftentimes we look at a drug and we say it doesn't work as well as it should, or it's only effective for X or Y segments of the population. And we're only going to reimburse for what it works for. So, for example, these risk-sharing agreements and such that come about. But we don't really typically go back to the framework around, is it the drug or is it our process that's getting it wrong? And what do I mean by process? As clinicians, what do we do typically? We diagnose, we prognose, we treat, we communicate, and I would hope that we would help the patient cope. Right? So those are probably the 5 things. But if we look at diagnosis, how drugs work is it's really a statistical play. A lot of these pharmacological compounds will actually work if you hit the right receptor. But we have to be really honest with ourselves and say, do we understand disease? Do we diagnose it well? And I would argue, oftentimes we don't, right? How often do we misdiagnose rare diseases? All the time. Well, of course a drug's not going to work if you misdiagnose it, because you didn't get the disease right. 1/3 of patients who are diagnosed with asthma actually don't have asthma, right? Over half of patients diagnosed with schizophrenia actually don't have schizophrenia. Then, of course, there's prognosis and treatment. if we can't get the prognosis right, and study after study after study has shown how poor we are at prognosis, how are we going to optimally manage? So we have to be better at that end as well. And of course, treatment. This is why we struggle with treatments, because oftentimes we don't even understand the disease well enough. And so sometimes it's maybe shifting the focus a little bit on how we actually diagnose, prognose, and treat. The drugs are fine, but we got to get the other game right as well. So there's a lot of areas that we could improve upon.
Thank you very much for that. So kind of the next, I think we've kind of talked about a lot of different challenges. It sounds like there's a lot of challenges, which there are, but it's not insurmountable challenges. So I'd like to now kind of turn our focus on this discussion to solutions. You know, and it's hard to talk solutions if you don't agree or at least talk about the challenges. So, and in Canada, we love to talk about all the challenges. But I do want to give the audience a sense of kind of what are we doing to help solve these challenges. So the next kind of round of questioning will be around potential solutions. Again, if the audience would like to ask questions, feel free at any point now to stand up and ask. That said, in terms of potential solutions, maybe I'll start back, Whitney, with yourself. So we heard earlier actually today around the importance of screening, and you've talked about it a bit as well. Can you tell us a bit more about the work that you're doing around newborn screening and how you see that potentially impacting patients in the future?
Yeah, absolutely. Jim mentioned newborn screening for SMA as well. So in 2021, 2020, so our organization, we've been really busy advocating for SCID newborn screening across the country for years. We started in 2014. Ontario was the first province, but as an organization, we were advocating for SCID newborn screening. And at the NRBDO, we saw other organizations doing their own advocacy work for newborn screening. So in 2021, my colleague Jennifer at NRBDO and I looked at the issues that we're facing and wondered how we could get to more equitable access to newborn screening for rare diseases in Canada. And we wrote a report in 2022 with certain recommendations about achieving that equity in newborn screening. And we thought it would fit nicely with the DRD. And sure enough, thanks to CDA, they came to us and said, yeah, you know what, you made a recommendation for one of those recommendations was for a expert panel, an advisory panel looking at guidelines for a national framework for newborn screening in Canada. And I'm lucky enough right now to be a co-chair of a proof of concept for creating national guidance for newborn screening in Canada. We have until March, but some of you may have seen, we hosted a webinar. We asked for public consultation, which just closed in September. And we're now reviewing that feedback, and the panel will look at that as well. And we'll host another webinar, I believe, before March, in March, to talk about what we've heard and what we're doing. But the goal really is to create national guidelines on newborn screening. These will be guidance to the provincial and territorial newborn screening programs with a standard number of disease states to screen. It will not be saying to the provinces and territories, this is what you have to screen for, but again, kind of like the NACI recommendations on screening. And the panels will be reviewed periodically, but so we are doing that standard nomination process, standard review process. But it's been wonderful, I think, to be able to look at how can we, as I was saying, there's a lack of standardization across Canada, which leads to inequity in the rare disease space. And something like the newborn screening program that we've now looking at, and this panel is proof of concept, we can implement that across the board for other things as well, if it works, of course. I think it is, in my personal experience. But I think, and with the patient registries, it's something similar too. and the drugs coming down the pipeline. You know, where are we missing? Where are the gaps that need to be filled for the provinces? If one province has more funding and the other one doesn't, or they don't have those resources, or their labs are, where do we need to get those standards up to across the country? Or how can we be more efficient? Do we need to have centers of excellence in one province that does that test and the other province doesn't? Genetic screening is something that we know is a future consideration we need to look at. So, I mean, I know that there is a lack of standardization. Medical data across the provinces is completely different, and how can we look at standardizing that? I think that would be a huge help. And I know we need solutions for this, but I don't think, using newborn screening as an example, it can be done. We can't just say, oh, well, that's the way it's done, so too bad that patient in Newfoundland doesn't get screened for SCID, but it can in BC, or too bad that patient in BC gets that drug, but they don't get it in Alberta. We can't have that. It doesn't work. We need to look at, especially with what we know is coming down the pipeline, and CDA also with their strategic initiative has a pipeline repository and seeing what's coming down, and the goal is to have it where you can look from the registries to the pipeline to the screening. We know what's coming. Let's all work together. I think collaboration is going to be key here to be able to find those solutions. And like Christine said, we need to change. This is all new. I mean, I know coming down the pipeline we can see, but drugs will be coming that we can't even imagine, new categories of drugs that we can't imagine. We need to change the way we do healthcare. We need to change the way we think about healthcare. I think that's going to be important.
Dr. Delling, I think you have thoughts on screening as well. Would you like to share yours?
Yeah, I'm actually, it's interesting also to, I think, to hear all four of us pinpoint different things that I think maybe others, like I hear about less funding or not increasing budget for healthcare, and I think, wow, our hospital really needs more money from the province to administer these support services. So I think there's a lot of interesting competing challenges. And I guess I would say, well, if we're not putting the money towards our own health, then what are we doing? And I also hear about the diagnostics part. It's very interesting because on one hand, Canada is actually one of the innovators in terms of genetic diagnostics. Like, we're one of the best countries in the world in terms of the technology and the knowledge base. And you think about initiatives like Care for Rare, which has been a pioneer initiative across the world in terms of how you identify and diagnose patients with rare and ultra-rare disease. I guess the challenge then is how does it, as you say, democratize outside of the silos of places like CHEO and Sick Kids and the other places that I think are really quite adept at the diagnostics, and perhaps what you're saying, it's really how do you get to the specialists if that's the model. And I think it does then circle to the question of if that's an insurmountable thing, how much can we accomplish with screening? And I was curious because of the screening policy, one of the things that's I find a bit, I don't know if frustrating is the right word, but how it's a suggestion and not a requirement. And that I feel like there should be minimal requirements that every province should have to adhere to from standards, at the same time not limiting innovation. So if Ontario, for example, wants to pilot whole genome sequencing as a newborn screen, well, it shouldn't be restricted because of a national policy. But on the other hand, there's certain, I think, diseases that every province should be screening for. And so I don't know how one, as not a government person, how you compel different jurisdictions to do things in a harmonized way, because we do have this disparity, and I think that it comes up in multiple places, not just, I hear this from industry in terms of, well, why don't you bring your drug to Canada? Well, I can't guarantee that every province is going to pay for it. And so if it's a rare disease indication where we're at the margin of profitability and you drop off Alberta, then we can't actually sustain it. I don't know how true that is, but that's the argument I've heard. And then you think about a patient who could get a therapy in one province but not the other, and how does that be overcome? And then for diseases, when you're talking about with the ultra-rare setting where there might be 10 patients in Canada, if we can't look at them across all the provinces together, that really hinders us. And perhaps that's to talk about solutions. One of the solutions are hopefully coming from some of the government rare disease policy. So the funding of the Rare Kids Can initiative, which I think is really designed to help overcome some of these disparities and differences to harmonize at least the clinical trial piece across all the different provinces. So I think there's some work going on as well. And I guess the other one to mention is the Canadian Rare Disease Network, which is in its infancy, but I think is also meant to overcome some of the educational or diagnostic accessibility barriers to try to figure out how we can have rapid and excellent diagnostics across the country.
And Christine, on that note, to tie all of these subjects together around screening, you've mentioned it before, kind of, in the Ministry of Health, you've got to manage budgets and cost is a key issue. Presumably with screening, there's probably instances where earlier diagnosis leads to better outcomes or better outcomes for money. Does the province look at that? Is there an assessment of the cost benefit of adding new screening? Is that part of the thought process? Do you know?
Well, yes, absolutely. It's something that you take a look at because, of course, you want to know that you're going to have a healthy population, and it starts with infants, so you want to make sure that you can do that screening to anticipate if there's going to be any issues and then to deal with them from an early stage. Early diagnosis is always better. So I think you do need to pay attention to that. Do you always pay attention to that? Well, sometimes there's other things that have to be taken into consideration, but during my time there, I always tried to look at what's the cost of a new medication, for example, for a rare disease. But then on the other hand, nothing is free. If you don't do something with bearing that cost, what are the other costs going to be down the line in terms of hospitalizations, in terms of interactions that are going to have to go on with specialists, in terms of deaths, which you can't even quantify. So you have to take that into consideration when making those decisions if you're trying to make a good decision for the entire population. That said, there is only so much money that you can spend on health, because I can tell you when we were dealing with COVID, how lucky was I to be a minister during COVID. But I was most frequent flyer at Treasury Board asking for money, and the questions got tougher and tougher because everybody else was saying, well, I need more money for this, that, or whatever. And I was the one that had to argue for health based on what the Chief Medical Officer of Health and others were telling me that we needed to do to protect people. So money does have to come into the equation, but I always tried to look at it on the basis of, okay, you're spending this money, but then what benefit is that going to bring? And how is that going to help people be healthy and maintain their health during the course of their whole life?
Thank you. Yeah. And then maybe kind of finally on this subject, before I take a question from the audience, Dr. Mamdani, I know you've done a lot of work in AI, and a lot of it focused on improving efficiency. What's your perspective around screening? We've heard it's essential, we heard it's costly. Kind of, can you give us your thoughts?
Yeah, sure. Maybe slightly long-winded, but so our hospital is heavy into AI, and we have a whole team that deploys AI solutions. We've deployed over 50 AI solutions in our hospital. And the way we approach things, I'll tell you a quick story around one of the solutions and how it then relates to screening. So we have this one thing that monitors all of our patients. So it's all automated. It's been running for almost 4 years now, where it tracks all of our patients and it monitors them every hour on the hour. So this AI is running every hour, taking in between 150 to 170 different parameters typically. Lab values, vital signs, demographics, and such. And what the algorithm does is it predicts if you're going to die or go to the ICU in the next 48 hours. And as soon as it reaches a high-risk threshold, it's all automated, it pages the medical team. And the medical team, our protocol has to come and see the patient within 1 hour being paged. And there's all sorts of care pathways. Do you look for signs of sepsis, initiate antibiotics? Do you increase monitoring to every 1 or 2 hours? We just published a paper a few weeks ago in the Canadian Medical Association Journal showing a 26% reduction in unexpected mortality, which is wonderful, right? So these things are actually helping us save lives. So then the analogy was, well, can you not screen patients for diagnoses we miss all the time? Yeah. So we've got something called Reward AI, very early stages. The concept is very simple. This thing runs every 10 minutes. So as soon as new information comes in, it's looking for things that we commonly miss, and it's flagging them to say, hey, could you kind of look into this because we know you miss it all the time. We then extend it to rare diseases. There's a brilliant immunologist at our hospital who's very passionate about one disease in particular, several, but one in particular, hereditary angioedema. He says this thing is associated with incredibly poor outcomes, very, very difficult to catch for a lot of clinicians. How do we screen these? And we said, this is awesome, we should do this. And then he says, but we only see a couple of these every year. So can you actually have automated systems that are efficient, that are effective in monitoring patients? Certainly we can at our hospital. There's no reason why we can't at other hospitals as long as we're digital. So you can imagine a province that actually uses things like AI to routinely and rapidly screen patients in real time for conditions. But to get at rare diseases, I think to the point that was made, we all have to play together, because a couple of cases a year, we're not going to be able to build anything effective. But if we actually work together as a network, as a community, now we have many more cases. I think the power of these technologies could be incredible at screening.
Sorry, so I do think that's right. I think part of it is, you know, we're all talking about earlier diagnosis and how do we change the diagnostic journey for patients. I think there will be enhancements in AI and changes in AI that will make a difference. So we need to think about beyond diagnosis as well when it comes to rare diseases. I was just at a conference in Europe where someone presented about they're creating personas in Paris. So you put in an HAE persona and then you screen 20,000 patients. And if they come up with similar symptoms, that patient has HAE. If you do the same for SMA, they're doing this pilot already. So that work is being done. So I think we need to think beyond diagnosis, to think about the treatments, how we're better treating and working together, and as well the training and et cetera, and the education pieces. And when it comes to genetics, are we ready? Are we ready in Canada, that piece of provincial and equity across the provinces? Because that treatment, that diagnosis piece will be changing rapidly over the next 10 years, well, even maybe 5. It's going to be changing.
Thank you. I think we'll take a question from the audience.
Thanks, Brad. Judy Glennie, I'm going to put my former hat as Associate Director of the Ontario Drug Program on for this question, particularly targeted to Christine, but others to dive in. When we start thinking about the fact that we've got this pipeline of at least 200 products, and many of those, my bet is, are cell and gene therapies, which are kind of one and done kinds of products similar to Zolgensma and SMA. And we saw in our keynote presentation sort of the incredible difference that the availability of that product has had in the trajectory of the disease, and of that particular disease in children. And one of the challenges I know from my days in government is the cost issue, and really the inability of the whole of government to look at drugs beyond being a line item and look at drugs as being an investment. And I know, Christine, you looked at sort of the offsets, et cetera, but I mean, I've always wondered why in government we couldn't, we invest in capital projects over 5 to 10 years all the time in government and look at the ROI. Why are we not, what can we do in engaging with government to get them to start thinking about especially cell and gene therapies in the same way? Because it is an investment. Yes, it's high upfront cost, and there are a number of models around the world, mortgage-based models, et cetera, for funding these things, but the real barrier, frankly, I think, is getting government to think differently about the funding of products, and that there are an awful lot of offsets well beyond the health system. I mean, this child with SMA is now walking fairly independently, will have a very different life than a child that was born with SMA 10 years ago. So, I mean, how do we get government to start thinking differently?
It's a great question. I think it goes back to my earlier comments about we need to have leadership on this file. We have to have leadership from the provinces as well as from the federal government, and start looking at this in a different way, to look at different funding models, look at it as an investment, and make sure that we can start looking towards the future, because this is coming at us from all areas, not just from drugs for rare diseases, but personalization of medication generally, which is a wonderful thing, but government's just not ready for it. And I think that there are ways that that can be discussed without creating anything new. There is a federal, provincial, territorial health ministers conference that we met several times a month during the entire time of COVID, but that happens on a regular basis. That would be an opportunity to start speaking about this issue, because I know that all provincial and territorial budgets are struggling with this. They need to talk about how are we going to, first of all, standardize the information in the registries so that we get the information we need in the real world evidence to be able to get through the health technology assessments and get things onto the market, and then how to pay for them and look at different models for it. So the ministers of health can get together to do that, as well as the deputy ministers have a regular basis for those conversations as well. So I think the conversations and that collaboration and looking at things in that different way is really important if we're going to get anywhere. So the collaboration and partnership, I think we've all talked about that this morning, but I think we really need to get to it in a real way so that the people that have these rare diseases can get the help that they need in a timely basis.
Any other thoughts on, I think it's a really interesting but challenging problem, which is innovative models for funding, whether that's outcomes-based agreements, coverage with evidence, or other innovative models. Are there any other thoughts from the panel on that?
So I'm going to say something that's probably unpopular. Can we have innovative approaches to drug discovery and development? Because, quite frankly, I feel for the government in many cases where it's not going to make economic sense to fund a drug. You're going to have more value fixing up roads and such and saving lives that way. So where are you going to put your dollars? When we do cost-effectiveness analyses and ICERs and such, there are things from an economics perspective that should not be funded, and those are difficult decisions. So one is, how much money does a system have to put into healthcare, but how much money are we asking the health system to put into healthcare? And I'm not sure how much has been done to leverage technologies and innovations to actually make the drug development process more efficient and cheaper, and therefore reduce the cost of drug development. That's something else that we don't talk about very much.
Yeah, just to follow on, I thought the question about thinking forward on how to invest money, and your point, I would say the SMA, the Zolgensma example, is a wonderful example of success, but it also, I think, could be quite exceptional. I'm not sure how many gene therapies are going to have the magnitude of impact of death by age 18 months versus walking and running normally. So that, I mean, and that drug was several $1 million. So what if that delta is much smaller and now the drug is $4 million? And I think the good example right now is the recently FDA-approved drug, gene therapy for Duchenne muscular dystrophy, where the margin of therapeutic benefit is quite narrow. So to your point, perhaps we should be thinking instead, we can make these drugs. I mean, these are things that there's Canadian expertise to make gene therapy. It's not, not rocket science. And maybe that's where we need to be thinking about putting the money, is not in waiting for company X to bring us another gene therapy for $5 million, but we could make 10, 20 gene therapies for that same amount of money if it was really done in a national initiative, and then really increases the equitability and potential access to therapy.
I agree with Jim. I think, look at CAR T cells and what we've done in Canada with CAR T. I think if we invest in the infrastructure for gene therapies, there's also the concern with certain gene therapies that have been proved not to be profitable in other countries. So the industry is giving those licenses to academic centers. And how do we ensure, even if it's not a sponsored therapy anymore, but it's owned by an academic center, how do we ensure the patients still receive those therapies across the country? So those are things that I think if we built that infrastructure in Canada to create and, you know, be able to administer those gene therapies, that would be a worthwhile investment going forward.
So I realize we're coming up on time. I think we could have this conversation for another hour, but I won't keep people from their lunch. But maybe what I would do is I'd like to ask each of you. Oh, sorry, we have another question. Please, with our final question.
The question is really more about when we look at, I wonder if some of it's about even the accuracy of not the diagnostic processes, but the way that we approach even science. So I'm just thinking even from the AI point of view, something as simple as putting race in an equation when it's inappropriate to put in there because we just used a racist approach to include it in the first place because it was inequity related to health that led to an outcome. Like if they give ACE inhibitors, for example, and avoid Muslim people who are black. I think that we are not very good at creating equity within our modeling that leads to potentially inequitable treatment of patients because of the knowledge base. Like I know that right now we're working on guidelines to improve diagnosis of UTIs, and like even that simple thing, like you'd be surprised how much that is botched often. So one thing that I wonder about is how do we even start there? Because like I work in a sex and gender space in infectious disease, and that's like a huge issue, but this is even more problematic. So like you have something rare, like your confidence intervals are going to be so what do you do? How do you start there, especially in the AI space? Thank you.
Yeah, maybe I'll comment. It's really hard. I think I'll give you an example. So this thing that I mentioned that predicts if somebody's going to die or go to the ICU, we did 27 bias assessments of 27 different parameters, because we wanted to show that the algorithm was robust using AI among males versus females, older versus younger, sick versus not so sick. We have data to do that. We don't have race data. There's not a single hospital in Canada that collects race data well. So one could argue, well, how would you deploy an algorithm without doing something as basic as a race assessment in terms of bias? And I think we have to make some ethical decisions, because it's going to be virtually impossible for an ultra-rare condition to do extensive bias and race assessments and such. Because, you know, I can sit here and tell you we did 27 bias assessments. Some academic out there will say, you should have done 40. And I'll look back and saying, what about 50? Maybe 60, 100? Nobody says what the right number is. And the ethical consideration here is, when I tell people we haven't done race assessments because we don't have race data, the pushback is, well, you shouldn't have deployed the algorithm. And of course, my pushback is, you're right. Let's take the algorithm down. Let's wait for 10, 20 years until we get our act together to collect race data, and let 26% more people die every year. Is that ethical? So I think especially in rare conditions, it becomes even more challenging, right? Because you're not going to have the level of diversity. Now, what we have in Toronto is pretty unique. We have the most multicultural city in the world. So when we develop algorithms, we're fairly confident they're going to be very robust. Those 27 parameters, every single one of them was just fantastic. Is it fair to say it's probably okay for others as well? Yeah, I think so. But we don't know, and we will never know. But we have to make some judgment calls as a society in terms of what we're willing to accept. And sometimes those judgment calls are very tough to make.
Okay. Well, I think that was probably a good way to conclude this session. Thank you so much to my panelists for sharing their expertise today. Thank you for the opportunity to present to you. So thank you. And I think it's lunchtime.
All right, thank you to all of our morning panelists, moderators, and all the questions. Lunch is just right outside. Please be back for 12:45 for the next panel. All right, so hope everyone enjoyed lunch, and you don't want to sleep in on this panel session. I know there's been a lot of interest for this one. So the title for this session is Filling the Gap, the Case for a Policy Observatory to Serve the Canadian Rare Disease Policy Ecosystem, and I'll hand it off to Judy Glennie.
Thanks very much, Julia. Good afternoon. So let's make sure we don't get that post-lunch snooze in. We've got lots of really exciting things, I think, to talk about. We're going to continue the day's discussions related to rare diseases, building on our keynote speakers' comments this morning, as well as the Health Systems Readiness panel that we had right before lunch. And as Brad had noted, really trying to move ourselves towards solutions for, and in this case, making the case for a policy-focused entity to support the evolution of our rare disease ecosystem in Canada. Oops. All right, I should have tested that. Now, before we dive in, I'd like to reiterate our thanks for the land that on which we gather, which is located on the traditional territories of the Mississauga, Haudenosaunee, and Anishinaabe nations. This is a particular picture is Shared Path Discovery Walk, which is on the Humber River in the Toronto area, in the GTA, that connects an ancient Aboriginal portage route to modern roads and railways. And so given what we're talking about today in terms of frameworks for policies to support the rare disease community, we take inspiration from this and in the development of a shared path that necessitates also shared responsibility for the work that we do and the outcomes that we achieve. On that note, there we go. I just wanted to also, in the spirit of transparency, to share our disclosures for the session and the participants in the session today, and our objectives for today. What we're going to do is provide a bit of an overview of specifically the rare disease policy ecosystem, building on earlier comments, and we're going to focus in on the discussion of the development of an entity to identify and fill policy development gaps to ensure informed decision-making as it relates to the rare disease ecosystem. And we're going to hear perspectives from patients, from clinicians and policymakers as we do that. I'm very pleased to have our esteemed panel members with us here today. Rebecca Marsh, who's with the Institute for Health Economics in Edmonton, Gail Ouellette, who is the co-chair of Health Canada's Implementation Advisory Group for the National Strategy for Drugs for Rare Diseases, Dr. Hernan Gonoratsky, who's from Sick Children's Hospital, and Marcel Saulnier, who is formerly Associate ADM at Strategic Policy Branch at Health Canada and was instrumental in what we now see as our rare disease strategy at the national level. In terms of what we're going to cover today, as I said, we're going to talk a little bit about the rare disease ecosystem and just to get a common grounding, talk about the policy observatory, and then our panel members are going to give their thoughts on this policy observatory and how it might bring value to the Canadian rare disease ecosystem. And then we'll have some opportunity for Q&A from the audience as well. So I'm going to start with some background. Very busy slide. I'm not going to walk through this, believe it's for effect. We've been actively dealing with rare disease policy issues really since the time of the Fabry Initiative, which was in the mid-2000s. But there's been a particular uptick in rare disease policy activities over the last 10 years or so, starting with the CORD Rare Disease Strategy release in May of 2015, and then the most recent work that you heard about from Takeda earlier this morning in terms of their system readiness report. So as you can see from this slide, there are academic groups, there are patient groups, there are government bodies, there are HTA bodies, and individual companies that are very much involved in looking at or talking about or identifying issues related to rare disease policy. But there really hasn't been a sustained effort in moving forward with rare disease policies. Even some of the provincially driven activities kind of fizzled gradually over time and never came to fruition. But as you all know, things have been kick-started with the Health Canada's rare disease strategy. I'm not going to go into that in depth. And Quebec's plan of action, which was introduced shortly after the Health Canada's rare disease strategy, which is based on Quebec's own strategy that was released in 2022 with specific action plan and funding, et cetera, et cetera. I know I'm flying through this, but I really want us all to kind of get to the same place. So as a result of this activity, particularly over the last 10 years, but particularly the last couple of years, we now have a large number of organizations that are thinking about, talking about rare disease activities, whether it be federal, provincial governments or research groups. We heard a lot about the research activities that have been going on from a couple of our panels and keynote speakers. We've got CIHR and CIHI, all the C-suites, involved in various ways in rare disease activity. So lots of activity, lots and lots of activity. And when you look at, and we've done this analysis with a group that I work with, we've taken a look at all of these entities to try to look at how are they interconnected, either from a funding perspective or from overlap in terms of their steering committee members, et cetera, et cetera. So while there's a lot going on, there's frankly a lot of the same people who are doing this work. But we still, and again, this is for effect, not to go through each one of them. So, I mean, there's a real interest, obviously, on the part of a large number of organizations to really move this forward, which is really fabulous and very exciting. But we still have some unmet needs. I mean, despite all of these initiatives that are going on, there are no programs that are specifically targeting rare disease policy research, particularly as it relates to medication access and reimbursement policies. And we heard some examples of policy gaps during the sessions earlier today, whether that be in terms of different ways of funding rare disease products, et cetera, et cetera. So the solution is, or the issue is, you know, that need for new thinking, new processes, and a really combined and concerted effort. So not one-off entities coming up with some policy ideas, but a group that collaboratively brings people together to work from different perspectives, to work on policy research and policy solutions to move the Canadian rare disease ecosystem forward in an evidence-informed manner. So what would that look like? This slide summarizes some of the activities of a policy observatory that's been running in Spain for the last few years. This particular one is sponsored by Alexion in Europe. And we've done a lot of consultations around this kind of a concept. And one thing that has become very clear is that having a pharma company sponsor something or be the key driver of a policy observatory in the Canadian environment just won't fly. So we need to find different ways of addressing that, the unmet need and finding a different kind of a model. But in this particular case, and again, I'm not going to go into the nitty-gritty details, but this particular entity in Spain does things like writing policy papers, bringing together stakeholders and doing issues identification, but also solutions development. It engages decision makers. It is also spearheaded with those decision makers legislative change, in this particular case related to newborn screening. So not all drug related, it's very much above brand, just creating that environment of a more robust policy system to underpin access. And public education is that last pillar. So some interesting work that's been going on. So our focus for today is going to be on the introduction of the concept of a Canadian Rare Disease Policy Observatory. The goal of this observatory would be to serve as an evidence support organization specific to rare disease policy, and really would provide a key tool or entity that could support long-term policy engagement and policy research and stakeholder engagement, to fill that gap around the very sporadic approach that we've been taking over the last decade or so in rare disease policy. So at this point, what I'm going to do is hand over to Rebecca, and she's going to talk some more about the observatory concept. There you go, madame. Get all my stuff.
Thank you so much, Judy, and thank you for inviting me and the Institute of Health Economics to be part of this really important discussion. So as we think about what a Canadian Rare Disease Policy Observatory could look like, we find it useful to put some parameters down and some starting points so that we can have a productive conversation. So we're not coming at this from a but what do you mean? So these are some starting thoughts that we've put together based on the international learnings that were alluded to, and collective conversations and work across multiple years to really understand the potential opportunity and solution here. But what we are doing is really inviting everyone here and from all the different communities with an interest in participating in this to then work with us later to refine these ideas, to talk about what might be missing. What else do we need to consider? So this is a journey we want to take with everyone, and these are our starting thoughts to start that conversation. So really, when we look at a vision for a policy observatory, it's really focused around the patients, their carers, the families, right? It's improved and equitable health outcomes for those impacted by rare diseases. And as Judy mentioned, it's a coordinated effort to prioritize and address some of the key policy issues that we hope can help drive towards this vision in a more timely way. And so for these first few years, we are looking to focus these conversations as well around access to and reimbursement of innovative therapies for rare diseases. So when we look at some of the objectives of the observatory, we're really looking to align policy efforts in this space. So some of the slides that we have seen and the discussions this morning, we know there's a lot of good work. We know there are a lot of people who are putting efforts into this space. And so what we want to be able to do is be as efficient as possible with this, right? To learn what's working well, scale and spread that. Stop doing, ideally, the things that we're finding aren't working in certain jurisdictions so that we're not starting everything from scratch. So the more that we can align and coordinate and be aware of best practices, the more impact that we can have. And so really looking towards advancing policy solutions in the regulatory and the reimbursement space. So if we can align, we feel that we can advance in a more timely and effective way. And in order to do that, as we know, we need to evaluate the impact of any initiatives that are currently occurring, as well as any new ones that we might want to look at. So of the initiatives and the investments, we know we need to understand, are we achieving the outcomes? What are those intended positive impacts? What are the unintended negative impacts, right? This is the what works, for whom, in what context, and why. And so I will also add that goes for the observatory itself. Its activities will also be evaluated to understand where it can provide the right value. So what kind of activities are we looking at within scope of an observatory? So policy research and analysis, generating evidence-based insights. So we've talked a lot about evidence for use for treatments, for patient care, for system transformation. Also using that evidence, how can we do that in order to develop more effective policies? And then policy strategy. So if we can understand, using research and analysis, where are we at right now? Where are the gaps? Then we can look at strategy, which, as we know, is identifying what are the possible options to do things differently. And then what are the trade-offs between those? What are the advantages and disadvantages of those options? And then we can bring current state as well as these options for moving forward into engagement and dialogue. And that's where we hope to get to the alignment and the prioritization that we mentioned earlier that we think is so important in this. And then collective learnings. How are we learning from that? How are we collecting the learnings from all of the good work that's also occurring so that we can continue to improve? And so we've pulled together some principles for consideration for the type of work done by a policy observatory, right? I mentioned the evidence-based policy. How are we using evidence as well to inform our policy decisions? systems thinking. You saw the network that Judy put up on the slide, right? We know there's a lot of good work, and we know that there's interconnections. We also know from our own work as well as talks this morning that things don't also occur just by one jurisdiction, just by one type of the healthcare system, or even one type of policy. There's healthcare policy, there's also innovation policy, and there's economic policy. So how do we analyze and identify those key policy levers that we think are going to get us moving forward? Global perspective, can we learn from Spanish Observatory and others, but also for local impact, understand how might we need to tailor that to do things for the Canadian context. Solution focused. I know we all spend a lot of time on a lot of calls talking about all of the challenges. This will also say, yes, and now what? And how do we align on what we do moving forward, especially for sustainability. So certain investments we know, research grants, we hear a lot about how these are time limited, right? So how can we set up now for sustainability of those impacts as well? And then equity, diversity, inclusion. So not only for outcomes, but also who should be involved in the policy observatory, in setting it up, in evaluating it, and in the prioritization and alignment activities that we hope to be part of this work. So we throw this up here as just a first start on these. We always find it useful to have a theory of change or a theory of impact, even a logic model, depending on what world you come from. You can see I talk a lot about evaluation. I'm also a credentialed evaluator, so I'm always trying to get that in there for the community. And so really, if we do these 4 buckets of activities that you see that we talked about, then we think we can better align on priorities and possible solutions, as well as increase and improve policy capacity at all levels. If we do those, we think that we can have improved policies in other structures that will ultimately balance and maximize the sustainable access and treatments for patients, as well as efficient and effective healthcare resource use and incentives for healthcare innovation, all leading up to and which are critical and necessary for our vision. So as with all of this work, as we know, it really involves all of the communities coming together. It involves the different disciplines. It has to be cross-sector. There has to be some way of convening and facilitating and brokering trust at the middle of these different communities of interest and of impact. And so what we've got here now is a panel that's going to start talking about, from some of these different perspectives, what do we need to consider around establishing a policy observatory? What do we have to keep in mind in order for this to be successful? What are those opportunities for setting this up and really making a difference for patients and their families impacted by rare disease?
So you've got a little bit of a sense of what a policy observatory might be and might do, and I'm sure you'll have some questions, and if you can just hold those to the Q&A, we can maybe answer some of them or just take them under advisement as this entity or this concept continues to be developed. Now what I'd like to do is to turn to our respondents and have them share their perspectives on, at the end of the day, what do they see as the value of the policy observatory, and any comments that they have or policy issues or gaps that they see the entity potentially addressing. And I would put that out to all of you in the audience as well. You know, feel free when we get to the Q&A to share your ideas on what you think, the kinds of questions you think that the policy observatory could address as the thinking on this continues to move forward. So I'm going to start with Gail and ask you to, I'll flip to your slide, but just ask you to share your thoughts and your perspectives on this idea and how it might contribute.
Yeah, well, you introduced me. I'm here mostly as a patient representative of the Regroupement Québécois des Maladies Orphelines, or the Quebec Coalition of Orphan Diseases. I'm also a health professional. I'm a genetic counselor, and I founded the organization 14 years ago. And we got as Judith said, we got a policy, a rare disease policy in Quebec in 2022, and the action plan in 2023. It was 12 years of advocacy to get the policy in 2022, and that's where I'm going to make my link with the possible policy observatory and how it can be useful. 12 years of advocacy where it was mostly us at Quebec, the patient organization, coalition of specific rare disease patient organizations who held forums and summits about rare diseases. Sometimes we had some health professionals, physicians, researchers, not very often people from the government or from policy or from economics or whatever. We also wrote our own strategy in 2015 because we weren't heard very much. So, however, at one point we did get the attention of the government, but even there, it wasn't a collaboration or a really partnership. The policy did. Before the policy, there were consultations of all the rare disease-specific organizations in Quebec and ourselves, our organization, to write up that policy. So, and the other thing I want to say is that I reviewed the last years in policy research on rare diseases, and there's not that much in Canada, and it's mostly on access to drugs. And what I'm realizing now is that the Quebec policy, it wasn't guided by policy or research. It was, there were the consultations, that's great, and we're really happy about that, but it wasn't guided by policy. Sometimes I'm a bit too negative, but I've been in the rare disease space for 25 years, so 14 of those as a patient representative, and before that in clinic, and I'm still doing clinic because our organization has the iRare Center, which is the only information support center for rare diseases in Canada, mostly for those who don't have a patient organization. So I'm not a patient, and the other thing I know is I'm not patient. So 25 years of waiting and seeing what's happening in other countries. You know, I started in 2004 seeing what was happening internationally because France was the first country to have an action plan, and then all the other European countries and things happening in the States. So anyways, I find that it's a bit late. So yes, I think I welcome very much that there would be a policy observatory. I think there has to be stakeholder discussions, as you said, and collective learning, actionable and practical solutions. So we do have an action plan in Quebec now with some solutions. And I really want to bring this patient journey I put here. This is a Eurordis graph that's been out for some time, so the important issues for patients and caregivers, parents, that we hear as health professional clinicians see every day, and we see every day with people contacting our information center, is, has to do with this journey. And so you've heard that, the diagnostic odyssey, patients and parents go from specialist to specialist. It's a long time before getting a diagnosis. And some will not have it for a long time, years and years. The average is 8 years, but some may never know what disease they have, so there's that diagnostic desert. And something I even forgot here is that, yes, so once you get a diagnosis, at least you can get some care, specific care, and some treatments. But I should have also put a yellow box there with the treatment desert, because there's, as you know, there's less than 10% of rare diseases that have treatments. So, so following this journey, I'll just bring you the main issues that parents, caregivers, patients, adult patients bring up. And we did survey. This is based on a Eurydice survey, CORD did a survey, and the surveys say the same thing across the world. So first of all, the entry is a family doctor, and what patients want is a family doctor that listens and understands and especially knows where to refer. And then that's the other thing is referring to specialists, the access, the waiting times. And you go from one to another, so the waiting times that really, prolongs the waiting time. Access to tests, genomics. So obviously there's wait times in genetic services too, and not all provinces get the same access to genomics and genetic tests. And I don't want to forget other types of testing. We're not only talking about genetic diseases. Something that they bring up a lot is coordinated care. I mean, a lot of rare diseases are complex, need multidisciplinary teams, but there's rarely, besides some examples and models that we have with neuromuscular disease and cystic fibrosis for other rare disease, there's rarely this coordinated care. The burden on the coordination is to the patients themselves and parents, and often mothers who leave their jobs to do it. Expertise. One of the main things people ask us at our information center is they want to find a doctor who knows that disease. They want expertise. And we should even have a directory of that in Canada, which we don't even have. And sometimes the expertise is outside the country. It's important to that. Now, the undiagnosed, those who are in that diagnostic desert for a long time, they need support. I mean, they're the ones that are really, there are often lots of psychosocial issues across the journey for anybody with rare disease, but especially for the undiagnosed. And there's a financial burden. And then at the end, well, access to treatment. So we really understand that health is a provincial jurisdiction, but we all know that there's not national consistency for access to treatments in Canada, and that's awful for patients to know that a drug is paid in another province and not theirs. And the other thing that we're always questioning is that there's 2 HTA bodies in Canada, and they don't always have, their scientific committee doesn't always have the same response. So yes, I think we really need something like this to have especially an effective use of our health care resources. So we all know, and Judith pointed it out in a question this morning, that there's there's Dr. Deborah Marshall who does excellent work in University of Calgary about the socioeconomic burden of rare disease. We know that, and we know that we could save so much money if this was dealt with too. Not just access to treatment, but this patient journey, and that's where patients in their healthcare system and where they live. So. And I was asked just to touch briefly on a therapeutic area. I wanted to point out something that I found interesting this year. There's a paper that was published on the CFDI, the Canadian Fabry Disease Initiative, that was published in March 2024 by Douglas and Grunbaum at York University. And I found that they had nice conclusions, really good conclusions, and that are important in the context of doing some policy research and in the context of our actual national strategy for drugs for rare disease and all the things that are happening now with real-world evidence and registries. And so some of the conclusions was that it's a political challenge to negotiate across Canada, and I think that we're with the national strategy, that's for sure. And they were saying that the role of federal government was unclear, and it's expensive in time and resources to do this kind. Actually, this was a model of risk sharing and managed access, something that patient organizations like ourselves and CORD and some clinicians really advocate for, we've been advocating for a year. And this was a model, but these were the challenges, the time and resources, and you need high-level collaboration to do this. So, So anyways, they concluded that there's a lot of social, political, economic challenges, and that's why collaboration is needed. And I think this question of sustainability, I was dealing with the lysosomal disorders, the patients with Fabry, Gaucher, Pompe, when at the beginning of the 2000s with these diseases, taking care of registries and the patients and access to treatments. And for me, it was appalling when they decided to do this research initiative because of the blurring between research and care. And for me, it was, why don't we just give them their drug? and there was these years of doing a strategy, and it was good. A lot of patients got access to treatment. But I was, and then the more it went on, I said, this can't be sustainable for all rare diseases. It's impossible, and I don't think so. So anyways, in that paper, they also concluded, and I think this is important, that we have to address the reorganization and the staffing of clinical units to support the kinds of research activities for the collection of real-world evidence that are situated in care contexts. And what I'm afraid of in this context is we put it all in that data collection for treatments and that most patients don't even have, and put less in the care, psychosocial issues, and reorganizing our health system to adapt to rare diseases.
Thank you so much, Gail. Well, I counted at least a dozen different policy issues that you identified as you walked through those, so thank you so much. Hernan, I'm going to hand over to you. So as a clinician, what kind of policy gaps do you see as a clinician? What do you see as potential value here? I'll let you take it away.
Okay, so just for you to know what I do is I work at CAPT in the neuromuscular program. I think you actually heard two of my really close colleagues today, is Dr. Reshma Min and Dr. Jim Dowling. So basically we work all together. And neuromuscular in pediatrics, I tend to see vast majority are rare disorders, are kids that maybe there are like 20 families reporting in the whole world, and maybe this is the only one in Canada. So we try to usually reach out to people in international just to understand like what's going on, or eventually like what's the presentation of this kid. Remember, like you can have a common presentation of common disorder, a common presentation in rare disorder, and a rare presentation of rare disorders. And at CAPT, it's a tertiary hospital, we tend to see the three spectrums of things. In terms of the policy gaps, my feeling is that we are always running behind, and that's an issue. I can tell you, today you actually heard about probably Zolgensma and SMA. So just a disclosure, I have been consultant for Novartis, Pfizer, and other industries. Probably you have actually heard about the Zolgensma gene replacement therapy. And although there was when it just came or got approval in US, there was a really good intention, for example, to actually get access to families. So they created this lottery. I don't know if you have heard of this. Okay, good. So that was good intention, but it went really bad, like really, really bad. Families were fighting each other, like the families were trying to get money. Interesting, you probably have seen in the newspapers that they were trying to fundraise, so there were like famous people supporting this family. So the other family came to me and asked and told me why they are supporting this guy. It's like, because these medications are extremely expensive. It's $2.1 million. So that created a whole problem. And the other thing is I don't see a correlation between the federal decision and the provincial. So the medication can be approved, and then it might take months to say who is going to get approval. And even within different provinces, the patients might be covered in different ways. The other important thing is, in terms of policy, and also putting an SMA as an example, and the earlier you treat, the better the outcome. I don't know if you have seen, I think Dr. Amin showed you some patients. That's why in 2019, Ontario was actually the first province that created newborn screening for SMA. And you can actually see the difference. It's quite different if you actually treat those patients. But if you were lucky enough to actually were born in Ontario with SMA, you were going to look okay. But if you were born in a different province that didn't have newborn screening, That's the whole issue. So that created a huge discrepancy between provinces, which is another big issue. Talking about, I agree basically with everything you say. I grab a few things in terms of the clinical component. So when nusinersen came back, which is an antisense oligotherapy, again, for spinal muscular atrophy, and it's given through spinal tap, lumbar tap. I don't know if everybody knows. Basically, you put a needle in the spine and you inject the medication. That's the whole process. So when it came to Canada, they told me, hey, here you have a population of patients that probably weren't seen in the clinic for ages, but they all want to have medication. So suddenly I have 70 kiddos wanting to have spinal taps with medications. And the organization that there was like really, really difficult, and there was no support from the ministry. They told us to basically, you need to continue looking with physiotherapy, you need to actually do the motor scores, you need to do all these things, but there was no support. There was no money for it in particular. And this is going to happen with a lot of neuromuscular disorders. Duchenne muscular dystrophy is one of the most common neuromuscular disorders in pediatrics, and the age of death is basically in their 20s. And now it has been recently approved, the gene replacement therapy in US. We'll see if it comes to Canada. But if it comes to Canada, we have in our clinic, we have already 100 patients. Gene replacement therapy is not as easy as just giving a medication. You need to consider this that it might have a lot of complications. You need to actually have a multidisciplinary team that will actually look into complications. If we're not ready for that, it's going to be a mess. So clearly there's a lot of gaps there, like a lot of gaps in implementation. Talking about multidisciplinary care, pretty sure you guys see this multidisciplinary care circle and the patient in the middle. It's not real that it's actually the patient in the middle because it really depends on the care coordinator knowledge, as you were saying. For example, if I don't know when I need to send, for example, a patient with Duchenne to the cardiologist, I might be sending these kiddos at 2 years of age, which doesn't make sense, creating a huge overburden on the families. So education on rare disorders is extremely, extremely, extremely important. Because we need to start thinking, or we should stop thinking about a patient by organ. I'm a neurologist, you see the brain. Oh, I'm a pneumologist, you see just the lungs. Like the beautiful in neuromuscular disorders is you are a clinician understanding really, really, really well between 300 to 600 disorders and understanding the natural history on that. And if I understand that really well, I can actually reduce the overburden on the families. But we need to eventually educate new generations. And then we need to start, stop having like this, seeing the patient just by organ or just by one disease. Going to eventually also, tell me if we're running out of time. The other thing is real world evidence. That's a big issue. We need to create centralized databases. I think you actually have a talk through for the CNDR. I think it's here, right there, Victoria. I see it's so important to have national databases. It's so important, but the thing is there's no support for that. I, for example, in my group, through clinical trials, we are paying also coordinators, but it's not provided by anybody. We just grab coordinators so we actually can provide information so we can all learn. So it's so important to actually have that information, and it should be there should be a national approval. Like right now by bioethics, RBs, you need to go institution by institution or eventually provincials. By such a lack of coordination, if we can have approval for the whole country, that will be much, much easier. I mean, I can continue talking, but I think you get the idea, okay? I'll stop here so you can continue. No, I can jump in again.
No, that's great. That's great, Hernan. And yes, last but not least, Marcel, I mean, in our consultations around this policy observatory, we've certainly connected with the folks at Health Canada many times, and there's definitely an interest. I mean, one of the biggest issues is they don't have the capacity to do this kind of work. And so creating capacity to help answer the questions that policymakers need to have answered, I think, is one of the key drivers here. But maybe you can share your thoughts on what value a policy observatory could bring.
Yeah, thanks, Judy, and it's wonderful to be here today. I do think this observatory fills a really important gap, and I think it's a capacity gap, because I agree with that. Governments don't have, all the capacity we think they might have to deal with issues like this. And sometimes the capacity that is there gets sucked into the political vortex too often. And so even if you have really smart people that are paying attention to what's going on around the world in this space, the work tends to focus more on the immediate sort of political needs than kind of the longer term, where are we going with this policy, unfortunately. That's sort of the reality of working in public service these days. But I think there are lots of issues that need to be addressed. We heard this morning from the presentation about the system readiness issues that Takeda had put in its had in its report. So lots of crunchy issues to be addressed there. I think the timing for this particular idea is right. We've got the national federal strategy coming on stream. Most provinces don't have a formal strategy up and running yet, but you could see that happening, hopefully with Quebec's example, moving that forward in the coming months and years. The key elements for me that are particularly attractive is one, the focus on policy research. We spend a lot in this country on research, generally on health research, on basic science, on clinical research. I don't think we spend enough on health services and policy research, and this is a very good example of an area that requires that kind of attention. For example, just in the space, Health Canada does a lot in regulatory policy. There's very little regulatory policy research, academic or otherwise, that goes on in Canada in general, let alone in this particular area of rare diseases and rare disease drugs. So I think that's really a primordial mission for this project. Secondly, that piece around sharing practical insights and solutions across jurisdictions. That's always been something that we have championed. I think those of us who have worked in health services and health policy in Canada, we have this laboratory of a nation that is trying different things out in different places, but we don't always share those insights across provinces, across territories. And we don't always learn from what's going on internationally, and we don't have very effective ways of capturing that knowledge and conveying it to the people that need to know. So that piece around learning from international experience is really key. Now, who could do this? There are probably many different organizations that could have moved ahead with this. This idea. You would think governments would be in a good position to do this, but they're not always, for the reasons I just articulated. And I think IHE is really nicely positioned to champion this, because this work, I think, needs to be positioned outside of government in some ways, because when you do work inside of government, you can't always share externally what's going on. And I think the value of having this housed in an organization like IHE is that it's going to have to be transparent. It's going to have to be a process that engages many people, many stakeholders, and the learnings from that will be public. The advocates that have been so effective, over the last 20, 30 years moving this forward will have more resources and more tools to work with and try to convince policy decision makers that there's things that need to be done in various facets of this problem. And I think the gaps are huge in terms of the knowledge areas that need to be addressed here. I mentioned regulatory policy, there's reimbursement policy, research and innovation policy more generally, medical education, health system organization, screening and diagnostics. I think the problem with the concept is that you're going to have so many things to deal with. It's going to be difficult to prioritize.
Yeah.
But that's going to be the critical work for the first phase of the initiative, I'm sure. And maybe I can just close with a few caveats and success factors to think about going forward. The first one is, while I like the initial focus on reimbursement and regulatory policy, I do think, too, that it needs to be grounded in the broader context of policies relating to rare diseases generally. I remember when we started talking to stakeholders and patient groups about the federal strategy on rare disease drugs, there was a bit of a kickback around, well, why is it just focused on drugs? We are dealing with people here that have diseases and disease trajectories, and treatments are an important part of that trajectory, but they're not the only thing. And so, again, with the view to prioritizing, I can understand why you may want to focus on reimbursement policy and regulatory policy at the outset, but within that broader context of what's the epidemiology around rare diseases, where's the research at, education and training, patient engagement, and all those really important facets. I think the observatory will need to have a really strong presence in this space. When I hear the word observatory, I think something that is fairly distant and maybe a little bit aloof. I think it needs to be a very action-oriented observatory that will be present in publishing and putting out some tools and resources for stakeholders to use to engage with the broader community and to be really agile in a very fast-moving space. And then lastly, and I'll close on this, I think it needs to take into account the reality of Canada, and this is always the challenge when you're doing pan-Canadian work. Different needs across jurisdictions, different disease burdens, disparate system capacity between large and small jurisdictions, these significant equity issues that we see across the population. So, and I saw that reflected in the sort of the governing principles of the organization, which I think is going to be a really good place to start. But I think that's a really important aspect of the work that will be unfolding there. So thanks again for the opportunity, and look forward to any further discussion.
Thank you thanks to all of you for your comments. So I'm going to open up the floor to the audience. Let's get your post-lunch juices moving. No, I'm not. Get your post-lunch juices moving to see what questions you have about the observatory. We probably need to have another name, so it's a little bit more intuitive. What are the kinds of areas that you think a policy research kind of organization in rare diseases could be looking at? Please feel free to come up to the front and share your thoughts on this. We'd very much like to hear what ideas people have.
I have a question.
Yeah, go ahead.
So I basically agree with you. It's so much work initially in terms of the observatory. Do you think that it can be a bottleneck if it's so much work? And what kind of resources you think you might need?
I think that's the $1 million question. Not to say it's going to be $1 million, but that's the $1 million question. I think that certainly discussions that we've had, it's kind of, do you do everything, or do you start small, prove the concept, and then build? So, because we can't do it, I don't think any entity could take on everything, and that's why, prioritization, identification of issues, prioritization of issues, rating them in some way, shape, or form around likelihood of being able to do analysis, those kinds of things. Rebecca, any additional thoughts?
Yeah, I'd just like to add, I think what I've seen as being successful is you almost focus less on the observatory itself and more on the activities, and you actually just start with activities, and you can call it whatever you want, but you're focused a little more on, we're going to do, this analysis that's going to go into this particular workshop in March, and then we follow up by this date and do these sorts of activities that then kind of has a name but it's less about the name, although we have debated it a lot. I liked Policy Action Lab, Policy Strategy Lab. I have lots of names for things. But I will also say, based on names and stuff as well, I think a huge part of this is also in the knowledge translation, and it's getting in that sweet spot of not too much information and not too little as well. So it's doing things quickly, do the activities, and call it whatever you want in the background is a bit how I like to approach these sorts of things.
Great. Tim.
Yes, I'm Tim. So very similar question, so I'll just change it into comment. I really appreciate what you guys are doing here. It's a great concept, and knowing you're involved, Judy, will turn it into action. It's wonderful. And echo the Rebecca Marsh's comments also about do the small things, get the quick wins, don't be worried about names. But the save, like, I think we can all appreciate all of the activities that are currently going on and have been going on, and basically how much wasted effort it has been because it hasn't been coordinated. So I applaud you on pulling that and focusing it and bringing things to fruition.
Great, thank you. Any other comments? Yes, go ahead,
I just
Bill.
want to say that I don't mind the name observatory. I didn't think it was, if it doesn't stay too academic and intellectual, and but at least observatory from a patient perspective, I think at least it says we're looking at you, we're seeing you, and we're listening, I hope. So.
Yeah. No, absolutely. I think that will be the listening part and the understanding and hearing from people, and as part of a process of identification and prioritization of policy issues is going to be absolutely critical to the success of this, because then, and it's almost a segue into my wrap up, but it helps people buy into and they take ownership of an entity like this and want to stay involved, if they have a say in identification and prioritization of issues and are part of that dialogue. Just as a side note, I was involved with Dave Menon and Tanya Stefanski out at the University of Alberta with their PRISM Rare Disease Research Policy Group for many years. Tons of great work, and it's the pieces of work are the kinds of things that we need to update, right? But there's no funding left to do the updating part, and so all those, and there was a real emphasis on international learnings in terms of the things that we were doing. So, but do many people know about that work? Have we got a central repository for that work where someone who's interested in rare disease policy can go and find it? Not necessarily, unless you have connections. So. Shanna, question from you.
Sure, thanks. I'm really interested in the idea of this policy observatory, and I'm curious, is there a reason why this approach is chosen for rare diseases, or could it be expanded and used for any sort of condition that would benefit from coordination across the country? Is there, do you know what I mean? That's my question. Yeah.
Thoughts?
Yeah, so I think you're talking about it's a model, right, that is applicable here. Yeah, and I
do we
think
use
so.
it anywhere else, like in any
In
other?
Quebec, there's one I'm aware of, because there could be a link with rare diseases. There's a observatoire on the health of children of les tout petits. I don't remember how it's called, but so I've heard of that term and work like that. So, but I think we're talking about rare diseases.
Yeah, yes,
rare diseases has lots of needs that many common
It just seems so clever. I was like, how come I'm only hearing about this today in this one context where it sounds like it could be set up as a model to expand and make improvements in a lot of areas. Thank you.
I've seen a couple of examples of this. One is the North American Observatory for Health Systems, which is based out of the U of T. And it's kind of looking at, it's more of an academically driven network, but looking at what are the health policy, health system changes happening across Canada, across the US, even at the state level, and in Mexico, and what can be learned between the different jurisdictions in terms of best practices, leading practices, and so on. And of course, there's another really important one, the European Health Observatory, WHO in Europe has done this, this observatory role in terms of health systems across Europe and including Canada as well, possibly some others, in just doing health system profiles. What are their systems like? How are they set up, and so on? What changes are happening? So it's really with a view to making sure that knowledge is broadly shared in a non-interference, non-ingérence way.
Yeah. I mean, really doing that analysis that no one really has the time to do.
That's right.
At the end of the day. Don, last question.
Don Husro, University of Ottawa, also Senior Associate of the Institute of Health Economics. Thanks everyone for great talk. I'm just curious, something about Marcel said is about federal government policy research that's sort of not available. Clearly, rare disease strategy, strategic policy branch, public health agency, they do all kinds of commission work and internal work. Is it written in stone? I mean, we live in an era of open science. Don't we expect that we can crack that can open? Do you think there's any appetite that maybe on an ongoing basis? It just seems like there's a lot of research being done that would benefit this effort, for example.
Yeah.
Do you have any thoughts on that?
Well, I don't think it's being withheld for any nefarious reasons. I think a lot of good work gets commissioned and then kind of gets fed into the policy process, and then the decision about whether to make it public or not sometimes is just really practical. Do we have to translate these 15, 20 different papers and get them coded on the for internet access, and all that is somewhat resource extensive or intensive, and so sometimes it's practical issues like that, but in principle there isn't any institutional barrier to making that information accessible. I think there would be a time lag, unfortunately, but the disclosure rules federally are still pretty much in their infancy and don't really compel departments to do a really good job of putting, stuff that really isn't secret, of making it, I guess, as accessible as possible to everyone. Great question.
I have to hand over to Julia and then Allison. So thank you all to our panelists. And I hope, if nothing else, this serves really as a call to action for all of the stakeholders or persons with an interest in this area to engage with IHE, to connect with me or Rebecca or others to learn more about this, or to get involved, or really encourage that, because I think at the end of the day, as Marcel said, there's a real potential for impact in terms of helping us move and do really thoughtful policy work to address a lot of the issues that our panel members have raised and other sessions have raised today in the rare disease space. So stay tuned, and thank you all so much for your attention today. Take care. We're going to run now. Here we go.
Thank you, Judy, and thank you to all of your panelists. I'm going to invite the panelists for the next session to just line up on the side until the picture is taken. All right, so our next session is going to be titled, can I get everyone's attention? Yeah, feel free to come up. Okay, so our next session is going to be titled An RWE Case Study in Oncology, Generating Timely and Meaningful Canadian Real-World Evidence to Support an Outcomes-Based Market Access Agreement. Allison, I'll pass it off to you when you're ready.
Okay, good afternoon, everyone. I think this 1:45 slot is like the 7th inning stretch at a baseball game between lunch and coffee. So I'm going to ask you, just if you're able, just stand up and take a stretch right now. Yeah, Dawn, lead us in the stretching. That's my one of 2 requests. Just, yeah, get yourself sorted. Perfect, perfect, perfect. Thank you so much. Breathe in, breathe out. Let me get set up. Fantastic. Okay, thank you guys so much for humoring me with the 7th inning stretch. There'll be one more ask of you in just a moment, giving you a heads up. My name is Allison Wills from 20 Cents, and I am your moderator for this presentation and discussions on generating timely and meaningful Canadian real-world evidence to support an outcomes-based market access agreement. And we're going to be looking at a case study in RWE in oncology called ASCOT. So by the end of this session, you will know what ASCOT is, and we're going to learn some things about RWE for market access agreements, particularly for outcomes-based agreements. So here's my second ask of you today. I know that we've had lots of discussions in the past at this conference and others about the potential for timely access mechanisms like outcomes-based agreements, and a key component of that is generating evidence, new evidence, so collecting data, generating evidence. I'm just curious if there's anyone like me that still has questions, and you can raise your hand if you do, about the how to collect this data that's meaningful and appropriate and timely for outcomes-based agreements. Okay, well, so those of you who didn't raise your hand, you're going to come up here and talk a little bit about how to do this, okay? But anyways, I think about 3/4 of the room put their hand up. So that's great because we have here today a group of expert panelists who are going to help us discuss and learn about this exact topic. So I'm going to ask each of you to introduce yourselves, panelists, and maybe give us a flavor about why you're here today in just a sentence or two, and then I'll jump back in a moment. So Dr. Chung, I'll start with you.
So hi everybody. I'm Winston Chung. I'm a medical oncologist by training based in Calgary. I also run the Oncology Outcomes, or O2 group in Alberta, and I was involved in the ASCOT study that Allison mentioned, and I'll be describing that in a bit more detail shortly.
Thank you, Jessica.
I'm Jessica Arias. I'm a manager with the Provincial Drug Reimbursement Programs at Ontario Health. Been there for 10 years now, and it was Cancer Care Ontario, so I manage our drug funding budget for oncology injectables. I also manage the evidence building program where we've done a couple of studies on products that were conditionally funded until evidence was developed. So I'm here to support Allison in this discussion and contribute based on my experience.
Thank you, Jessica.
Yeah, Graham Statt. I'm a former provincial drug plan ADM, and also for a time was the vice chair of the Pan-Canadian Pharmaceutical Alliance, and I'm also here to support the discussion and to contribute based on my experience.
Thank you. Amin Sayani. I lead the medical evidence generation group at AstraZeneca here in Canada. We do a lot of our evidence generation work, real-world evidence studies across all our therapy areas, oncology and non-oncology, primarily supporting the Canadian business. Happy to be here with this panel. Thank you to Allison for putting together this wonderful panel, and to CAPT for letting us be here. Looking forward to the discussion.
Okay. Thank you so much, and welcome to you all. So the format of this session, I'm going to give you a very brief overview of what you need to know about outcomes-based agreements and data before we get into the ASCOT study. So Dr. Chung is going to give you a presentation of the findings of that study. And then the bulk of this will be a discussion about the different elements of data generation and how to do that data part of an outcomes-based agreement with the panelists. Save your questions for the end. Of course, we'll have lots of time for you guys, so I'm counting on you. That's my third ask of the day. Won't be any more asks. All right, let's just get into it. So a quick background on innovative market access agreements, real-world and evidence generation. What this all comes back to is timely access for patients to therapies that are coming to market here in Canada. We know that outcomes-based agreements have been done in this country. We saw a presentation earlier this year by the PCPA showing the types of agreements that they've had. But what's really important when we're looking at timely access mechanisms and using something like an outcomes-based agreement is that there's a data collection part of it. So outcomes-based agreements is just one tool in that toolbox to use to support timely market access. When we're talking about these agreements, we have the financial component of the agreement. I think we're all familiar with PLAs and rebate-based agreements. It's sort of traditionally been used in this country. But with outcomes-based agreements, what's happening is that access would be given to the patient, the product would be listed, and then additional evidence would be generated, data would be collected, evidence generated from that data, and then that's used to help adjudicate the financial part of the agreement. This is a new skill set that we need to put in place, right? Generating evidence to support a financial agreement. That's what we're going to talk about here today, so that data collection piece. There has been a lot of research in this country on how to generate real-world evidence to support healthcare decision-making. And this first study, I'll just tell you a little bit about it because it's a bit of a precursor to the ASCOT study. Myself and Dr. Chung and some others were involved at looking at the Alberta oncology health system data and looking to see if it could be used to support an outcomes-based agreement. And what this is not actually touching the data. It's looking at the data readiness, the data interpretation, and the data time frame. So, is there data that is accessible for an OBA, complete and accurate? Data interpretation, is that health outcome clear and simple? And data time frame, can it be collected in a reasonable time frame? So it's looking just at characteristics of a data set. So what we found, looking at 5 outcomes, I'll just show you really the results of that, is that overall survival and time to next treatment, those 2 health outcomes in Alberta are already there. They're in the health system data, and they are ready, available, timely, and suitable to support an outcomes-based agreement. One other element with OBAs that often comes up is the question around, well, how timely is this data? Can we get it in a quick enough time frame that all parties would be comfortable with running an agreement, perhaps over multiple years, et cetera? So for this exercise, what we did specifically was we looked at, for those 2 metrics that were available, OS and time to next treatment, what would the time frame be to collect the data? So, OBAs can be set up in a lot of different ways, and in this one, we use the hypotheses of recruiting patients over a 12-month period and then monitoring them for a 12-month period, which you'll see up there on the top sort of section of the timeline, and then looking at how long would it take for the data logistics. That's the middle piece for both of those. And then how long would it take to do the analysis and reporting? So in this instance, we saw that it was about 2.5 to 3 years when using OS and time to next treatment to collect the data from start to finish for this type of OBA. What we'll see, though, is subsequent research has come out in recent years showing that actually payers and manufacturers might both want some interim reporting along the way to help them adjudicate their budgets or their sales forecasts, which usually happen on an annual cycle. So that's just a little nugget to keep in mind as we look at what was happening in the ASCOT study. So I want to now bring us into the topic at hand, which is the ASCOT study. This is the Alberta small cell study on clinical outcomes and treatment patterns since the introduction of durvalumab. What's really interesting here is that the team working behind this study, they took the concept of investigating the real-world data and real-world evidence generation to support an OBA one step further. They actually tested this data collection and reporting process in a real-world setting by measuring cancers with short-term trajectories and looking at the outcomes. So the concept of using Alberta Health System data, they went one step further and they actually did a study on it. So that is the ASCOT. I'm going to, before we invite Dr. Chung up, I'm just going to ask Dr. Sayani if perhaps you could give us a quick overview of, what was the objective of putting together this ASCOT study?
Yeah, thank you, and thanks for that setup. I think what was important in the setup that you provided is the work that you and your team had done with the Alberta data, along with Dr. Chung, on being able to demonstrate the availability and the readiness of this data to be able to take information and data that was there to be able to describe how you might do an outcomes-based agreement. And so what was important is that you show that our overall survival, time to next treatment were appropriate variables for us to look at. What we did then is to be able to say, do we have an indication, do we have a drug that we might be able to test in this particular scenario and show that we can do this? As you may be aware, 12% of lung cancers are small cell lung cancer, and of which 6 to 7% are extensive stage. Our previous studies that we had done within our own group in Alberta and Manitoba had shown that there were very low rates of first-line treatment and even lower survival rates. I think these were about overall survival in the real world with current therapies had been around 8 months, and only about 8% of patients actually reached survival rates, at only 8% survived at 5 years. Durvalumab was approved in September 2020, and so it was important for us to sort of look at this and say, well, how have treatment patterns evolved since the introduction of durvalumab? How has the treatment landscape changed, and what are the real-world clinical outcomes? At the same time, as you mentioned, there was a lot of interest in OBAs and a lot of interest in the use of real-world evidence, and whether or not we could actually use RWD for outcomes-based agreements. And so we took this step further to say, this is an appropriate drug, this is an appropriate indication. We should be able to measure these outcomes in a reasonable time frame, and so let's set this up as an actual, people like to use the word demonstration project, pilot project, whatever it might be. We just said, let's see if we can get it done. And so that was the approach we took. This drug serves as a good role model for the reasons that I've already described. We wanted to understand and demonstrate the feasibility of being able to collect real-world data, how we would implement it, how quickly we would be able to get the data, how would we collect the data, what is the frequency with which we could collect it, what data infrastructure was needed. And so we really wanted to test all of these different elements out. We had seen the work Dr. Chung had done. We were aware of the Alberta Health Service data set as a very valuable data set. There's a lot of good linkage of data between the clinical and the administrative. And so we thought this was a good opportunity for us to actually do this. And so we sought out Dr. Chung and started working on pulling together a protocol to be able to test this exact concept. So
okay, fantastic. So I will also seek out Dr. Chung right now and ask him to come and speak to us about the ASCOT study. Dr. Chung?
So I think I told some of you that I took the red-eye flight this morning from Vancouver to Toronto, and I think I'm starting to feel the effects of the flight now. It seemed like a good idea a week ago, but maybe not so much now. But despite needing caffeine, I'm very excited to be here, mainly because of this study. We're very proud of it, and I'm happy to share some high-level results and findings from this investigation. So as was already mentioned by Allison and Amin, really the premise of this study are several-fold. One is to better understand the patient characteristics, treatment patterns, and outcomes of patients with extensive stage small cell lung cancer in the real-world setting since the introduction of this new medication called durvalumab. And how this study was structured is as follows. We accrued patients over a 1-year time frame since the introduction of the new medication, so specifically July 2021 to July 2022. We then followed these individuals in regular fashion and regular intervals over the span of 2 to 3 years. Just to be clear, it was a retrospective analysis because we were tracking these individuals, but we would kind of go backwards every quarter, every 3 months. So for all intents and purposes, we were tracking these patients, but going backwards to look at their outcomes every so often. Importantly, because this was a pilot or demonstration study, we also developed an OBA steering committee. And the benefit of having this committee was to really get their insights and input in terms of what was going well, what was not going well, what would you improve if we were to redo the study in the future. And we also want their comments and feedback in terms of what they felt were the key data requirements or elements that would be important in an OBA setting. We also want to get their feedback as well in terms of how we can circumvent some of the obstacles and barriers that we did encounter throughout the study process. So as I already discussed, it was a cohort of 1 year, about 60 or so patients. We did a series of quarterly retrospective analyses on these individuals, and after each quarter, we'd also produce a report. The steering committee consisted of not only data experts from our team, but we also involved a number of clinical experts and oncology leaders to ensure that the buy-in was incorporated. So some of these names you may be aware of. So these are largely lung experts given the topic at hand, but also some oncology division heads and directors so that their input can also be integrated. Again, as I discussed, the key questions that were to be addressed by this committee included, were they happy with the data and outcomes that were measured? Were there other things that are missing they want to see? And we also want to reassure ourselves that it was possible to generate these quarterly reports because that was a pretty large undertaking. So again, I'll just give you a snapshot in terms of the key findings. So overall, we were able to demonstrate that the real-world effectiveness of durvalumab in this small cell lung cancer population did mirror and align with the findings of the clinical trial. More importantly, we were also able to show that OBAs are logistically feasible, at least in Alberta. The outcomes we were able to assess and ascertain are as follows: overall survival and time to next treatment. And these are elements or outcomes that we were able to revisit from Allison and my group's earlier work. We were also able to capture items such as duration of therapy, as well as reasons for discontinuation. Some of these parameters did require a chart audit of the actual patient records to ascertain. Also, as equally important is the fact that we were able to generate these quarterly OBA reports. Each report included a detailed case flow diagram, who were still alive, who were still on drug, what were their demographics and clinical characteristics, what were their outcomes, and again, as I mentioned, what their time to next treatments were, and also if they passed away, their reasons for their death. I also thought that was very successful to have the committee be involved from beginning to end, as we were able to kind of get their feedback throughout the course of the study. And again, I think their insights were very valuable because throughout the study, we were able to add additional endpoints to what we're capturing. I know this is a somewhat busier slide, but this is sort of an overview in terms of how the study reports look like on a quarterly basis. I already mentioned there's a table that describes the lay of the land in terms of what the cohort looks like. And then at each quarter, we'll also look at their outcomes. Again, as I already shared with you earlier, the outcomes in the real world did track quite well with what the trial showed. So I already spent a bit of time in terms of what insights were gained, but I think it behooves me to also underscore to you what were some of the challenges. So even though we were able to capture a number of key endpoints and outcomes, there were additional ones that I think the committee want to see. So a common one that comes up quite a bit is recurrence or progression information. That's always pretty hard to come by in the oncology literature. There was also comments and remarks to really reiterate the fact that more stakeholders at the committee level will be really important. So we were able to include oncologists, clinical experts, and oncology leaders, but having payers and also patients at the table be equally important. We did try to engage these parties as well, but for this study, we weren't able to recruit these individuals to the committee. Another remark that was very common was this is very Alberta specific, and the question now is, can we expand what we've learned to other jurisdictions and other provinces? As you may have heard from previous speakers this morning, it's very difficult to get national data sets. It's very, very hard to come by, mainly because the data rules are quite strict, and even sharing data across borders, it can be quite tricky. So the question now is, are there existing data sets that we can leverage? So the idea of using patient access program data or patient support program data has come up quite a bit because, as you know, these are national in scope, and perhaps they can be tapped into to address similar questions that we have done in the context of this study. So that was a whirlwind kind of overview in terms of what the study aimed to achieve. So now I'll turn it back to maybe Allison to.
Perfect. Come join us here. Okay. Yeah. Thank you so much. Thank you so much, Dr. Chung. So for that overview of ASCOT, and I think for me, the first time I saw ASCOT, I thought, wow, this is really fantastic because we talk so much in this country about how can we do this implementation of outcomes-based agreements as a barrier. And seeing two big elements for me were the steering committee, putting that in place and testing how that can be used, as well as those quarterly feasibility reports. That's something new I hadn't seen before, so kudos to you guys for putting that in place. Now we're gonna go on to our discussion part of this session and really looking to see what we can learn from the ASCOT study in terms of generating meaningful and timely real-world evidence. So I'm gonna build on this steering committee question, and I think this is gonna be for Jessica and Graham. I'm curious, we heard Dr. Chung say that for this simulated OBA, that they would have liked to have payers involved in the steering committee. I'm just curious from your perspectives and past experiences, who would the appropriate parties be to have included in an OBA steering committee? And even what specific considerations are there for engaging these folks and timing on that? Maybe Jessica, I'll hand it to you first.
Thanks, Allison. So I'll start with the timing. I think as early as possible is probably ideal, even at the health technology assessment phase or prior. I think because forming the plan for an OBA takes some time. I know with the evidence building program, we had 2 products go through. It took tremendous effort on behalf of several individuals who were involved in the planning of it, and it took a lot of time to implement conditional funding, because you really need to think about who are the stakeholders, what are the outcomes of interest, what's the data that we need, who's going to analyze it, and what do we do with the analysis at the end. So you really need representatives from all aspects of stakeholders. I would say for the steering committee, a patient who can validate the outcomes that are meaningful, that were expressed during the HTA review process. So we see, based on the surveys that come through and the patient input, this is what's meaningful to them. So you want to make your OBA relevant to the patient. For a payer, they're the ones that are going to have the ongoing relationship with the manufacturer, so they need to have input early on to say what's even feasible, because it's more likely than not that the payer is going to be responsible for the data analysis and assessing whether the data is there and are there resources to conduct the analysis. We found that having a data expert, a methodologist early on to say, yes, we can do this, no, we cannot, was critical. And obviously the clinical expert who can also ascertain what's meaningful, what are meaningful outcomes.
Okay, thanks, Jessica. I'm curious, Graham, from your experience as well. The ASCOT steering committee included industry partners and the data experts and clinicians. What are your thoughts on this? And also just building off what Jessica said, to include a patient and a payer on a steering committee.
Yeah, I guess my thoughts would be almost having 2 committees, one sort of the scientific committee, and that's where your data scientists and clinicians are, maintain the neutrality there. And then on an overall steering committee, you certainly should include payer, manufacturer, patient representative, maybe someone from the patient organization. You could probably get broader there in terms of representation. I think payer time is probably a factor. It may have been a factor in this case as well, as you couldn't get payer involvement. But in any case, payers are going to want to be involved from the beginning to understand the design of an OBA. And you could still have cross-pollination between the 2 committees if you had, say, the chair of the scientific committee also being present and represented on the governance committee, that sort of thing. But at the end of the day, I think payer would want to be able to ask even the scientific committee questions at any time, and also be wanting to ensure funds are being utilized appropriately, that sort of thing.
Okay, thanks for that. And I'm curious, just going to push you on this. What's your perspective on the industry partner being involved with this, and what is their role?
Yeah, I mentioned on the steering committee side, I think definitely should be present. And I think their role is, obviously a lot of times they're bringing funding for the enterprise, but also know their therapies pretty much better than anybody else. And so I think they're bringing a great knowledge base there, answering questions, helping along the way. But I wouldn't include manufacturer presence on what I'm terming the scientific committee.
Okay, fantastic. Any other comments from the group on this question? No?
Yeah,
Oh,
I think in the UK, Netherlands. I think the sponsor will actually submit a proposal with their submission for a health technology assessment. And I think that's helpful. Just going off of what Graham said, they know their product best. They know what the drawbacks are, what the outcomes are that are meaningful, what data is missing, what evidence is needed. So a proposal at the offset would be helpful.
Okay. I know we had a little pre-call on this, and I'm going to jump ahead a little bit to pick up on this question from Jessica, or this point from Jessica. So I'm curious, thoughts for the panel to comment on. This was a simulated OBA, but if there were to be a real OBA proposed, what would be the best place to have those conversations? You mentioned now a proposal early on. Is there something more specific that you could propose, or maybe that you've seen in the past? And even for any of you, if you have experiences in trying to propose these types of innovative agreements, has there been challenges in when and where to do that appropriately? So maybe back to Jessica. Sorry, Jessica, putting you on the spot.
I think national engagement is important for these. We've definitely had engagement with manufacturers at the local level, and knowing that across Canada we're really trying to align funding decisions and have equitable access across, which is progressing away from the way it may have been in the past. It's hard for one jurisdiction to just deviate and do something related to an OBA. It really has to be a concerted effort, I think, on a national level. And there would be power behind that, especially for smaller provinces, rare diseases, just an ability to combine efforts and resources to conduct such activities.
Okay, fantastic. Graham? Yep.
Yeah, I underscore early as possible, and I think Jessica mentioned earlier as well, the idea of even a pre-submission type meeting before or at the point of the HTA application. Payers are going to be tracking exciting medicines. A lot of times there's these pipeline conversations that are being had. The exciting medicines and the breakthrough stuff, they're going to make time for that. And so I think an early conversation would certainly be welcome. And I guess I'd just throw idea for future state, maybe an idealist idea for future state, but I think in a perfect world, if we can get to the place where CDA and PCPA are creating kind of a special teams approach, where for special medicines, breakthrough things coming through, often in an expedited way with a lot of political and patient expectation, to right up at the front end have these critical conversations that might involve innovative agreements and OBA-style agreements, and structuring the kind of governance that we need early on in the process to be successful.
And I think it's just kind of building on this. I think this is where the opportunity for us may be, right? I think we have a unique opportunity. So you mentioned earlier that the manufacturer and the industry partners have a really good understanding of their product and what the data says. And that's where there may be opportunities where, when we're looking at these data sets carefully, we know where the uncertainty may be, whether it's clinical or economic. And is that an opportunity for us when we think about we want to bring these medicines to patients faster, and we want to get that timely access? Is there an opportunity? Maybe it's a special committee, right, that kind of sits down and says, hey, the manufacturer can open the door and say, we've got this innovative drug. This is the type of data we have. There is an unmet medical need. Is there an opportunity for us to consider some sort of coverage with evidence development or OBA to be able to collect real-world data and get access to the drug, right? And so that may be a really interesting way for us to get that data faster, but get access to patients faster as well. So there is an opportunity for us to really push for this sort of approach. And I think certainly it's not every drug and it's not every indication, but we've now shown that it's possible. Right? And you can get these data, you can get these reports, you can actually look at these reports and show what the clinical outcomes are and be able to make some decisions around those outcomes and continued funding for the drug.
Go ahead, Winston.
I do want to maybe underscore the early engagement piece that's applicable to not only the payers, but also patients and the data experts and clinical experts, because I think this ASCO study was done in a pretty efficient manner, but despite that, it was still quite resource intensive and took 2-3 years for it to materialize. So the time course of doing an OBA, I think, is that 2-3 years. So when I talk in other venues, I think there's this assumption that it can be turned around in 6 to 12 months, and that's really not the case. And I think in some jurisdictions it can take even longer. So I think early engagement across the board, I think, will be really key.
Okay, thank you all for those comments. I'm wondering if we can pick up on a couple of things here. So the time frames for the data generation, and now really unique in the ASCOT study, we've seen that these quarterly reports were able to be generated. So reports were able to be generated on a quarterly basis. So a question for Dr. Sayani and Dr. Chung. I'm curious about what was the experience of generating those quarterly reports and even working with that steering committee. So maybe the generation question for Dr. Chung to start, and then we can talk a little bit about the steering committee experience with the reports.
Sure. So I think when we first started the study concept, I think there were various intervals being bounced around and considered. I think there was interest in generating monthly reports at one point. I think as the analytical team, we were more leaning towards maybe every 6 months, just to kind of cut down on the resource intensity of the work. So I think quarterly was sort of what we settled on as being sort of the happy middle ground. And I think quarterly turned out to be quite feasible. I think monthly would have been stretching the capacity by quite a bit. And also, even though we were tracking individuals, it was still not a real-time study. So in the sense that there's still a data lag in terms of outcomes and endpoint ascertainment. So even if we were able to logistically produce the reports on a monthly basis, I don't think you'll see really tangible difference in the outcomes per se. So I think quarterly is probably makes the most pragmatic sense from my perspective anyway.
Yeah, maybe the only comment I would add to that is, by looking at these reports on a quarterly basis, we were able to, and then using the steering committee and having the expertise that was there, we were able to get an understanding of what data might be really, really important for us, right? What data would those clinicians want to see? What data might payers want to see? And we were able to work with Dr. Chung and team and tweak these reports from one quarter to another and say, hey, you know what, maybe this category doesn't actually show us what's meaningful and relevant, and so could we tweak it? And so we were able to, using that quarterly frequency, we were able to actually tweak these reports to make them more useful.
Maybe just to give an example in terms of what we mean by tweaking, the endpoints didn't change per se, but one of the things that we looked at was reasons why someone stopped the medication. But then when we classify those categories, they change over time. So initially we had maybe 2 or 3 categories. We lumped some of them together to make it more clinically useful. So I think that that steering committee feedback was very helpful to make the report useful and informative.
Okay, fantastic. And I'm curious about the frequency of the timing of the reports. Question for Jessica. What is your thought on quarterly versus monthly versus every 6 months? What does that feel like for a payer?
I think in my space, it would probably end up being our team that would have to generate the analysis, depending on how this theoretical activity would be structured in the future. So I think quarterly is ambitious. It probably really just depends on what's the nature of the agreement and how it's structured. Ideally, as Winston said, to get meaningful data, it would take even more than a quarter to determine whether or not the outcomes or the analysis that you have is meaningful to support any reconciliation with the manufacturer. So, and being that it's resource intensive, not knowing how many you would have of these to manage, it's just something that would have to be considered, whether the resources are there, the number of these that are in action, and what's going to be meaningful at what cadence.
Okay, fantastic. I'm going to pick this same concept up with Graham. I'm curious from your experience of managing the drug plan, would you want to see data at a quarterly or every 6-month frequency? Like, what would be appropriate for you as a payer with an OBA?
Well, I just take off a bit from Jessica's comments. In government, I don't know which law of thermodynamics it is, but every action leads to an equal and opposite reaction. So when you create a report, it has to be analyzed. People are already busy. I think twice a year is plenty, maybe even just annually. And if we're tracking things like overall survival and tying them to a price regime in a financial agreement, really it's going to be the back end that's the most important piece on that outcome. That being said, I think any kind of tool or reporting is helpful for the budget planning process and engagement of Treasury Board. That's very important because when you transfer dollars between fiscal years, that Treasury Board sometimes will punish you vigorously for that by actually saying, oh, you obviously have surplus dollars, so we're going to start you out next fiscal year on a reduction basis, actually taking some money away, which is one of the reasons why often payers produce or prefer simple rebate kind of agreements. And I just guess how that would tie to this is any kind of OBA arrangement would likely be looking at kind of discount pricing and then agreement to increase price if outcomes are achieved at a later point, which ties back to probably less frequent reporting and more focusing on the outcomes on the back end would be something payers would be opting in for.
I just want to provide further context. I think this study was also designed in a very strategic way in the sense that we chose a tumor site that was relatively rare. So even despite that, the quarterly reporting was quite intensive. So if this OBA was now done in the real world involving a more common disease setting, I think that does alter the logistics of things, and it could make it quite tough to report on a quarterly or monthly basis. In this cohort specifically, there was like fewer than 100 patients. So I can imagine the workload increasing quite drastically in a different setting where things are a little more common and it's a more prevalent disease.
Okay.
And I think very much would depend on the therapy area itself too, right? So what's the therapy area? What's the most relevant outcome? What's the actual relevance of the frequency of that reporting? There may be certain areas where, depending on the outcome, you actually need that data report faster or sooner than the quarterly or even the biannual. And so I think this is very much dependent on the therapy area, and would have to be, I think this whole idea of early engagement, making sure we put all the right people at the table to be able to say this is the right outcome, this is the right frequency, and this is how we'll do it, would be ideal in these situations, or would be needed, I think, were we to actually pursue an OBA.
Okay, fantastic. Let's get back to the ASCOT study for a second. So we saw in this study that 4 of the outcomes that they assessed, overall survival, time to next treatment, duration of treatment, and reason for discontinuation, were feasible in Alberta and could potentially be used to support an OBA. So I'm going to ask this question to Jessica. I'm curious if, based on your experiences, do you feel that in this case these are appropriate outcomes to look at for an OBA? Or even, what is your reaction to using these types of outcomes to support an innovative agreement?
I think it's drug indication specific. For us, we did an analysis on adjuvant therapy, and it took a significant amount of time to, obtain mature data in that space. So when we're looking at advanced disease, these are probably outcomes that are more meaningful and faster to obtain. So I just really think it depends on the indication.
Yeah. Okay. Do you have any comments on that? No? Anyone else? No? Okay, perfect. Maybe one more for Jessica, so picking on you a little bit. I'm curious, now that you've seen this study, the way the ASCOT was set up, would this be possible with Ontario data or the data that you work with?
Yes, short answer is yes. The data's there, so definitely we've looked at overall survival, time to next treatment. It's available.
Okay, perfect. Thank you. Okay, maybe a little bit more of a high-level question for our panelists. Now, we've seen in recent years a number of mechanisms come into place to help sort of fast-track innovative drugs that are promising with limited evidence. We know on the regulatory side, there's Project Orbis. Here in Canada, we've seen Quebec's INS promise of value HTA pathway. We've seen the TLR and PTAP pathway, time limit recommendation from the CDAMC come out recently as well. But that initiative, for the moment anyways, excludes the use of real-world evidence as confirmatory data. So now we're looking at RWE and thinking about that. How could the learnings that we see here from the ASCOT study help contribute to evolving our thinking around the use of real-world evidence to support timely market access through formalized mechanisms, or maybe less formalized mechanisms like outcomes-based agreements? And maybe I'll start with Graham.
Yeah, sure. I guess first thing I'd just say is even with the time-limited recommendation, a logical next step is going to be that we do start including outcomes-based agreements and real-world evidence sort of in that trajectory. I know they're in the trial stage right now on that whole process, but I think this study shows that good data can be gathered and that can inform and should inform even those processes. In any case, something that's rocketing through the system, that's, notice for compliance with conditions and time-limited recommendations and being flagged for PTAP, you need something in the toolkit, like an OBA-style arrangement to actually help things and to come up with innovative listing regimes and pricing regimes. So I think it's very necessary, and this study shows that there's a lot of feasibility there. And I think you could just build into the OBA how, when the phase 3 trial data comes in, how that's going to be incorporated. I actually imagine a scenario where even if phase 3 trial was, hum-ha, but no safety signal, but things looked really good on the OBA side, I think you could still see continued funding and maybe an augmentation of that funding from a payer perspective. It's all just information inputs into decision making. At the end of the day, payers don't want to pay for drugs that don't work. Patients don't want to be on drugs that don't work either. So I think there is some common sense approach that can come into all this.
Okay, thank you so much for that. Dr. Chung, I'm curious, sort of a similar question for you, but maybe your experience from the data generation side. How do you feel about these types of data initiatives being done? And is that something that you see as possible to support timely access initiatives?
I mean, I'm probably, preaching to the converted, but I definitely, I've been doing this for many, many years now, and I definitely see the value in RWE, especially the ASCOT study. But I think that the devil's in the details in terms of how the study's operationalized. A common question that came up based on the ASCOT study is, well, can we now leverage the findings here to influence decisions in other jurisdictions or other provinces? So I go back to the point I made during my talk, which is it would be, I think, important to maybe replicate the study either in a different setting in Alberta or in other provinces. I think the PSP data also brings a lot of promise because it is national in scope. And I do wonder whether if PSPs can be designed sort of preemptively or a priori with an OBA in mind, can they be more enriched in a way where the data sets hold more value and hold more strength, and by doing so can be leveraged more fully and more wholesomely for an OBA type setup.
Okay, thank you for that. I'm curious, for Jessica, whose desk this may land on one day, how do you feel about this type of data initiative and linking it to market access agreements?
Yeah, I guess I have to, throw it out there, as we always say, and we always hear, it can't be a mechanism to bypass the gold standard. There have to be criteria by which it's identified that this drug is truly meaningful, meets an unmet need, and is really going to bring value to the system, that there's just the anticipation of that. It can't be that RWE is the solution for quick patient access. We're really looking for products that are going to bring value to the system and have demonstrated clear, meaningful benefit. But RWE, obviously, I mean, there's no question there's value in that. We're looking at data that demonstrates that real patients in the real world are benefiting, and how can we say there's no value in using that? But then the tricky part comes in that whole risk share aspect of it. How do you bring those products forward, knowing that there's a true risk share associated with it, knowing that there are limited resources? So there's a lot there to balance, but I think clear criteria on what can pass as a really good OBA candidate is important to establish.
Okay, thank you. All right, this is my heads up to the audience that I'm going to ask them one more question, and then I'm going to be counting on all of you. I saw Dawn stretching. Good. Give it a minute, okay? Give it a minute. So I'd like all of us here to reflect a little bit about your experiences with ASCOT, and I'm curious, one, if you have any final comments you'd like to add before we go to audience questions, and two, is there any additional research you're either thinking about working on, or it's something that you think that it would be nice to see or work on to help advance our knowledge and capabilities in RWE generation to support timely access mechanisms? So maybe I'll throw it down to the end. Dr. Sayani, you can go first on this.
Yeah, I'll start with our experience on this study and working with Dr. Chung and his group and the different investigators that we had involved in the steering committee. I mean, I think it was a very positive experience, right? For us, I think what was absolutely valuable was the ability to be able to show that we could use real-world data from a health system to be able to demonstrate real-world outcomes in this particular patient group. It was absolutely positive that the real world overall survival tracked very much the RCT data, so that was positive for us. But generally, if I think about what did we get out of this, it was that we're able to do this, right? This is what we set out to do, and we were able to demonstrate that we can do it. I think where this now goes is I think we've kind of been talking about this towards the end here, is can we actually use real-world evidence? And some of these mechanisms that are starting to come through the system, like TLR, and there may be others where we can, in fact, use real-world evidence to be able to improve access and timely access for drugs. So I do feel there's a real opportunity there. Granted, it's not for every potential drug and every potential indication, but it's something that should absolutely be on the table, I would say. The data in Canada is continuing to evolve. We always say we have a very good health data system. It may be fragmented, but there is very good data across the country. And so how do we continue to use these opportunities to strengthen our data infrastructure in the country? I think we've got to think about vehicles like HDRN as an example. There are other pan-Canadian initiatives, data initiatives as well, that we've got to think about and see if we can use those as vehicles as well. So I think the vehicles are there, the approach is possible. We've shown proof that this can be done, and I think we've got to do more. Certainly from our own perspective, there are things we could have done better. You know, we talked about the payer, we talked about the patient. One of the things that Dr. Chung and I have spoken about is the idea of a rolling cohort as well. We had one cohort that we followed, and at the end of the year, we kind of ended the study. But we've talked about a rolling cohort as well, right? Being able to continue to bring patients into the cohort. And so there are other opportunities for us to continue to strengthen this work, and I think that's where we'd like to go next.
Okay, fantastic, thank you. Rolling cohorts, I hear it. Graham, for you.
Yeah, I guess just in terms of summary comments, I would say, I mean, super encouraging to see this happening, to see that it can work. There hasn't been a ton of experience with OBA, but there has been a lot of experience, which I think offers example by analog through special authorization on special medicines, and similar learnings can be gathered there. And from our use of that program, I could tell you, overburdening the agreement with asking it to just do too much can really break things down and slow things down. Also, you really do need something like a scientific committee, somebody that makes the final court of truth decision on is the outcome working. So I think there's some learnings there. And especially if price is going to be tied to outcomes, there's always going to be a desire to reduce interpretation on the back end. I guess the last thing I would say is, it should be in the admin data, but one of the things it'd be neat to track, certainly be of interest to the payer, is just the total health system costs while on serving that patient while they're on the drug. I think that'd be a lot of interest to the payer and could provide some insights into future work as well.
Okay, thank you for those comments. Jessica?
Yeah, I agree. I think this is a great demonstration of what the potential is for an OBA. I think taking it one step further is something of interest. We talked about this in the pre-meeting, is let's tie some numbers to it. Let's see the what if we had done it this way in an agreement, what would that have looked like, and would we have seen added value at the end for a structure like this? I think where the rubber meets the road is probably of interest as well. And as I mentioned earlier, I think a national concerted effort, a framework, criteria, a true interest in risk share, knowing that there's equal interests at stake in these sorts of agreements, and I mean, I don't know. I think that's it.
Thank you. Dr. Chung, any final words for you?
I mean, I think I agree with what all the other panelists have said already. But in my view, I think the ASCOT study is really, it's just scratched the surface. I think during the study process, it became evident that there were a number of other outcomes that would be equally valuable. So things like patient-reported outcomes, quality of life, and as more cancer centers are now beginning to collect these variables on a routine basis, it'd be great in the future OBA to really incorporate these patient-centric endpoints, because they're obviously extremely important. So I think incorporating more endpoints would be very important. Hopefully, it can be done in the future.
Okay, fantastic. Thank you for your comments and for your work on the ASCOT study and sharing all of that with us today. I'm going to open it up to the floor now. Don, the mic is yours.
Right on. Don Husro from Ottawa, policy researcher. Thanks, Winston, for sharing the study. It was great. I'm just curious, so the outcomes that this is a really curious question, and it's going to go to two people, but the outcomes that you highlighted are kind of population-based outcomes, aggregate, average, survival, time to discontinuation. It's possible that somebody's interested in some individual outcomes, like, for example, early failures or maybe even long-term success. Is the data that you have amenable to that kind of thing? I mean, just given how it's curated whenever, it's anonymized, obviously. Is it okay? You can identify individual cases. Is that something that's did that even come up in your steering committee discussions?
So it is possible, and as you know, there are certain data rules about suppressing really small cells. For this cohort, we did do chart audit, like chart review for some of the cases, and I may have gone through this too quickly, but we also did capture reasons for stopping therapy, and that's not available through admin sources. So we are able to do a chart review of patients. Again, this was a very manageable number of cases, but again, if the number goes up a lot higher, then I think it becomes less feasible to do. So the short answer is yes, we can look at that, but again, it depends on what parameters we're delving into. And if it's really, really rare, then there's a risk of identifying the individuals, in which case we would have to mask those findings.
Yeah, that's how I wondered about the rare, and I wondered about some rare individuals within a bigger cohort, and so I saw you had a rare cancer. I'm just also, the follow-up question is, Jessica or Graham, I mean, do you think payers would be more interested in these individual cases like early failures, or do you think they'd be equally interested in, aggregate outcomes like average survival, average? Maybe you think it just depends on the case, but just putting you on the spot. But what do you think?
I mean, I don't know. I guess it's always easy to say both, but I think probably more on the aggregate. Particularly from a payer perspective, maybe even getting to disease-free survival rather than overall survival, which is a bit of a different angle on looking at the performance of the drug. That'd be my perspective. If you have one, Jessica.
No, I agree. I think maybe in cases of rare disease and higher cost drug product, that may become more of interest. But I think at this point, aggregate is sufficient.
Yeah, maybe just to add to a comment on that, Don, I think one of the key reasons we set this up in this way, as an industry sponsor, obviously we didn't want to have any patient-level data. And so we set it up so that we were only getting that aggregate data. I think were this to be a real OBA for certain conditions, like maybe rare diseases or something of that sort, where the payer was directly involved in the adjudication, there may be potential to be able to share exactly how an individual patient is doing. But I think that would be very much dependent on that particular case and what that therapy area was.
Okay, fantastic. Thanks for the question. And Lester, hi.
Thanks a lot. This is a great conversation. So thanks a lot for the publication and study. I guess this question is more for Jessica and Graham. So I don't know if Winston and Amin did a good enough sales job to convince you now we got to do OBAs, or Allison, right? Seems like it's a lot of effort, a lot of work, a lot of resources. So I think, Graham, you mentioned something that I think was fantastic. You said, sometimes we got to make sure that if we do an OBA, it can't do too much, right? It has to have a very specific objective. So what do you think is the primary objective that would tip you, like payers, to actually conduct an OBA for a drug or test or whatever it could be, right? Is it, for example, would it be primarily trying to reduce costs would be like the major objective? And then second part to the question would be like, what would be an example of like a disease or some characteristics of a disease that would fit into something that would tip you over to actually do an OBA? Thank you.
Yeah, there's a lot to unpack there. I'm going to try and go quickly. I would say in terms of the things that are going to flag for eligible for OBA, things that have variable response, limited data, or disputed therapeutic benefit. Those kinds of things are an initial filter. Another indicator is what's coming through on a time-limited recommendation. Now, that means initially we might see a lot of stuff being just on the oncology side, but I guess what I'd just say in terms of coming back to the remarks you were referencing earlier, just keep it simple. Like what it comes down to is we really have to just do some of these. Like we just have to do them. And so that's why it's so exciting to see this study come through. It shows that it can be done. We can keep it simple, and we can track that data, and it should inform payer decision making on that. So I don't know, Jessica, if you have to.
Sure. I think the financial component is important, and that's a driver for OBA, but also knowing that patients are in fact benefiting from the intervention. Just funding blanket cases and not knowing for certain that we're getting the benefit we expected, that's a real gap, I think. And when working with limited resources going forward, it's a combination of financial, but also wanting to know that we're putting resources towards the most valuable outcomes. And cases of rare disease are probably the ones that are the best candidates. However, you're also dealing with small populations, so that brings its own challenges. Yeah, great question.
I'm going to just jump in here because there's one thing I heard that I want to remind everyone. OBAs are not a tool for negotiation to get a lower price. OBAs are a tool for timely market access. So remember the toolbox analogy at the beginning. It's when there's not timely market access. Use a PLA if you can, please, okay? And if you can't get there, and if there's going to be timely market access, that's the appropriate time for outcomes-based agreements. It's not a negotiation tool for price lowering. It's about timely access. Jerry and then Trish.
Thanks. Actually, I have two questions, so should I ask them both, or do I get
Jerry,
one?
Trish, Jerry. Or Trish.
Just in regard to the comments earlier about cross-jurisdictional data and stuff. I wonder, and I'm asking this of Graham and Jessica, would a study that was conducted using Alberta data be acceptable as as evidence for another province? And can we avoid having to do these nationally by simply realizing that there's not going to be a lot of difference between a patient in Nova Scotia and a patient in Alberta?
Absolutely. I think any opportunity, and I speak for myself, any opportunity to use resources mindfully is a great, is a direction that's probably worth exploring. I'll leave it at that. I think there's definitely generalizability across Canada, so I don't think that there's harm in using another province's data as proxy or analysis as proxy. But I think that there's strength in numbers, so if there are other provinces that can engage in a particular agreement and provide that data, that's always even more meaningful.
Graham?
Yeah, maybe I'll just even augment that. I could say for certain that at the PCPA we did have some of these discussions about how to our comfort level with using proxy data and results from another jurisdiction. And I think where we kind of got to eventually in that conversation is yes, cautiously optimistic to your question, that can happen, but people always want to pressure test at the front end in terms of, okay, how rigorous is your system, what's actually being gathered, who's involved, et cetera, et cetera. And I think if you can get that right at the front end, there can be a comfort level with using data on proxy.
Okay, Trish, it's your mic.
So, and I'll just add to that, we would definitely use other provinces' data, assuming that there wasn't a difference in the care. So for example, if Alberta or something also covered some sort of adjuvant therapy that other provinces didn't cover, in that case, you can't, it's apples and apples. Now I forgot my question.
Well, you did a good job of answering that question.
I have to make up for you guys. Just kidding.
Yeah, someone's got to, yeah.
Hey, hey.
Ouch. Okay. So this is fantastic. I can't wait to read the details of this. Having been in the space for a while, things fall apart very, very quickly when it comes to assigning the thresholds. So at what threshold of overall survival of any of the performance measures does either the OBA end or coverage discontinue? And I'm just wondering if there are any plans to continue this, this analysis in that regard. So were there any thresholds discussed as to when the OBA, the agreement would terminate and coverage would cease?
I'll take an initial stab at it, and then Dr. Chung may want to as well. So in this particular situation, because this was what we called a mock OBA, we did not have any sort of financial component linked to the outcomes. Having said that, just generally what we were looking for is how well would these outcomes track to the clinical trial. And I think that's what we would normally be looking for, I think, in these sorts of agreements, is how close are we to what we might be seeing in the trial. So we didn't talk about anything of that sort in terms of thresholds. Would we want to do something, continue to do this and think about those thresholds? I think there would certainly be appetite, because I think this is where the next step for us could be, is if we were to bring a payer on board, is to say, okay, how should we think about, even if it is a mock financial agreement, right? What should that look like? What should thresholds be? And have some further conversations around that. I think that's certainly a really valuable next step for us to consider.
One other thing I want to add to that is that I think setting thresholds is quite tricky in the real world, because I think in this study, I think the outcomes tracked quite well with the original trial. But having done similar studies in other disease settings, because rural patients are sometimes sicker and frailer than the trial population, it's probably unrealistic to expect the outcomes to always align with the trial. So how close is good enough would be a very pivotal question, and how do we determine that is also quite challenging. So really good point, but in terms of how to operationalize and implement it, I think is yet to be determined, I think.
Thanks for that question. Jerry, there's actually a question behind you. I think I'm going to give priority, and then you're going to get the last question.
Sorry. My name's Joan Paulin, and I'm a patient advocate for a rare disease organization. And my first part is a comment and then a question. And the comment is that I agree and I support completely patient organization inclusion much earlier in the process for a couple of reasons. The earlier that we are included in the process, the easier it is to get buy-in, because we actually, when you're asked to be part of the process, you actually understand the process better. The other thing I support, I think patient organizations would support, is the addition of patient-reported outcomes, burden of illness, those kinds of things that are important to patients. My question is, we talk about getting patients earlier in the process. Because this is the confusing part for me, is I would assume that if you're going to be doing a outcomes-based agreement, that would be a decision that's made very early in the process, because you understand what the drug is and what there's an assessment, especially in the rare disease space, that you're going to be running into things about a lack of evidence, a small patient population, a possibility that the drug is meeting an unmet need. So my assumption is that an outcomes-based agreement, and the drug is going to be expensive. So my assumption is that an outcomes-based agreement would actually be something that would be talked about very early in the process, and again, something that I think that patients need to be involved in. We don't need to be involved in the pricing, we just need to be involved in understanding, so that getting back to Tricia's point about thresholds, if we are part of understanding what the thresholds are, then you're also going to get better buy-in from the patient organizations. So yeah, the question is, where do outcomes-based agreements fall in terms of, or the decision to be using an outcomes-based agreement, where does that fall in the process? Thank you.
Yeah, I think as soon as possible in the process, and like we had mentioned earlier, even in a pre-submission meeting, HTA, involvement of the patient community, involvement of patients, absolutely. And frankly, I think even all through and on the back end, we should be getting to a higher level of transparency on the nature of the agreement, what's being tracked, and publication of the results. Not the pricing scheme, obviously, but, and you've already acknowledged that, but I think everything else should be, so that we can have a continuous improvement approach to this.
Yeah. I think if we go with a framework where the sponsor is submitting a proposal at the HTA stage to identify that their product is a good candidate for an OBA, it's right there at that point. HTA is already engaging with patients, getting patient input. Patients are consolidating survey data, providing that to the CDA, INES. Those are opportunities to further engage the patient on those topics.
Okay, thank you guys so much. Jerry, I just got the end sign from the team, but I invite you to come talk with the group after. So thank you so much to all of the panelists here today, and for you in the audience for being so engaging and asking great questions. Coffee time.
All right, everyone. So our last panel for the day, before we get into the student oral presentations, is titled, "Are Healthcare Systems Ready for Advanced Therapeutics?" So the moderator for this panel is Monica D'Angelo. She is a health and behavioral scientist with expertise in outcomes research, health policy, technology assessment, and change management. She works with health and healthcare stakeholder patient groups, healthcare organizations, clinicians, researchers, industry partners, payers, and policymakers to define and address healthcare priorities, identify opportunities for value-based system improvements, and inform change strategies. She's also an adjunct professor at the University of Ottawa. Monica, I'll pass. Please join me at the podium, and I'll let you lead the rest of the panel.
Thank you very much, Julia. So we're very excited here to be discussing healthcare system readiness for advanced therapeutics, and specifically CAR T therapies and bispecific T-cell engagers. The conversations throughout the day have revolved around integration, application of advanced therapies, and system readiness for all the advancements that science is bringing to patients. But of course, the issue is, do patients have access to these, or what do systems have to do to ensure that patients actually have access to these breakthrough therapies? So we have a small panel. It's more of a fireside chat here today. We have experts who will, two experts, and you probably know them both, who I'll introduce shortly, who will bring the perspectives of the healthcare system sort of readiness based on work that Don Husserl led, as well as the industry perspective on how industry and drug developers can work with other stakeholders in the healthcare system to ensure to expedite and to ensure that access to these therapies is equitable across Canada. This is intended to be an opening conversation on this topic. There's work, there's a project that is going to be launching shortly to do a little bit of research on what other jurisdictions have also, or what they are doing to expedite access to the to advanced therapeutics, specifically CAR T therapies. So stay tuned for that. But we are very much welcoming and encouraging any patients that are in the group, as well as healthcare providers, for your feedback kind of throughout the discussion. So while there will be a Q&A period at the end of the session, please do feel free to interject. We can make this more of an interactive discussion if so desired. So with that, it is my pleasure to introduce Cynthia DiLullo. Cynthia has over 20 years of experience in the pharmaceutical industry with expertise in marketing, sales, and business analytics for products in multiple therapeutic areas at all stages of their life cycle. Cynthia joined Pfizer in 2001 and has held various roles in marketing and sales, including Director of Business Intelligence, Marketing Director in Primary Care, and a Regional Business Director for Ontario. After spending the bulk of her career in the primary care setting, Cynthia moved into oncology, where she has successfully led the launch of more than 10 products over a 5-year period. She's passionate about bringing new innovative treatment options to patients in Canada, and is therefore excited to be contributing to discussions such as this one. Welcome, Cynthia. And Don Husero is an adjunct professor of medicine at the University of Ottawa and a senior associate at the Institute of Health Economics. Don does freelance healthcare research and works with private and public sector life sciences organizations to help them understand the value of health technology and its implications for health and innovation policy. And welcome, Don. And we'll start the discussion by having Don do a presentation to provide some context around what system readiness for these advanced therapeutics and complex interventions looks like, what the state of readiness currently is in Canada, and what the challenges at the healthcare system level look like. Over to you, Don.
Okay, thanks. I'm going to do this. Let's see if the technology works. How about that? Oh, good. Our healthcare system's ready for advanced therapeutics. So thank you for getting coffees, because this could be a snoozer, just to be clear. I thought I would start, there's a whole literature about how society transforms technology and technology transforms society, and I thought I would remind us of that. I was going to think of some pithy examples, like of Toronto, when, back when the days of horse and cart, and then I got too caught up in like historical archive readings, and I said, I don't know anything about this. So I went with COVID. We all understand COVID. COVID came, we all locked down, and then suddenly it did a bunch of things. This graph, the red bar, is deaths in individuals in Ontario 80 years and older. The reference is at the bottom. And then suddenly after lockdown, the traffic deaths went down. So COVID saved a significant proportion of elderly individuals. While it was simultaneously killing them in other ways, it was saving them from motor vehicle accidents. But what it did do as well is it had us locked down, and then we said, oh, how are we going to work? Because we all need to work. And so we suddenly video conferencing became a big deal. And we started introducing the verb zooming. And that had ramifications as well. In Ottawa, and I think in Toronto, we see this weird thing with traffic patterns. In Ottawa, it's very evident. We call it the twits. They're the Tuesday, Wednesday, Thursday commuters, because on Monday and Friday, they don't have to go to work. And so suddenly it becomes very busy. I started reading about traffic patterns. Fascinating. There's like a whole research around that. But apparently in the city of Gatineau, which is right across the river from Ottawa, they had like a massive drop in commutes. And then I found this other chart that showed, like, in the city of Arnprior, they actually have 22% increase. So all because of video conferencing, we have differences in how we have to now commute and think about commuting. Apparently there's even 2 different peaks in the morning. There's certain people who go early and certain people who don't have to go so early. I work at home, so I don't have to deal with a lot of that. So video conferencing has changed where and how we live. A lot of people actually moved out to Arnprior, and then house prices went up in Arnprior accordingly. When and how we drive and commute, and everybody knows that they're checking emails at 2:30 when they're really buying groceries. And how we dress. I'm wearing pants right now. I may not be on a Zoom call. I'll wear shorts, though. I wear Bermuda shorts. And then how we deliver and receive health care. I was just sending a text to my 16-year-old daughter who has a video conference with her dermatologist, who is not a dermatologist, who's a family physician who was trained as a dermatologist. You see where all these changes that we're, and it's by video conference because it's like about acne. And there we go. I'm sure she would be lovely to hear that I'm talking about her acne in front of everyone. I will not give you her name. So, but we were prepared for Zoom, luckily. Can you imagine, like, if this came 10, 15 years earlier when everybody was, like, on 1,200 baud modems? That wouldn't have worked very well. Well, I guess we would have had phone calls. But we had broadband connectivity. Everybody had, raise your hands who does not have Wi-Fi, who does not have internet in their house. Anyone? Anyone? Yes, I thought so. So we all have internet. We all have microphones. We all have all this stuff. And what did I put? Oh, and we also have, and we had browsers that enabled this too, so it wasn't an excuse just to say you didn't have the app. So we were ready. But now we have this technology that transforms health systems. I thought somebody was raising their hand, but that's just a microphone. Okay, technology that transforms health systems. And I want to give definitions. I think definitions are extremely important. Words are very important. We're calling them advanced therapies, but that doesn't really mean anything. Health Canada has a definition of an advanced therapeutic product. That's, this is their definition, and again, it's not that definite. Typically, it says typically personalized, developed at the point of care, and manufactured, distributed, and used in ways that differ significantly from other healthcare products. Still some fuzziness, but if you think about it like a CAR-T or something that is manufactured from a person's cells nearby, rather than like you buy it from a package that was, a drug that was manufactured somewhere else. We're not just talking about that though, because we're also talking about complex therapies. And complex interventions, as defined by the MRC in the UK, they have interacting components, reliance on behaviors, reliance on groups, organizational levels, and there could be tailoring, they could be iterative. So I've given some examples here at the bottom, some of which I can see. So CAR-T is one of these, but we also have things like fecal microbiota transplantation, which is a technology I've been doing a lot of work on over the last few years, and well, anyway, I won't make any more jokes about that. And then integrated care models. We could even mean things like combination therapies, which are become complex in terms of scheduling problem. Certain surgeries, we have gene therapy, we have continuous or closed loop systems for diabetes. So things that you don't just buy them out of the box and use them. There's a whole bunch of other things that have to happen. You need specialized human health resources. You may need diagnostic capacity. You may need, this morning we heard Mohammed Mamdani talking about the role of information systems. You might need a new regulatory framework. You might need processing facilities, all kinds of things. The question is are we ready for these types of new technologies, which are becoming more abundant? And so today we're going to talk about T-cell therapies or T-cell, I'm calling them T-cell therapies. We have CAR-Ts, which are where you take cells out of your body, you infuse a gene into those cells, you put them back into a person's body. There are variations on that now that you're going to see in the future. We also have antibodies that actually engage with T cells. They're called bispecific T cell engagers. They attach themselves to a T cell, and they also attach themselves to a cancer marker. And the idea is they're bringing the lazy T cell over to the cancer to kill it. And we're seeing more and more. I'll show you that. But here's an example. Like we have this was a CADETH, a CDA submission, brexucabtagene for acute lymphoblastic leukemia. And, remarkably, it showed, compared to salvage chemotherapy, an additional 3.35 life years per patient on average for people who got this. That's like, it's nothing to sneeze at. That's a lot of additional potential life for an individual who has this disease. So that's fine and dandy. We want to pay for life-saving things, but as per some previous conversations today, at what price? And so here's a chart of all the things that CDA has positively recommended in the T-cell therapy world. And so I had one company who said, well, our new drug isn't there. And I said, well, that's because they haven't recommended anything yet. There's been also one CAR T that got a negative recommendation, so I've kept it off the list. But you can see, this is, if you take the projected number of individuals annually who are going to have to use these from the CDA estimates themselves, from the budget estimates, this is what you get. You go from, we had blinatumomab, which is a Amgen product that came in for a whole bunch of ALL indications over the course of many years, but for very small select populations. And then suddenly you have this explosion of CAR T, and then now CAR T is in yellow, and bispecific T-cell engagers, which are now coming in, and in disease areas that are with more people, like multiple myeloma. And we're going to see more and more and more of these, like the number of bispecific T-cell engagers, the number of CAR T, and the number of applications, and the line of therapy going earlier and earlier and earlier, where you have bigger and bigger and bigger populations, is coming. So, the question is this sustainable? And why is this a challenge to implement? Well, okay, utilization's not usually a challenge to implement. I mean, cancer managers sort of look all the time at projections and sort of decide, but they have this situation with T-cell engagers in particular. There's a lot of specialized resources that are required to implement these things. T-cell therapies can cause a real issue with some patients where they need critical care. So in some cases, it's recommended in the monograph. These people are admitted to hospital. And some of these monographs are admitted for up to a week. So you need to have beds. You need to have that kind of availability. And so if a cancer planner is thinking about the future, they might be thinking, well, it's difficult to increase capacity in a hospital. And so the question is, well, could we do this in an infusion clinic? Well, no, well, sort of, but we'd need like a very reliable way to monitor. We need to have access to critical care. There's all kinds of, we need specialized human resources. So these are all challenges. They're also, these things could be costly. I mean, CAR T therapies are an interesting example, just like gene therapies, where the payer's asked to pay everything up front. So maybe that's really amenable to like an outcomes-based agreement, as we just talked about. But they're taking a little more risk than they would maybe with an ongoing therapy, where if the patient fails, then the patient just discontinues. They're paying the whole thing right at the start. And it's sort of like, we promise it's going to work. So, however, if a patient has having to go to the hospital every month and be admitted for 3 days, that's not exactly convenient either. So there's all kinds of new implementation challenges with these particular therapies, and we're just using this as an example. There are, as I said, there's a number of other therapies that pose their own complications in terms of needing infrastructure, needing health system readiness. Last year, we were speaking a lot more about the same topic as this morning, about molecular diagnosis and the need for an infrastructure of laboratory services that can deliver specialized tests. So, I'm going to stop there. This is the context for the discussion. One of the things that I've been asked to do is I'm working with a consortium of companies on looking at what are some potential solutions and policy options. And we don't have a patient representative up here today, but we felt that there are patient representatives out here, and we wanted this to be really just the start of a conversation. And we wanted to make sure that people would chime in. So we felt like, well, we couldn't have everyone up here. So we're going to have this conversation about, I hope you understand what some of the challenges are, but then what could be potential solutions and the like. So I'll stop there.
Mm-hmm. Perfect. Before we sort of initiate the conversation and give Cynthia an opportunity to speak as well, are there any comments or questions for Don regarding the presentation, regarding the context? Okay, so you did a fabulous job. You were so clear, there were no questions. So given the challenges that you've outlined and the fact that these kinds of innovations require resource-intensive infrastructures in order to be implemented, what seems to be it seems to be a unsustainable issue, and you're talking about solutions, but from your perspective, what are the necessary next steps that you foresee for healthcare systems to be ready for these complex interventions?
Yeah, and I don't know, I mean, I can't speak to whether this is unsustainable. I mean, you may have a healthcare system administrator saying, well, we can accommodate a future use of these particular therapies, but it's a slow-moving process. We can't just, build more hospitals or have more beds in a minute. That's a long-term planning. So what that means, though, is if it's slow, that may disenfranchise patients. I mean, it might create problems with access. It may create problems. I mean, we already have some of these therapies just being delivered in highly specialized centers. So, I mean, already we have a situation where you might be able to get access to this therapy, but you do actually have to travel quite a ways to get it. But with more and more and more and more application, yeah, it may become a challenge. So I think the question you had was, what was the question you had again? Sorry.
What are the necessary next steps?
Right, and I think, one obvious one is really getting a handle on what's the magnitude of the quote-unquote problem going to be. It's not really a problem to save lives, is it? But I mean, it's a problem if you can't actually, it's a problem if CDA says yes to a therapy and then you can't actually implement it. So, being much more forward-looking about some of these therapies, I think is probably going to be more so than we are maybe with other therapies, where it's kind of nice to know they're coming. But with these ones, it requires a lot of health system planning. So there's got to be that sort of projection and planning aspect that starts a bit early on. I think also, so that probably also requires working with a whole bunch of different people. These are, clinicians are going to have ideas about how to best and safely deliver these products. Healthcare administrators are going to have ideas about what's feasible and doable. There are models of care where they're delivering these things in a kind of outpatient basis, but not like a true outpatient basis, because it's like outpatient but close to a critical care area or with highly specialized monitoring. So I think the healthcare system planners are also going to have to start thinking about like what options are feasible and doable, and that's actually the project that we're engaged with, is to really look at what are other folks doing and what is feasible and doable. And so I think it's going to be it's a lot more forward-looking, I think, than the policy sphere tends to be very reactive, and so I think there's going to have to be a lot more sort of forward-looking work ahead to anticipate this. I mean, these therapies here are only the tip of the iceberg. I mean, I do a lot of consultation with global companies, and there's just a ton of these things coming. I don't know how we'll ever get our head around this, so I'll stop there.
And I think also to your earlier point, it'll need to be a collaborative process to really be able to identify what the challenges are, what the priorities might be in terms of next steps, including patient engagement, so that we understand what the access, what the preferences and access issues are from the patient perspective, right? So Cynthia, assuming a company like yours is aware of these challenges, because you would have put a lot of thought into this, what are your thoughts around the necessary next steps and kind of the challenges from your point of view?
Sure. So, listen, it's great to be here with everybody, and thanks, Dawn, for providing the context behind this challenge that we're facing. And as industry, we're trying to figure out what our role is, what the expectations are from industry, who we're bringing these new therapies, and so there's nothing more discouraging or sad to see is when we bring therapies that can really have great value for patients, and they can't get them, and so we've worked very closely with the oncology community to get to patients faster. And we do that by trying to, address access barriers and, tackle some, inequities in treatment. So it's really important that we move with urgency to really identify and try to, address some of the challenges that patients are facing. And so, what we've noticed over time is that, initially it was Health Canada approval that was important for us to bring a therapy to Canada, to Canadian patients. And it was like, okay, now we need to get public reimbursement. So that provided further delays, to get the medicine in the hands of the patients who need it. And now we have this additional challenge in terms of implementation. And, so these therapies that are coming that are more complex, that have implementation challenges and sometimes, supportive care challenges in terms of, as Dawn mentioned, adverse events that, patients have to be monitored closely. And so it's more important than ever that we try to understand how these can be implemented in a healthcare system that wasn't necessarily designed to take these medications into consideration. Obviously, no one knew they were coming. And so, I think it's more important than ever that we deepen our collaboration around trying to find solutions here. And I don't think anybody has the solution, but I think if we work together, we'll get there. And, if we expect the healthcare system to make these changes and to invest, it's our role as industry to demonstrate the value proposition to patients. That's the first and foremost. We need to demonstrate what value this is bringing to patients to even expect changes to be made. But once that's done, then how do we work together to make sure that, we find solutions? And I think, it's not a one-size-fits-all. We've seen, we talked earlier this morning about molecular testing, and, 10 years ago, I think even more than 10 years ago, Pfizer brought a therapy for ALK-mutated lung cancer, and no one knew how to test for ALK. And so there was a huge effort, multidisciplinary effort that went into trying to do this. And over time, we've gotten better at it. We have NGS testing, but we're still faced with delays and trying to get results to patients quicker. So how can we work together to address this? Because we need to come up with, because we don't know what's coming, we need to kind of come up with a formula or guidelines that take into consideration the patient journey and the challenges that they're going to face, and put together some type of a format. We were talking earlier about observatory that can be used and can be transferred to other therapeutic areas, other issues. So be it biomarker testing, be it bispecifics or CAR T, that it can actually work for different areas and hopefully help us solve this problem. But we also need someone to champion this. And maybe it's patient groups, but there's so many stakeholders that own a part of this. It's how do we move it forward?
Thank you for that. And of course, Dawn, you mentioned that you're leading this project to look at different policy options, and so I'm sure that solutions that are being used even in other jurisdictions will be investigated or explored there. Are you able to provide some hints as to what what factors this project might consider?
No hints. We're just in the early days here, but so there's no actual solutions. We know that some of the bigger hospitals in places like the United States have had to come up with solutions to kind of deal with this. So we know that some people have had to think. We even know hospitals here like Princess Margaret and others have, and we've been speaking to clinicians at, for example, Sunnybrook, where they're sort of ramping up. We know they've been thinking about this sort of at a local level. So we know that there are potentially solutions to this. There are some solutions that are a little harder to deal with, like we've seen in the readiness for genetic testing, a shortage of laboratory technologists, or there might be challenges when you have health human resource challenges. It can become incredibly challenging. And it is, and so I think what Cynthia's alluding to is it's like the case of the ALK. It's slow moving, but we don't want it to be slow moving because there's patients who are actually waiting for things. And so this suddenly becomes really problematic when everybody wants to pay, but nobody can figure out how to do it. So I don't know if I've answered your question.
No,
again.
yes, you have. And I also thought, like, in terms of building on the prior research that you did in terms of system readiness for biomarker testing, whether you can, like, so when you talk about readiness for these different types of advancements and advanced therapeutics, how might this research, perhaps differ from?
Well, I think, yeah, well, I don't know. I mean, what I'm finding is it's very interesting, right? Like technology, if you look at, the new CDA, and I can pick on Trish because she's here, but you look at the new CDA and they say, there's like a little subline and it says health systems. And of course they do some work on health system organization and what have you. I mean, that actually, if you go to their website, you'll see that there's research done. But what you find is like technology people are focused on the technology and they sort of see the implementation issues as a sort of side issue. And then you go to the health services research community and they sort of see technology as a side issue. And nobody really wants to kind of think about the fact that the uptake of technology has to do with health system organization and financing and all of these other things. And so I think the kind of things that we're doing, this kind of system readiness work, it's somewhere in between. It's policy research that's focused on technology ostensibly, but it's recognizing that technology doesn't exist in a vacuum. It doesn't fall from the sky and then machines, you don't just plug in the machine and a miracle happens. You need a whole bunch of people and other things working in concert to make it happen. So I don't know, I think it's important as we continue to think about technology, we think about larger organizational challenges that are associated with technology. I think it's not just some side thought, it's going to become more and more important.
Mm-hmm. The larger infrastructure that's required to implement it.
We have somebody as well.
Oh, I didn't. Oh, okay, the light was in my eyes. Yes, please go ahead.
Yeah, hello. Well, I think you wanted patient organization.
Yes, absolutely.
Yes, we do.
Yes, please.
So I don't have any questions, but some comments about 4 experiences we had with. So 3 examples. Some years ago, we initiated a study. Our group brought a study, natural history study and then intervention study to Montreal because we have, for a certain rare disease, Morquio disease, a bigger community affected by that disease in Quebec. So I went to see medical geneticists at McGill University, and one decided, okay, I'll be PI of this. And anyways, we convinced the company to come and do the study. So this Dr. John Mitchell was PI, and so kudos to him, the work he had to do to get this in a hospital setting. It's an infusion for the intervention, and even for the natural history study, the testing. So really, besides all his clinical work doing this, I thought he was a hero, the patients too. And then bad news because Ines didn't recommend the drug after all that. And second example is you were talking about some settings or in the US, or I accompanied a patient with late onset Pompe to Pittsburgh a couple of times for participating in the interventional study there. And the facilities were incredible, and I think there would have been, again, difficulty in getting it done in the context in Quebec. The other example is we were contacted because for the gene therapy for hereditary retinal, because it was taking a lot of time to get the clinical settings up, and there had to be pediatric and adult. But we were at a loss as a patient organization for that, because can we really intervene with the bureaucratic and the obstacles and challenges in a hospital? So that was, we were at a loss for that. But anyways, I think it finally got done, but it took some time, it seems. And the other gene therapy for SMA, well, then it's a question. That was a question of price negotiation. We first time a doctor called us up to say, "I'm ready to do this. This, I can do the injection anytime." But we were waiting for the price negotiation, and the government didn't want to do a special agreement with the company. So, anyways, that was. But the doctor who was involved in the clinical trials was ready to do it, and it was 1 year. More than 1 year after the INES recommendation, and then it took another 6-7 months to bring it to the and the parents. We even had protests in the streets of Montreal. First time I saw that, because the government was saying there's 2 other therapies, but yeah, when parents hear about gene therapy for their baby, they don't care about the 2 other. Therapies, the media hype about gene therapy, so if there's one available, that's what they want. Now, a positive example, you were talking about, maybe 3 days hospitalization but I have a close family member that has a rare lymphoma going through chemotherapy. Now, he's 3 months in a 6-month therapy. He goes in the hospital 1 week every 3 to 4 weeks, and the monitoring between is incredible. It's a full-time job for him. And he already had the stem cell collection because he's going to have stem cell transplantation. So anyway, that's a positive example. It's incredible the care he's getting. And that's in a university hospital, but not in the biggest city in Quebec. And so that's a good example, I think. But I agree, if there's a lot of these therapies, and when he's in therapy, he sees all the people in that oncology department, and he can't believe it, and so obviously, and how the oncologists seem to be working on the clock. So if there's many of these, I guess it is a problem. It could be a problem.
A challenge, for sure. Thank you very much. Thank you for sharing that. There were 2 points, Cynthia, that were raised. One was and I think you mentioned the importance of a champion, right? And so we heard about how that made a difference in the example that having a clinical champion to bring these therapies to patients. And then the other one was special agreements with payers. And so I'm curious in how willing is your company, for example, to work with payers to make this therapy more accessible?
Yeah, so Pfizer and other pharmaceutical companies have been, we partner with payers to try to, bring therapies to patients quicker. And, I think we all need, including industry, we all need to be held accountable for the outcomes that, we want to achieve with patients. And so, we're exploring a range of different solutions. And, we talked earlier about outcomes-based agreements and other innovative agreements that, can bring therapy, especially therapy that is, in a white space and where there's an unmet need to patients, cancer patients who need them, but then also taking into consideration the uncertainties that payers are faced with. So we heard earlier, how complex that is. It's not simple. There's investment required. There's time. But we are definitely willing to continue to work with payers to try to find solutions. They're not straightforward, but we're at the table, and we all have the same objective, right? It's to bring these therapies to patients faster and to find a way to do it in a way that's sustainable. So, it's, again, this is in terms of paying for the therapy, but then it goes one step further now in terms of how do we pay for or make the systemic changes to the healthcare system in order to be able to implement some of these newer therapies. And there again, we need to partner and work with multiple stakeholders, and it's multidisciplinary, and yeah, we're willing to do our part, right, and trying to figure out what is industry's role in this.
Because it really requires comprehensive solutions, right? Multidisciplinary, comprehensive.
Exactly.
We have a question here from the audience.
Yeah, Judy Glennie. I wanted to go back to this issue of implementation, and I work with a consortium of companies, and we're very specifically focused on the Ontario oncology space. And we had a meeting at the beginning of this month, and we will publish the results of it eventually, related to exactly this issue, you know, so the challenges of implementation, planning, et cetera, et cetera. A couple of points. I think that one of our key learnings, I think, was that the royal we cannot depend on the organizations with whom we interact when we're making submissions, whether that be the HTA organization or the payer in the individual province, to be communicating with the actual centers that deliver the care. Because what we heard consistently was, oh, I find out on Friday that something is going to be funded as of Monday. And literally, no time, you know, that's when they start implementation. So no one is owning the issue of implementation. We've got implementation planning as part of our HTA process. I don't think the payers who are doing the input on that are really thinking things through or talking to people, so I think there's an issue there. And then the people who are primarily dealing with the HTA submissions and making the funding decisions are really not coordinating and communicating within their own ministries, et cetera, et cetera. And then, as I said, it's the people at the coalface, the people who are delivering care who end up wearing it and having to. So I think one of the comments that was made was that there's no visit, you know, you don't know when these products are coming. Who else knows but the company? Like, you are the guys that know that a product is coming. So I think industry, again, another learning, industry has to take some ownership of this to say we need to help our systems plan better, and we as a company need to understand better what the potential implementation challenges are going to be. So just like you're developing your marketing plan, just like you're developing your market access plan, you are developing an implementation plan. And that is something that individuals are going to have to own, companies are going to have to own, because no one knows your drug better than you do.
So let me clarify.
No, let me finish. And I think a best practice that we saw was with the introduction of the first CAR-T, where literally the company invested 2 years of going around the country, working with payers to try to, and institutions to try to figure out how to do this. And it still took time. It still took the system, a nationally based approach still took a lot of time before a patient actually saw the light of day of actually receiving a CAR-T. So I think, you know, companies have to take some ownership of this as well, and also start to, one of our key learnings was start to talk to different people, because we're clearly, maybe we figured out maybe we're not talking to the right people who actually have to live with the implementation piece. So I'll stop there.
Okay. Can I respond?
Yes, please.
So, yeah, so let me clarify there. So I think there was a bit of a misinterpretation. So when I say we don't know what's coming, I mean, you know, we didn't know we were going to come up with a drug to treat ALK, right? I mean, like, I can't predict what's going to, we have our pipeline, but I see what's in our pipeline in later phases of development. And one of the things I completely agree with you on is, I mean, you know, we start, you know, you know, bringing products to market, bringing products to patients, we start looking at it, you know, late phase 2, early phase 3, you know, where we start saying, okay, is this going to be a me too? Is this going to be, you know, a completely new therapy that's bringing something new to patients where there's an unmet need? And so we start to do that assessment, and during that time, we need to now start looking at, will there be implementation challenges? And the issue, I think, is that the stakeholders that we've been working with in the past are not necessarily the stakeholders who have those answers. And so we need to start to talk to people, you know, hospital administrators and people, you know, and we have been working with patient groups, but, you know, we don't know what we don't know in terms of how this is going to be implemented. And I think starting earlier, to your point, completely agree, we need to start looking at what is this therapy going to ask of the healthcare system, and how can we start to address it sooner, and how do we bring the right people to the table to start finding those solutions. And doing that early on is critical, because to your point, if we do it afterwards, then we're just further delaying bringing the therapy to patients. So, you know, we've got Health Canada, we've got reimbursement, and then now it's like all of a sudden we want to implement it and we're realizing we have all these barriers. wrong time to be doing that. So I think we've learned that, you know, and some of the things we can anticipate and other things we can't. And again, you know, if we don't start talking about early enough, then we create inequities in the system too, where there's some centers that are able to manage it and patients can have access there, and there's others that can't and they don't have access, and we have travel issues like you mentioned. So definitely starting earlier on, I think that's really important, identifying who we need to work with to do that. But yeah, you know, my point was more around the fact that we cannot predict all the different types of you know, interventions that are going to come over time, and so we need to have a formula that can actually be used for any type of therapy that, you know, so we can implement these new therapies.
But Judy, I think your points are really well taken. Companies have to start rethinking about how much time, effort, resources they need to commit earlier. They're all, like most multinational companies are publicly traded. It's not like they don't know, it's not like we don't know what they're developing, and then they get a good sense of when things are really going to leap ahead way earlier than, you know, than the HTA process, for example. So yeah, they have to start rethinking things. And then you pointed out the governance structure of any healthcare system is so important. In Ontario, we have this legacy decentralized governance structure. So the hospitals are more like, you know, very powerful fiefdoms, and then, you know, now they're trying to centralize and rein people in and everything else, but but we're still sort of fighting. As you said, there's no one that's like truly accountable. The government can make all kinds of announcements, and then everybody is scrambling to keep up. And, you know, presumably they're going to go and sort that out eventually. Maybe we all have to be very realistic about how hard it is to change an ecosystem, especially a big one like Ontario, 14 million people. Like, it's slow moving, and like you know, I'm never saying, gee whiz, the healthcare systems are too slow. I'm saying, what can we do to kind of make it a bit better? I mean, maybe it has its pace, and maybe we need to do the best we can, recognizing that there's only, you know, it's like dealing with global warming. There's only so much we can turn the ship when it's that large. Anyway, I see there's other people, so I'll stop there.
Thank you. Tricia?
Oh my God, I thought you'd never stop talking. Okay. So, right? Yeah, thanks. Okay. What Gail was saying, and Judy, about the sort of the disruption that happened, you know, when CAR-T first got introduced, huge. So we were introduced to Kymriah and Yescarta at least a couple of years before they actually hit market, and when the first approvals came through. So we were having discussions at a provincial level together with oncologists and oncology groups across Canada. And so we knew that they were coming. What we were told, though, about what they would do and who they would be used for was different than what actually transpired in the end. And I'm not just talking about what the HTAs approved or what the regulatory process approved. Essentially, it got down to the impact or the number of patients that were estimated to be treated in Canada was much, much lower than what actually transpired. So all of the planning that we did for Yescarta and Kymriah when it came in was around, okay, well, if it's only going to be, let's say, you know, 20 patients per year, do we need a site in each major city in Canada? Do we need one in every tertiary hospital, right? And so that discussion happened. And so it was decided about, you know, maybe these regional centers. And so there was definitely planning. But then when they came out and it, you know, started with one indication, and then there was another indication, and so the number of patients that were actually being referred to treatment was higher. And then we had this fantastic thing happen where I think one of the plants in the US shut down, and so one of the products wasn't available, so all of the patients had to be migrated to the other, and hospitals had to be accredited to administer these products, right? So it was chaos. All of that to say that, I know, when am I going to stop talking, right? So all of that to say that I think some of the major disruption has happened in that we've now developed some systems and a little bit, maybe a sort of an outline / template for how we will implement similar technologies that require, tertiary or a combination of primary, tertiary, and follow-up care. So I think that some of that major disruption has happened. But my very first CAPT conference was in 1998, okay? I was 11. And I see a lot of people in this audience that are not old enough to use Botox. And I think that you are at this age where hearing where some of these challenges are, it's not just about the, understanding the number needed to treat and all the epi stuff that you're working on in your health services research courses, but it's some of this administration, implementation level questions that I think you guys are at a perfect point in your careers to start getting specialty in, because it's lacking. When I was in the drug plan, everything comes to the 10 people or 13 people across Canada that are the leaders of the drug plans, and we can't do them all, and we don't have enough people to help us do these things. So that's just my plea to encourage you and motivate you to find some of these spaces.
Thank you. And over to you, please.
Thanks. Trish, I thought you'd never stop talking. Hi, I'm Isra Awani from Biotech Canada. Thank you for your presentation. I just thought I would make a timely, yet still shameless plug for a poster that we have up where Biotech Canada and the CDA worked together on a joint project exactly on this topic. How do we assess and support system readiness for ATPs, identifying many of the points that have been raised today, which is around the importance of early engagement, the importance of identifying the receptor, and also the importance of really looking at equity considerations throughout. So yeah, I do invite you to come and chat with us about that upstairs later. Thanks.
Mm-hmm. Thank you. So system readiness, as we can see, there are different infrastructural requirements depending on what the innovation might be. And we heard, there's another question here. I'll ask my question anyway, and then we go turn it over to you. Don, this is for you. Do you think, when we talk about system readiness and the different components for complex therapies, advanced therapeutics, how might they extend to, how might the requirements for T-cell therapies extend to other therapeutics? And similarly, how are we learning from prior disruptions, such as those that we saw with stem cell therapies, like some of the adjustments, some of the reform that had to take place in terms of
I suspect we are. I suspect with CAR-Ts that they were thinking about things like, stem cell transplant and how they had to sort of get specialized resources for that. So it was probably an extension, but it depends on what the underlying issues are. And so, I would think that sometimes you can learn, but sometimes you can't. I mean, we're going to have, there's a whole, we're going to have some things that are complex that have entirely new issues, whether that be because of digital technology incorporated or what have you. And, we're going to have to deal with those things. So I suppose each technology probably brings some new twist, and we have to deal with it.
Mm-hmm. And I'm sure that your project will address some of these.
Well, I hope, but maybe not. More research is required. Is actually the conclusion of the project. Yeah.
Please.
Thank you, Tim, independent guy. New twists on technology. Don, if you go back to your line graph, one comment. I suspect that one of the offsets that these new technologies are going to bring is the reciprocal curve of progression to the next line of therapy, either delay in time or the necessity of it in its entirety. So I don't know if it's completely additive. So just one comment.
Well, yeah, I mean, a lot of these things came in later lines, like as most companies do. They hit the highest unmet need later lines first, and then they move up in lines. But yeah, point taken. You could have some offsets for sure. If you're going to earlier line, then maybe you've avoided a later line. Maybe not. I mean, this is a rough graph. It's not. We have no idea. This is like a projection. This isn't even. We have no idea actually what utilization really is of these. So, not that I know of. But point taken.
One implementation issue that sometimes goes unnoticed, I think Judy mentioned it, or alluded to it a little bit, the people actually delivering the care. One of the things we've noticed at the hospital level, particularly in Ontario, as we moved from OPUS, where funding letters were distributed through protocols within OPUS that were distributed universally to all the centers around Ontario. Now people have gone to EPIC and other systems. Every time a funding letter comes out, each center now has to build their own protocol. So it's a multiplication effect through all the centers versus the previous system. And the speed of which the new funding letters are coming out has changed drastically over the past 4 years, from roughly once a month, several years ago, to now several times a month, sometimes several times a week. And each of those protocols requires the same effort within the institution to build and to test and to implement. The patient populations keep getting smaller and smaller. So the frontline people are being drawn out of care just to build protocols for the innovations we're trying to deliver to patients. So we're creating another bottleneck that way. So I'm not sure if that's been looked at in the implementation studies, or if other companies are aware of that.
Did you want to respond?
So
nothing.
Take it as a comment,
Nothing that I
not
know
as a
of,
question.
yeah.
No, but it's a good bloody comment. I mean, they absolutely right. I mean, it reminds me of like any change management. I mean, we once, Alberta, for example, for a long time had the highest cost per capita care and the worst outcome. Well, not the worst outcomes, but like you were never getting more outcomes for the amount of money you were injecting into the system. And this came around the time of going from a highly decentralized, regionalized healthcare environment to a centralized one, which was not easy, right? It's never easy to change the governance structure. There's a lot of inertia and resistance. And, one of the things working with Phil Jacobs and others at the Institute of Health Economics, we thought is there's probably like a lot of hidden change management costs. Every time you have to like change things, exactly what you're saying. Every time you have to change things, you have to bring people out, they have to work on things on the side of their desks, and there's all this inertia and then things can't happen as quickly, and that all costs, and so you can't see where the money's going, but the money is going into actually reforming the system itself, into turning the ship, and I can imagine what you're talking about is they're going to they become hidden costs in a way, like we're more and more people running around, but to what effect? And it speaks to governance too, doesn't it? I think if every center is having to do the same thing, are there efficiencies to be gained with a different type of structure?
Yeah, centralized would be probably helpful.
Yeah, and the decentralized model made lots of sense years and years ago, I suppose, when you wanted to make sure, like, you're thinking about equity, you're thinking about localized, being able to tailor to local needs and whatever. But now we live in a day and age where we can, through informatics and what have you, we can centralize a lot easier. And so, like, what's stopping us? And I mean, I know Ontario's moving that direction, but it's like Alberta years ago. Like, they're Ontario Health, but that's still going to take a long time to get to a really fully centralized system, I imagine.
Thank you.
Thanks for your comment.
Thank you. Cynthia, to get your perspective on this, so we heard about the unique requirements. They're oftentimes unknown, and you mentioned that as well, and that you're, as a therapeutic developer, you're prepared, you do your homework obviously in advance, but do you think this will always be a challenge, or is there a way to identify priorities and challenges that can be sort of built on for new therapeutics as they continue to evolve?
Well, I think we need to develop a mechanism by which, we know how to operate when we come with a new mechanism, for patients. Again, starting early is really important. And I think, it's a good debate as to, when is the right time to start this, because the changes take time, right? And nothing happens quickly. And starting too early is probably not good either, because we need the hospitals need an incentive. There's a lot of change going on, and so why make these changes until you know for sure this is a therapy that's going to come and really be disruptive and really add value to patients? So finding that right time, and I think we're going to get better at it. I think, we mentioned earlier, we've made huge inroads with CAR-T, and now with bispecifics, there's a lot of learnings that we'll be able to apply to other new innovations that come. So that's the hope, is that we figure out what the formula needs to look like, and we apply it to new therapies when they come. And the learning to start early, to start talking to different stakeholders, to make sure that we work together to make this this implementation smoother and quicker for patients.
Okay. Thank you. And I think we only have 2 minutes left, so to conclude this discussion, maybe I'll start with Cynthia again. If based on these learnings and the experience that you've had, what is a key takeaway or maybe a key priority in this space to overcome some of the challenges, or what is the key priority?
So I would say identifying the issues early on, getting the right people at the table to help you figure out what are the challenges that we're going to have, and making sure it's a multi-stakeholder, multidisciplinary solution that we come up with that hopefully is scalable and sustainable. So to me, that's the key, is that this is a lot of us in this room need to be involved in this. It's not just one stakeholder on their own. We're not going to get there if one person tries to do it on their own or one group tries to do it on their own. And finally, I really think we need a champion for this. And maybe that'll come out of the work that we're doing to figure out who should lead this for us.
Thank you. And Dawn, same question to you, but based on your research perspective.
Well, I mean, I think we hear it all day, like, oh yeah, we need multi-stakeholder conversations. But I mean, to Tim's point, just recently, I mean, getting people away from their day jobs and then to chime in and think about a potential future, which Trish told us, doesn't always transpire. Maybe that becomes difficult. I'm finding true multi-stakeholder discussions, which are valuable, are becoming increasingly difficult as people, I suppose, are busy or what have you, or there seems to be sometimes more divisiveness. And so, yeah, it's important, definitely. And I totally agree. I find I think it can be difficult. And we do have healthcare systems that are working away. One of the things that I worry about is for example, Ontario is doing all kinds of reforms, but if you try to figure out what they're doing, they don't like to talk about it very much. Well, that's not very helpful to you're encouraging people to become researchers in this area. What are they going to research if nobody's telling them what's going on? So I think governments have an onus to be a little more transparent about the changes they're making and what they're thinking about. And we live also in the ethos in Canada is consultation, PMPRB consultation, which means, you write us a letter and maybe we'll read it, maybe we won't. What about exchange? What about deliberation? What about bringing people to the table and having a conversation? That seems to not happen so much, and I don't want to pick on the CDA, but, they also follow the leader. There's a lot of consultation that goes on. Consultation's a bit meaningless. So I know because I consult with my children all the time and I don't listen to them. So, no, I think we have to be not afraid to talk to each other, but that requires really good management itself. I mean, you can't just because companies like Pfizer, they got a ton of dough. They can step all over you if you don't watch it. So you have to have a well-managed conversation.
A ton of dough.
A ton of dough, yes. Well, we can get there anyway. So you have to make sure we do these things properly. And so good deliberative processes are really important. Really good exchange is really important. We shouldn't be afraid of it. We should embrace it, but we need to do it well.
Very good. Thank you very much. So deliberative process,
Compared to healthcare
collaboration. Thank you very much, Cynthia and Dawn, for this very informative discussion, and thank you very much to the audience for your active engagement.
A ton of it.
Fine, a ton.
Wow. Let's look at your quarterly revenues, Pfizer.
All right, everyone. Last session. I think there's a... Okay, if I can have your attention. Most important session of the day, and I'm not kidding. So we had, well, there's 4 presenters. If they can make their way up and join me here, that'd be great. So we had 35 abstracts and posters this year, which I think is amazing. I'll have to be honest, as the incoming president, I'm hoping next year we'll have even more. So just putting that plug out there, but submit abstracts. Of those, 22 of the abstracts and posters you see were submitted by students. So all of the abstracts were ranked by the board, and what we did was we selected the top 4 ranked abstracts, and these are our presentations here today. So what I'll do, each one is going to present for about 10 minutes, and then there'll be about 5 minutes, maybe a little less, for questions. I don't want those all to come from me, okay? So please come up to the microphones. We have to be a little quick about it, so you can even line up before they are maybe finish their presentations. And as students, I think they're going to welcome questions. It's a good opportunity to grow, right? So let's all help them out and give them some good questions today, all right? So first up, hopefully I say the names right. Apologies in advance if I don't, because I didn't get to meet you ahead of time. So Mira Maximos.
You said it right, so thank you. Again, my name is Mira. I'm actually a funny one. I'm an early career scholar pharmacist, so that's a fancy way of saying clinician scientist baby one, but also a PhD candidate at the University of Waterloo. So I'm going to talk at the beginning with my PhD candidate hat on, and then at the end with the clinician hat on. Little thingy, little thingy, thank you. Okay. So we're going to be talking about part of my PhD project, looking at risk stratification and understanding penicillin allergy labeling in the population, but with a sex and gender perspective, and that's really important, and I'll get into that in just a sec. Button work. Okay, so I tried to put in animations. This is the only one that we're getting. So this is how we're going to be going through our presentation. Just little points that I'll put this back up. So we're going to start with a bit of background about why this work is important. We'll go through the methods that we carried out, results, and actually our protocol has been published, yay! So I can share that with you if you want, and then open up to questions. If there are burning questions during the presentation, feel free to interrupt me. It's okay if we don't finish, and that's fine by me. So let's get started. So one thing is, if you think about yourself or anyone you know, at least 10% of people in the population have this quote-unquote penicillin allergy label. So they say they're allergic to penicillin. However, interestingly enough, using various means from historically what we used as a gold standard being penicillin skin testing to now using oral challenge or algorithms and questionnaires that help us directly delabel people without intervention, we can get rid of that allergy in at least 90 to 95% of people. My area of practice is infectious disease, and that makes me super happy because when someone comes in with something like necrotizing fasciitis, please don't Google it. I'd prefer to use CAPT-ACTP instead of something that would be second line that wouldn't necessarily be as effective. So using beta-lactams is something that we use in so many contexts, quite effective, relatively safe agents, and I would like to be able to get rid of those allergy labels personally. Interestingly enough, historically, female people tend to report higher rates of these penicillin allergy labels, but we're not sure if this is actually a sex-linked difference. So is this biological hormones associated with steroid hormones that lead to maybe higher risk of inflammatory processes, or is this more of a gender difference in the sense that women are more likely to go seek care and therefore might have a higher rate of reporting? So in a sense, is it like gender roles, institutionalized gender, or is this sex or a combination? So we're trying to kind of dissect that, but first understand what are we seeing in the literature. So why is this important? I could go on and on and on about this, but biologic sex does influence pharmacokinetics, dynamics, and therefore drug response. There have been various different studies, various different things that we've seen in the literature. I was actually involved with Center of Excellence for Women's Health and Health Canada on looking at the whole entire drug life cycle. And we actually were able to show that there is a lack of evidence on how that can actually impact care. We also know that female sex is associated with higher adverse event reporting. Caveat, when I say sex, studies sometimes mean gender. We don't always know. I'll leave it there. And hypersensitivity reactions. So we see, for example, like more asthma propensity in females versus males in certain populations. And gender roles, the stigma associated with presenting as a certain gender, and I'm not just saying binary as in male-female, I'm saying across the continuum, and that actually leads to potential discrimination. And that can lead to implicit biases in how we deliver health care, and the concept of institutionalized gender affects how we as a healthcare community treat patients. Implicitly, that can create bias, and that bias affects how people are able to get the appropriate diagnosis and even sometimes prognosis. I don't know where the pushy thing is, but so the aim of our systematic review and meta-analysis was first to identify, we've already done a lot of identifying, there are already systematic reviews out there on this, but not specifically in the population I'm going to talk about, and assess the quality of and synthesize the evidence out there that reports on effectiveness and safety of delabeling interventions. So delabeling is get rid of the allergy entirely. We looked at sex and gender where it was reported and tried to stratify it. I think it didn't go great with the stratification, which tells me there's a lot to do. So my job is pretty secure for now. We looked at adult patients, specifically with low-risk allergies. And what I mean by low-risk allergies is there's something called a PENFAST score that had a talk with Jason Trubiano, who is a lead author on it. He's pretty awesome. And one of the coolest things is there is a score out there, and at least 60% of people with this penicillin allergy label can actually be considered low risk. So it's a pretty big proportion of the population. We looked at just direct delabeling or oral challenge. I chose those because they're things we could do now. They're things we could do in either a clinic or hospital setting relatively safely. We looked at any comparator, so we hoped, the gold standard was skin testing or other interventions or no intervention. And obviously the outcome was successful delabeling. Sorry, I tend to blab, so I'm going to talk faster. With respect to methods, we co-designed this intervention with patients, with healthcare leaders and leadership personnel within the institutions, like within hospital settings. The intent was to understand what every group would be interested in gathering. We included all types of study designs that were interventional in nature, quasi-experimental is in this case interventional, Multiple different databases were included, and we included something called the PROGRESS acronym for the understanding of equity, or to help us gather some information about what possible factors can impact the gender aspect. And we used the effective public health practice tool for quality assessment, and that's again because many of our studies were actually quasi-experimental. We used various means of synthesizing the data. So if we had a control arm, we were able to report relative risk and risk difference. For quasi-experimental studies, you'll see that the graphs are proportion-based. We looked at heterogeneity. We still reported it for the proportion ones if the heterogeneity was still high, because there's actually less evidence on not reporting the I-squared statistic in studies that were just proportion-based. And we did some predefined subgroup analyses by the clinician type, the care center that it was done in. And some of the reason we did that was to understand what were some of the factors that we could look at to help us bolster our evidence on who to delabel in. Okay, so I'm going to speed into results. Sorry. Okay, so this is my PRISMA diagram, all the studies that we screened. 28 were included, only 2 were RCTs. One of them was really well designed. The other one I had a little bit of trouble following the population, so I would say more internal validity questions for me. 26 studies were quasi-experimental. The majority of them did not have a control arm. They actually didn't any have a true control arm. 2 included only direct delabeling, so some sort of algorithm to get rid of it. The allergy label, I mean. 16 only oral challenge, and 8 included both. Okay. So overall, mean age of the population was 56. 61% of the population was female. 5 studies actually just included information about demographics. 10 reported ethnicity, and the majority were Caucasian. And here's another soapbox. Allergies, like a rash, looks different on dark skin versus lighter skin. So that's another thing that we have to work on. This is the quality assessment that I won't get into too much detail, but as you can see, given the study designs, most of them were not considered of higher quality, which is okay, but to be aware of. One thing we also did was thematically analyze all the different allergy components that were included for direct label and oral challenge. As you can see here, I'm just going to say this is cleaner, but when you look at oral challenge, it was a lot more complicated. So how we categorize someone that would be low risk, but low risk and could be included for an oral challenge was a bit more complicated than direct labeling. Okay, so effectiveness of the intervention. Simply, in the RCTs that were done, it was just as effective as skin testing. I mean, that's no surprise, but it's good to see this. And the other thing is it's just as safe. And the interesting thing is you don't have a high false positive rate like you would with skin testing. So you know if you give someone the drug and they tolerate it, they tolerate it. In the direct delabeling arm, here we had about 27% of the participants could be delabeled just by using an algorithm, which is actually huge. I can just sit with you in a clinic, go through a proper questionnaire, and directly remove the allergy. 1 minute, okay. All right, in the oral challenge population, 90% of the people could have the allergy label removed, but there was a lot of heterogeneity within the studies. This is the part I want to just spend like a sec on. So we had 5 studies that sex disaggregated the outcomes. In those studies, interestingly enough, when you looked at the subpopulations, those that were in the inpatient setting and older, we tended to delabel males more. Less females were delabeled, but in the outpatient setting and younger populations, there was no sex difference in the delabeling, which makes me wonder if this is more of a gender difference, if we think like, are we thinking females are more frail, or what is exactly happening? And that's something we're gonna look into. With respect to the process factors, we found that they interchange race and ethnicity consistently. Nothing was described on lived gender, gender of the individual's gender identity. None of the studies were conducted in middle or lower income countries, which is actually another problem, and I'm being told to end. Last thing that I'm gonna say. Okay, so safety of oral challenge. No one had a severe adverse drug reaction. No one reported anaphylaxis. All reactions were managed relatively in-house, and nobody had any complications. And if you even think 4% of those that experienced anything, it was more like if they had a rash or they had upset stomach, that was still included as a reaction. So my takeaway is we can do this, and we can do this in a clinical setting that doesn't require intensive management, and we can follow up with patients in about a week to see, did they have any delayed hypersensitivities? But we need better data to understand if this is sex or gender or a combination that's leading to that sex difference we see at baseline. That's it, I'm gonna stop talking. Oh, these are my acknowledgements and the funding agencies, and that's it. On to questions. I had to, that was my favorite slide. Okay.
Simon Lafrance from Université Laval. Thanks for your presentations. In the meta-analysis you report there was very high heterogeneity, also like studies were from like high risk of bias for most of them. So I was a bit surprised with the conclusion that you mentioned that direct labeling are effective. Do you think we should maybe have more nuance in the conclusions, and if you have done like a great analysis of certainty, that could maybe like be something to add? I don't know if you have a point to say about that.
Yeah, okay, so when you think about heterogeneity, the reason the studies were considered heterogeneous was because the populations were quite different. The issue is proportion meta-analyses don't actually have the same degree of evidence to say that an I-squared that's 75% or higher is actually useful. So when we look at that kind of meta-analysis, you're looking at it clinically. So if I have a patient who is low risk of having a true reaction, and I'm seeing it with respect to the side effect reporting, I would prefer that the patient get the most appropriate drug. And if I can do that safely, I would trust the proportion meta-analyses. But also in the 2 RCTs that did compare it to skin testing, they also showed the same thing, similar safety and similar efficacy. The other thing is, the only other method we have right now to really appropriately delabel people is skin testing. So if you've ever had to do that, like it takes months to see an immunologist or allergist. By the time you get there, if you have an acute infection, we cannot actually deal with that at that moment. So you're getting second-line therapy, which means you have higher rates of resistance, higher rates of treatment failure. So it's a risk-benefit approach. Should this be done in an unmonitored setting? Absolutely not. But it can be done in a clinical setting that has people who have expertise in managing reactions and then know how to deal with it like a week later if there is a delayed hypersensitivity, which shouldn't happen because that type 3 hypersensitivity population shouldn't be included in here. But thank you for the question.
What types of system or drug utilization impacts are you projecting should the direct delabel oral challenge be implemented broadly?
That's a good question. I think that we're going to have less of a bottlenecking effect for agents that maybe we should be reserving for more resistant pathogens, and potentially lower rates of adverse drug reactions when we're using the beta-lactams. I'm not entirely sure it will have a huge difference because we're using those agents anyways, but I just think that the impact will more be on like less risk of treatment failure and less risk of having the side effects associated with using things like vancomycin or fluoroquinolones. It's a good question though. No problem. Thank you.
Thanks very much, Mayor. So next up we have Rose Gagnon.
Hi everyone, so nice to see such a crowded room. It's my pleasure today to be here to present part of my PhD results. So my name is Rose Gagnon, I'm a PhD candidate at Université Laval. So as you can hear, I have a small accent. So if at some point you do not understand something, please come to the mic and ask me to repeat, it'll be a pleasure. Okay, so this is my awesome research team. If you look closely enough, you can see that someone is sitting in the room right now. So if you have more questions, you can go and ask this person if I fail to answer correctly. So all members of the research team declare that they have no competing interests. So this is the layout of my presentation. I'll go quickly over why the costs of musculoskeletal disorders are important. Then I'll talk a bit about our methods, and then how much does they really cost in the emergency department, and then why is this helpful to know more about these costs. Okay, So musculoskeletal disorders, this is a bit of a mouthful, so I'll say MSKDs from now on. So MSKDs are very prevalent. You might have heard of people telling you that they have knee pain, back pain, shoulder pain. And as I said, these disorders are responsible for oftentimes pain, but also lots of limitations in mobility, dexterity, and function. And you might not know that, but currently, over 1.7 billion people globally are affected by MSKDs. So some people might say that MSKDs are not that serious, but in fact, some of them quite are, and they can even evolve into persistent pain or chronic pain. So it's not so surprising that they are responsible for more than $8.7 billion per year in healthcare costs, 6.7 billion in direct costs, and 2 billion in indirect costs. They represent up to 6.7% of all Canadian healthcare costs, and those numbers are likely to be underestimated. And most surprisingly, they are one of the 6 most costly health conditions in Canada. So most of these people at some point will seek care for their musculoskeletal disorder. And the emergency department, or ED, is sometimes the main point of entry and preferred resource when primary care services are not available. Some factors contribute to this situation, such as the lack of affiliation with primary care and the inability to see a doctor in less than 2 days. So because of that, and because of the overcrowding that we see currently in emergency departments, it is said that up to 25% of all ED visits are currently made for MSKDs. So the objective of our project was to measure the costs of the care processes administered to patients presenting with a minor MSKD in a Canadian academic ED. So our approach, we realized a cost study based on randomized clinical trial data, and 2 interventions were compared in this RCT, so management in the emergency department by a physician alone or by a physiotherapist and a physician. So 78 participants were recruited in one of the ED of the CHU de Québec Université Laval, which is a hospital-based university center in Quebec City. And to be included, participants had to present a disorder or pain of musculoskeletal origin, to be aged between 18 and 80 years old, to present a P3, P4, or P5 triage categories, so triage categories that are less urgent, that are not emergent or urgent, and a capacity to understand French and respond to oral or written questionnaires. So the costing method we used is time-driven activity-based costing, or TDABC. So it's a costing method where time invested with a patient determines care costs. So it can be broken down into 4 steps. So the first step is to map the care pathway of interest. So the care pathway we were interested in was the management that MSKD patients receive in the emergency department. And then the second step is to estimate the time required for each care process in the care pathway. And then we calculate the unit cost for each resource, such as nurse, emergency physician, physiotherapist, the consumables, such as bed sheets or gloves, and then the overhead. The overhead are the costs that the emergency department still needs in order to function properly, but are not usually thought of when we think about emergency departments, such as security, electricity, or even the cleaning fees. And then the last step is to calculate the costs incurred during the patient's care pathway. So, our results. During this project, we costed 165 different care processes in the emergency department, and costs varied considerably by type and profession. And what I mean by cost types is that we had costs related to human resources, equipment, consumables, imaging, to overhead, which I discussed earlier, splinting and walking aids, such as walkers, crutches, and canes, care processes as a whole, and the mean cost of the ED visit. So speaking of the mean cost of the ED visit, you can see here, please keep in mind that all costs that will be presented are in 2019 Canadian dollars. So for all patients, I don't have no laser. Okay, so for all patients, at the bottom right, you can see that the mean ED visit cost was $268. And then we separated the ambulatory patients of the stretcher patients. So ambulatory patients are patients that come on foot and that are sitting in the waiting room in the emergency department. And the stretcher patients are patients that are lying down on a stretcher during their ED stay. So for ambulatory patients, the mean ED visit cost was $148. And then for stretcher patients, it was way higher at $562. So as for ED assessment, we have numerous costs here. So the dark blue is for ambulatory patients, and the gray is for stretcher patients. So for the physician assessment, it costs between $47 to $60 per patient. This is always per patient. And for the physiotherapist assessment, it costs between $80 to $120. You have to keep in mind, though, that the physiotherapist, their cost per minute was lower, but since their assessment time was longer, then it's the reason why it costs way more than the physician's assessment. And then we have the reassessment as well, and then the check-in. The check-in comprised care processes such as ED pre-triage and then registration in the ED. So depending on the way people came in the emergency department, depending if they came in by ambulance, on their feet, or if they needed a collective prescription for an X-ray, for example, then it costed between $12.55 to more than $50 per patient. As for human resources, so the main cost driver was the physician per minute cost at approximately $7 per minute, and then we dropped down to approximately $1 per minute for the physiotherapist and the nurse, and then it all went down after that for the imaging technician, social worker, and so on. As for the equipment, the main cost driver was the CT scan cost. So for each minute of use, it was $1. It's worse than that for MRI, but data is not shown here. And then for the ultrasound cost and the X-ray cost, the cost was negligible. As for consumables, so remember like bed sheets, gloves, it was per department, and the department which had the most consumables costs were imaging department, and it's kind of normal because they need to transfer lots of patients. They have to prepare the imaging machine. They also have to switch, and they see lots of patients during a given day. After that, the emergency department, and then it became negligible after that. As for overhead, it's also per department, and this depends on the square footage of the department. The bigger the department, the more costs are associated with electricity and cleaning, for example. So you can see here that they were all about the same, except for nursing assistants and imaging. So walking aids, walker, ankle splint, and then, so these costs are for education and then giving the walking aid. Okay, so as for a discussion, we observed a high variability in costs. This was mainly due to the fact that we didn't standardize the care pathways, and there was a great variability between individuals because we recruited a diversity of MSKDs. Ambulatory versus stretcher patients, we included both of them, and you saw that the costs were quite different between the two kinds of patients. But they use the same resources, but the difference between the two kinds of patients is that the duration of care processes was different. And for stretcher patients, it takes a lot more time because you have to manage the stretcher, and then you have to reinstall the patients in their stretcher when they've done their exam. So this project has some limits. So first of all, we did have to manage the process duration. For things, we have to standardize the process duration in order to keep things manageable, and we also standardize the severity of MSKDs. It would have been interesting to, for example, for a given exam duration, to stratify according to MSKD severity. This project also has some strengths. So the costing method was adapted by healthcare professionals with a good knowledge of the condition of interest, and it also has good external validity because of the great variability of individuals that we included. So as for perspectives, This project gave us a better understanding of the overall cost of managing MSKDs in the emergency department, of the care pathways, and the processes used. But we have to ask ourselves, every intervention received was included, but do every intervention utilized give value to the patient when they come to the emergency department? And then it is high time that we consider effectiveness beyond costs and overall efficiency of the interventions that we implement in emergency departments. Thank you.
Hello, hi. Thank you for the nice presentation. I have a question regarding since you're working with musculoskeletal system, so it is well known that the severity of the musculoskeletal conditions worsen during the winter, and the prevalence and incidence increases it's quite the opposite. So I didn't know if you showed any duration when you did when you recruited the participant. So do you think this seasonality can bring a bias in your study, or how would you address it?
Thank you for the question. It's an interesting question, actually. We recruited participants during the fall and the winter. So we did have patients that came in the emergency department because they were shoveling snow, for example. And that's a time of the year that we see a lot of patients. Before deciding at what time we would recruit patients, we did look at the stats, the emergency department statistics, to see where it would be the best time of the year to recruit participants. And actually, it doesn't vary that much during the year, because the reasons for going to the ED for MSKD are different throughout the year, but we see that almost the same number of people will go, but for different reasons. And it's strategic to have other health professionals during the fall and winter, because usually those are very crowded times in the emergency department. So if some people can exit the emergency department faster, then it gives the staff more time to care for the other people that are present that do not have MSKDs. Thank you.
Thanks very much, Rose. Next up is Tyler Schneider.
Okay, hi everyone. My name is Tyler Schneider. I'm a pharmacist and I'm a Master's of eHealth student at McMaster. And I'll be presenting some of my master's thesis work, preparing electronic medical record data for pharmacoepidemiologic research, essential data validation. So just a bit of background, electronic medical records, or EMRs, they have a lot more data useful for research than administrative data would have. And it has things like demographics, medication administrations, as opposed to just medication orders or dispensations, vitals, labs, social situation, risk behaviors for patients, et cetera. And so EPIC, which is an EMR, has really exploded in popularity in Canada. It's the second most common EMR, and it was only introduced in Canada in 2017. St. Joseph's Healthcare Hamilton, or St. Joe's, was the first Canadian academic adult hospital to install EPIC. And EPIC's also the leading EMR vendor in the United States and very popular around the world as well. EPIC is a highly structured EMR. It has over 18,000 data tables, but there's really no guide or clear roadmap as to see which tables and fields contain which data. And EPIC has their links and data tables and fields as proprietary information. And so EMR data is not collected or stored primarily for research, primarily for patient care. So to actually use it for research and have high quality research and analysis, you need to have high quality, accessible, and organized data. We go back to the classic saying, garbage in, garbage out. And so we need to validate the data for quality and accuracy. And so few studies really assess the validity of EMR data. There was the Canadian Primary Care Sentinel Surveillance Network, or CIPSEN. They have a primary care database. They validated some chronic conditions. Hospital EMRs, there's been some validation for completeness of the problem list. There's been some validation for cancer treatment and diagnostic, or cancer treatment and progression, and some diagnostic markers. And for EPIC specifically, there's been some algorithms to identify diagnoses. There's been some work using lab tests to validate diagnoses as well. And so we did a bit of an international scan of research-intensive institutions, but we didn't really find any readily usable data validation metrics. So like SickKids, Stanford, and Harvard, they all have research repositories with their EMR data, but nothing really that could help validate the data of any given institution's EMR. And so the objectives of our study here was to create an entity relationship diagram for the EPIC EMR for some key general research themes. So we were going to use St. Joseph's EPIC dovetail data. It's about 6 years worth of data. And we were going to look at things like demographics, providers, exposures, outcomes, comorbidities, timing, decision support, like medication alerts. And then our other objective was to validate our EMR data for these key themes relevant to pharmacoepidemiologic research, and kind of applying this to an ongoing project of whether QT prolonging medications are or are not associated with major adverse cardiac events. And so the aim of that project is to develop a clinical prediction rule on who will have MACE if they're taking QTP medication. And so we had a team of clinical pharmacologists, chief medical information officer, medicine specialists, pharmacists, research data analysts, data scientists, informatics specialists, methodologists. We extracted our data from the EPIC Clarity database, which is a reporting database that's updated daily, where you use SQL queries to kind of extract the data. We found relevant data tables and fields through the EPIC Data Handbook, which is basically a website where you can search for whatever kind of data tables and fields you're looking for, and it'll kind of give you stuff that's relevant, potentially. But it was a lot of trial and error and iterative improvement just to actually find tables that we could use and kind of matched what our needs were. And then we validated data for completeness and correctness. We did manual validation by manually going into charts and randomly selecting patients and seeing if the data we had lined up. And then we also did computational validation, so we compared our EPIC dovetail data to the CHI-HI-DAD data, which is the discharge abstracts database, or comparing EPIC dovetail to Slicer Dicer, which is an EPIC data exploration tool. And so we had all patients that were aged 18 years or older admitted to St. Joe's from December 2nd, 2017 to March 24th, 2023. We had CHI-HI-DAD data available as like a gold standard for diagnoses, and then also just as a secondary data set for comparison. And for validation statistics, we used correctness, which was essentially percent agreement, and then diagnostic accuracy, so positive predictive value, negative predictive value, sensitivity, and specificity. And so for results, this is the entity relationship diagram that we came up with. So you'd think that when you go into like an EMR and you go into a chart and you see all this data, you can kind of see like what fields, like maybe the age or date of birth or different diagnoses are in. So you would just be able to see it. It's in the same place in every chart, so it'd be pretty easy to pull it. But it's actually kind of like searching for a needle in a haystack to know which actual tables have like complete data and correct data. So this was kind of a diagram made of the 31 tables that we used for this project, and that's out of the 20,764 data tables that are actually active in EPIC Dovetail. So this, each box represents a table. We couldn't use the actual like table names and field names and links just because it's proprietary information from EPIC, but these are just kind of generic names that basically describe what we were getting from these tables. But yeah, these 31 tables were for medications and medications administrations, patient flow in hospital, so admission, discharge, transfer, demographic information, diagnoses and comorbidities, other variables like labs, electrocardiograms, and then alerts, so mostly focusing on medication-related alerts. And so just some examples of some of the validation we did. For demographics, we had about 70,000 unique patients in EPIC Dovetail, and we compared that to Slicer Dicer, which we had over 99% agreement, only about a difference of 100. And then we validated age at admission to the CHI-HI-DAD data for over 9,000 patients, which had 100% agreement. We also manually validated some sex and gender identity. So 131 patient charts we looked at, and we had 100% agreement. Something interesting to note is that there was a sex listed for all patients, but for gender identity, it was only about 4% of patients that actually had a gender identity listed. For exposures, this was to medications, so we looked at ATC code and generic medication name. We had to use both just because one or the other actually had quite a few missing entries. But if you combine them, when we looked at 335 charts manually for known QTP medications, we had diagnostic accuracy at 95% or above. And we had 50,000 patients who took a known QTP medication, which is just a medication at higher risk or known to actually prolong the QT interval. And then for outcomes, we had our major adverse cardiac events, or MACE. So that included death, ventricular arrhythmia, which included torsade de pointes, non-fatal cardiac arrest, and syncope. We manually validated 335 CAI charts. We didn't actually end up reporting what the dovetail values were, just because a lot of the outcomes occurred pre-admission and were actually rather incomplete. So we had to validate CAI instead, which validated pretty well. Diagnostic accuracy was mostly above 90%, except specificity was 81%, largely due to syncope not validating quite well. And then a few more examples. Lab values, we looked at potassium, magnesium, calcium, troponin, manually validated 736 lab results for 50 patients, which were 100% agreement. For electrocardiograms, we looked at the QTC interval and cardiac rhythm. We manually validated 53 EKGs for 38 patients, which had 100% agreement. For comorbidities, we looked at diabetes, hypertension, and heart failure and compared it to the CAI data. Diabetes had about 93% agreement, hypertension 81%, and heart failure 70%. For timing or time stamping, we looked at the date of admission for CAI patients in Dovetail, and it was just for over 10,000 admissions. We had over 99% agreement for the date of admission. And then lastly, we had medication safety alerts. So we found 850,672 medication-related alerts were actually shown to providers in 2023, and 98% of those were overridden. If you include alerts that were filtered, because certain providers see certain severity alerts where physicians see like only the highest severity and pharmacists see moderate and high severity, there was actually over 2 million alerts in 2023. And so the lack of an official entity relationship diagram is quite inefficient. It wastes a lot of time and potentially creates errors. There's other studies, like I mentioned, that use lab results and whatnot to look at diagnoses. So if we could have kind of had a starting point by looking at what tables they used when pulling it from Epic, it would have saved us some time. A very small percentage of data tables are actually needed for research. Data from CAI will actually be used for some of our fields, like MACE outcomes, where the Dovetail data validated quite poorly, and that's largely because diagnoses are not stored discretely in Epic unless they're added to a field like the medical history or problem list. So natural language processing could help parse that information from clinician notes. And then common data models such as OMOP or I2B2 are required for collaborative research across different EMRs to standardize the data that's being extracted. Epic has its own Cosmos network that they cited recently as having 274 million patients in it, and that's really helpful for rare disease and whatnot. Oh, and that's actually the end. I didn't put a thank you slide, but thanks to my co-investigators, and thanks to everybody for listening.
Thank you very much. I was very interested in your presentation. From what you presented, I believe, and you can correct me, that you looked at the medications and you looked at the outcome of MACE, but you haven't yet combined to see if the medications predict the outcome.
That's correct, yeah. This was kind of validating the data, and that would be the next step.
Perfect. My question to you is when you go to do that next validation step, are you just going to sort of look at medications and the outcome, or since you have collected such like a lovely data set with electrolytes, potassium, sex and gender, will you include that in your predictive model, or will you just sort of leave it to drugs and outcome? I'm curious.
Yeah, all the fields that kind of we reported on were supposed to go in that model as well. So it would be, yeah, do the drugs affect it, but looking at other confounders like electrolytes, even previous cardiac comorbidities, stuff like that, presence in critical care, would all be used to predict to see if the QT drugs actually lead to the MACE events.
Excellent, thank you.
We got time for 2 questions. Very intriguing. Actually, 3 questions. First is if you can clarify, what is the definition of override? So 98% of the drug warnings were override?
Yeah, so that would be that a clinician saw the alert and said, I'm going to continue with prescribing or verifying the order for this drug, despite this alert. So basically they see the alert and they're kind of overriding it to say, yeah, that I'm okay with it or not relevant or the benefit outweighs the risk, so I'm going to ignore that alert and continue with the original plan.
Interesting. Wow. So I'm wondering if the cost benefit of that alert system, it seems to be pumping out way too much stuff that's not actionable. So it's chewing up people's time even doing the override. So that seems excessive. Gosh, what was the other question I was going to ask? I'll get you at the poster session. Okay.
Thank you.
Thank you, Tyler. So last definitely not least, we have Arani Santareswaran. Yeah.
That was better than I expected. So. All right, last presentation. Thanks everyone for sticking around. So I'm a PhD candidate at the University of Toronto, and I'll be sharing some of my work today. Okay, so just by a show of hands, how many of you have experienced a drug shortage? Okay, seems like we have a lucky bunch around, but about 1 in 4 Canadians have experienced a drug shortage just within the last 3 years. And as of the first quarter of 2024 in the US, there was a record high of 323 drug shortages. And this was the highest since 2001. So we know that shortages prevent patients from accessing medications that they need. And this is then associated with adverse events, increased medication errors, non-adherence, inferior treatment, hospitalization, and in some severe cases, even mortality. And shortages also burden the healthcare system through prolonged recovery times, delayed treatment, and increased recovery costs. And beyond that, it also strains physicians and pharmacists since they need to source appropriate drug alternatives in a timely manner. Pharmacists report spending on average 10 hours a week just for managing shortages alone. So what are we doing to prevent shortages? There are some policies being considered, such as stockpiling, buffer stock, and exceptional importation. But with the sheer amount of drugs that face shortages, we can't possibly apply a policy measure to every single drug that's going to go into shortage. If we stockpile every medication, not only do we have the physical space for that, but that'll also cause Canada to go bankrupt. So the important question is, which drugs should we focus on when we think about policy implementation? So currently, with the aim of prioritizing these medicines, there are some essential medicines lists out there. However, these focus solely on clinical importance of a drug. And clinical importance will vary across different healthcare specialties and healthcare settings. If we ask an oncologist what they think is an important medication, we're going to get a list of chemotherapy agents. So clinical importance isn't something that's concrete enough to base policy implementation off of. But an equally important part of the equation is supply chain risk. And this includes factors such as the number of manufacturers, ingredients, and formulations. So anything that complicates the manufacturing or distribution process that can lead to a supply chain issue downstream. However, supply chain risk has not yet been considered when creating these essential medicines lists. And we think it's important to determine these supply chain factors that are associated with drug shortages. So our solution was to create a predictive model that can score supply chain risk of facing a significant shortage for all Canadian drugs. And then we can use this to guide policy implementation. So our objectives were to, 1, determine how many reported Canadian supply chain events lead to a meaningful decrease in drug supply. And we defined this as a 33% decrease. Second, we wanted to discover drug characteristics that are associated with these decreases. And then using those drug characteristics, we can create a predictive model that can ascertain shortage risk. So our main data source was IQVIA MIDAS, which carries monthly wholesale purchasing, sales, and manufacturing data from 2017 to 2021. For shortage and discontinuation reports, we use the Drug Shortages Canada website starting in March 2017, and this is when reporting became mandated. And for drug covariate information, we use the Health Canada Drug Product Database for information such as drug schedule, age, the number of DINs, and number of APIs. We also use some other sources like the ICS drug list as a predictor for public plan coverage, the WHO essential medicines list, tier 3 status, and some manual flags like brand versus generic and therapeutic equivalents. And across these data sources, we defined a drug as having a unique ingredient and formulation. So to go into the conceptual framework that gives rise to our exposure and outcome, in the drug supply chain, there are protective shields that are built in. And this includes available policy measures that can help prevent shortages, such as importation, extending expiration dates, using up stockpiles, opening up production lines, etc. So when a manufacturer reports for a potential drug shortage, these built-in shields can prevent that potential shortage from becoming an actual drug shortage. However, in some scenarios, there can be a supply chain failure or a hole in these shields that causes that potential shortage to become an actual drug shortage. So here we want to emphasize that a supply chain issue report doesn't necessitate that there's going to be an actual drug shortage where we see a decrease in the available supply and patients are unable to access their medications. So given that, our exposure was a supply chain issue report, and our outcome was a 33% decrease in the available supply 6 months following the report. So we conducted a matched cohort study, taking drugs with a supply chain report and drugs without a supply chain report, and matching them using exposure density sampling. We then flagged observations that had the outcome within 6 months. Then we ran a logistic regression model to compare the odds of experiencing the outcome for drugs with versus without a report. Then using the predicted probabilities, we scored the risk of the individual drugs in our cohort. So our findings actually suggested that most supply chain events don't actually face significant drug shortages. Only about 11% of reports have a meaningful 33% decrease associated with them, and about 5% have a severe 66% decrease. So that's about 1 in 10 reports facing a 33% decrease, and 1 in 20 reports with a 66% decrease. We also looked at factors that were most predictive of a shortage. So drugs that have sales then less than $100,000, anti-infective medications, and having a unit price greater than $100 were predictive of having a shortage. Factors that were most protective against a shortage were rectal formulations, having ODB coverage for 50 to 99% of DINs, and then having 5 to 9 manufacturers for that drug form. So here's a histogram of the probability of shortage. So the probability that a potential report becomes an actual drug shortage. And the median probability was 6.25%. So that's 6.25% that a report leads to an actual shortage where patients potentially may not access their medication. And about 70% of drugs have a less than 10% chance of facing a significant shortage, while only about 1% of drugs have a greater than 50% chance of facing a significant shortage. So this is a cohort that we should be focusing on when we think about policy implementation and safeguarding access. So the main takeaways are that only 1 in 10 supply chain reports led to a meaningful decrease. And this indicates that the built-in protective shields of the drug supply chain actually help prevent drug shortages. And now we know supply chain factors that are strongly associated with significant drug shortages. But only 1% of Canadian drugs have enough of those factors to give it a greater than 50% chance of facing a significant shortage. So again, this study looked at supply chain risk, and this is which drugs are likely to have a supply chain issue downstream. But the other side is clinical risk. So which drugs, when they're in shortage, will impact patient health. And both of these are very important factors that should be considered equally, which is why our overall work focuses on combining supply chain risk and clinical risk of a shortage to create a robust at-risk Canadian medicines list that can help guide shortage policy and safeguard Canadians' access to medicines. And with that, I would love to take any questions you have.
Hello.
Hi.
Thank you for the nice presentation. So I have a question about your predictive model. So you mentioned some covariates.
Mm-hmm.
So I was wondering I didn't see all the list of the covariates, but I was wondering, did you find any effect modifier while you were adjusting for those variables in your predictive model?
Sorry, what do you mean by effect modifier?
Like odds ratio changed a lot when you adjusted
yeah,
for
so
it?
those are the ones that I mentioned. Those are mostly predictive, and when I did model fit, I found that those were the ones that, were always high and really predictive of having a shortage.
Okay, thank you.
I have a very quick question. I might have just missed information, but when you said 1% of the medication having 50% chance of having a lack of supply, what is the time horizon for having that lack of supply? Is it over a year, over 10 years?
So it's 6 months following the report. So within 6 months, will there be a 33% decrease in supply?
All right, thanks for the great presentations, and you're our bright minds of tomorrow, so thanks for making us proud, and keep doing what you're doing. All right, yeah, we still have quite a few people here. Thanks for making it to the end of the day, end of day one. I bet your minds are buzzing based on all of the panels, all the presentations that we've heard today. And I'll take this opportunity to kind of end off with some of my reflections for the day, mainly in the form of questions. So based on the conversations we've heard today, right, how are we going to ensure our system and Canadian data infrastructure is going to be ready for specialized treatments moving into the future? How will we get innovative treatments to the patient in a timely manner? Is it going to be through outcomes-based agreements? How are we going to reduce that turnaround time related to molecular diagnostics? And of course, you've heard this so many times throughout the day, let's get better at initiating multi-stakeholder conversations earlier. But what exactly is that sweet spot for initiating those conversations? What's the role of policy, and how can we expedite policy evolution? And how are we collecting fit-for-purpose data within registries? I think these are some of the questions that we haven't answered today. We still have a long ways to go, but having these conversations, no matter how uncomfortable they are, is a great start. So thank you to all of our moderators and panelists for the day. Before I kind of close off, just a couple of housekeeping items. So for anyone who is participating in the student poster tour, please just congregate right in front of the podium here. Students, there's also a student social happening at 7 o'clock. So if you have any questions, feel free to find me at the reception, or Danielle, our student rep, just waving right there. And for the reception, so the career fair is still open, so feel free to stop by any of the booths. All of the posters are going to be, again, on the main floor of Mars. Just go up the escalators, keep going straight, you'll see it. And I believe everyone is entitled to 1 complimentary drink ticket, so enjoy that. And we'll see you all tomorrow for day 2 of the conference. Thank you. Sorry. I should have remembered this. We do have a vote for the audience choice of best poster. I did have it in my notes and I just forgot it. But please do vote. There's a QR code. Use the QR code, vote in the Google Forms, and the audience choice will win an award tomorrow. Thank you.